Hello. Hello. Good morning, everyone. So we will starting our academic session on day 2 with recorded live surgery for MISO. Dr. Shekhar Srivastav will be speaker. I am inviting Dr. Shekhar Srivastav, and I would also like to invite Dr. Ravi Kumar and Dr. P.S. Ashok sir on the podium as a moderator for the session. Thank you.
Good morning, everyone. And I can see that everyone is recovering from the gala night. So, so that's what happens when you have the first lecture after the gala night. But then the show must start on time. And we know that nothing excites us more than a surgery. You get charged when you start with charge your day with your surgery. So here also we are starting with a recorded live surgery done with MISO. So some facts about MISO. It is a indigenous robotic system for joint replacement system. It's a platform which they are uh, establishing for doing surgeries for knee replacement, hip surgeries, for spine, uh, and it is a active robotic system. That means it's an autonomous system. And these are few features of this system, and which is I think common with most of the systems, that they have a good pre-planning software, and then they have the robotic arm which helps in delivering the planning in a precise way. These are few technical specifications. So it has got three main parts: a main console, which contains the system monitor, where you can do the intraoperative planning. You can revise whatever plan you have. Then it has got the optical tracking system, the robotic arm, which contains the operating software, the cutting tool, and also for the irrigation, because it's a burr-based system, so heat is generated, so there has to be a continuous irrigation. And then you have a surgical planning software which you can do on the surgical planner. This is the workflow, and most of the robotic system have similar kind of workflow. The image-based system, then imageless, the workflow is slightly different. So here you have to first acquire the CT images following the protocols according to the manufacturer, and then on that CT-based system you do the preoperative planning. That gives you an idea about the sizing of the implant, and based on different kind of philosophies you can you can do your preoperative planning. Then second part is the patient preparation and the robot and instrument calibration and verification. Then the points are verified on the patient's knee. So patient to image registration is done, and it is matched with the preoperative planning. Gap check analysis is done at this time. So that's the time when you can do intraoperative modification in your plan. And once you are okay with your intraoperative planning, then you go for bone resection. And intraoperatively also you can keep checking whether your cuts are okay or not, and once you are satisfied with everything, then you can go for implant fixation. So that's the surgical process. It's a image based system, so you need to do the CT scan. This CT data is loaded, and then you set up the surgical plan. You then arrange and you get ready the tools, then you do the registration on the patient body, and then cutting and gap check and implant insertion. So this is a real life surgery. So I will take up a case. He's a 68-year-old gentleman, and on the right side knee replacement was done 7 years back. The philosophy which we thought of following in this case was adjusted mechanical, and the implant used was opulent. So that's the preoperative HK view, and you can see that the patient is having osteoarthritis grade 3-4. Now once the CT scan images are loaded, then you have to point out these images on the CT scan. So as it's a CT scan based system, so the accuracy is supposed to be better than image-free system. So you have to locate few points on the patient's anatomy, which will help in uh, deciding the alignment as well as sizing of the implants. So these are the few points which are taken on the femur, and then similarly there are 8 to 9 points which are taken on the tibia. Now once all these points are taken, then you can get the idea about the patient's preoperative alignment and the preoperative deformities. Now mind you, this is all static and it's being taken in lying down position. So that's how the tibial points are taken, and once all these points are taken, then the software will give you an initial idea about the sizing of the implant. Now, so you can get these images in 3D, in corneal cuts, in a sagittal cut, and also in axial cut. Now, you can try to match your implant according to the patient's anatomy in all these 3 planes. Once you have done that and once you are satisfied with that, then you get this kind of image, which gives you an idea about the final alignment of the limb after implantation. What will be the resection level at the level of femur, distal femur or posterior femur, similarly at the proximal tibia. So this is your preoperative planning, which you load onto your robotic arm. Then you come to the surgical part. So standard incision and standard exposure. Only thing is that because it is a CT scan based system, so you don't have to do anything to the bone before you have done the registration. That means you can't remove osteophytes before you have done the registration. Otherwise, there will be inaccuracies in your intraoperative resections. Now, just a bit of medial release up to the mid-corneal plane. Just the capsule is slightly released so that you can put the pins there. Otherwise, you don't need to. As it is, you have seen that in the preoperative images also, there was not much of the deformity. So once that is done, then because it's an autonomous system, so you have to put some pins for the tracker, and then you also have to put some pins to fix the robot to the body. Now these are the registration point on the patient's knee, and these points will be mapped and then it will be matched with the preoperative planning, so that both match each other. So around 40 points are taken, 40 points on the distal tibia and 40 points on the proximal femur. Once the software recognizes that your mapping is accurate, then you can go for gap balancing. Now again, gap balancing, that also is very much surgeon dependent. You must remember that it's always a robotic assisted surgery, not a robotic surgery. So robot is going to do what you are planning to do. So there are some guys who will do all the balancing preoperatively, and then there are some who will balance the unaffected side and do the releases on the affected side if needed. So here what we are doing, we are trying to balance the lateral side, which is unaffected side. So we try to balance the lateral side both in flexion and extension. Now there are various ways you can do it. You can, especially you have to change the position of the femur. So you can either make it more proximal or distal to increase the extension or decrease the extension gap. Similarly, you can rotate the femoral implant a bit. That will reduce the, if you increase the flexion, that will reduce the flexion gap. So, or you can rotate it to have any differential changes in flexion gap by rotating the femoral implant. So, this way you can match and you can balance the lateral side, which is unaffected side. Now, we see that once it was balanced, there was a difference of 2 to 3 millimeter on medial and lateral side, and we know that once we remove the osteophytes, it will be balanced. Various studies have shown that you don't have to balance it completely on the medial and lateral side, otherwise you will be over releasing the medial side. Then it's an autonomous system, so it gets fixed to the body, fixed to the thigh of the patient, and it starts, it's a burr-based system, so it takes cut on its own. In between, after each cut, if you want, you can verify whether your cuts are accurate or not, and you also have the option of revising your cut if you feel that it's not accurate. So here we are rechecking that whether the cuts have been taken or not. Now it can take all the cuts of the femur, including the box cut, and it can also make the peg holes if you are using PS knee. Now, all during the procedure, you will be seeing that which part of the bone is getting cut, because it's a CT scan based system, so it understands the boundary of the bone. It will show a red flag if you have planned beyond the bony boundaries. So the chances of the burr going into the soft tissue and causing damage to the neurovascular structures are very less. Now, you don't need to retract everything. You don't need to put Homan to retract the patella laterally, because the robotic arm moves in 6 axes. So if it has to cut in the medial side, then it will be cutting from medial to lateral, but if it has to cut on the lateral side, then it will be cutting from anterior to posterior. So you don't have to retract the patella laterally. You just need to have an anteromedial window from where, so you can see here it is cutting on the lateral aspect and it is coming from anterior to medial. Now once it has taken all the cuts, then you have to remove the part of the bone which is left posteriorly. So it leaves a wedge of bone on the posterior aspect and on the lateral aspect. Sorry. So here you can see that the burr has cut beneath the surface of the tibia, and you just remove the bone on the posterior aspect, and then you can do your trial reduction, and you can again check that whether your balance is okay or not. Of course, a surgeon's feeling is paramount, and that is most important thing, but then it also gives you an objective analysis in terms of numbers, and once you are comfortable with that, then you can start believing those numbers also. So that's how the tibia is prepared, and so it can make keel of the tibia also, but we just make the flat surface, and then we make the keel on our own. So that's the trial reduction, and then you can again check the numbers whether they are matching or not. Now one thing which can be very useful in these cases will be something which can also check the pressure, and they are working on that, because these numbers can vary depending on the forces which you apply. But a difference of 1 millimeter is usually accepted. So normally we try to keep our flexion gap slightly looser than the extension gap, and on the lateral side also we accept a laxity of 1 to 2 millimeter with respect to the medial side. Once you are satisfied with that, so then you can go ahead and do your final implantation. So that's the final implantation. So that was the preoperative X-ray of the same patient, and that was the postoperative one where the tibia is in a bit of varus, and that's the overall alignment of the limb, slightly medial to the center. So these are the few features. So it has got an emergency stop. It stops automatically if the bone moves by more than 2 millimeter. So sometimes if the patient is very deep and is breathing heavily, then also it becomes sometimes difficult because the bone starts moving and you have to tell your anesthetist to just wake up the patient a bit. So this is precise, this is personalized, and the footprint of this robo is much smaller than the other one, and it is quite safe. So thank you for the patient hearing.
Anybody, any questions from the audience?
Yeah, you said 2 millimeter medial osteophyte to be taken into account for a soft tissue balancing.
Yes, sir.
What about the slope? When you were a CS surgeon, how to control that here?
So
Because when you, the slope is very important as a CS surgeon, so how do you account that? So we can't.
So preoperatively also when we do the planning, we try to match it with the patient's native slope.
Okay.
So because it's a CT scan based system, so you can check that on the preoperative planning.
Okay. Because these CT-based image doesn't have the softwares or sensor-based softwares.
Yes.
So everything goes on the CT images. So when
Yes.
you are a CS
So
surgeon,
that's
particularly
that's a static planning.
static planning.
Yeah,
So I
but
think when you
that
have a
gives you an idea about the patient's native slope, and you can't always match patient's native slope, but then accordingly you can make some adjustment.
yeah, because we have a lot of gross deformities, so it's difficult for us to match the. And second thing, we should not remove
So
the osteophytes.
there are always some boundaries which you have to follow, and you can't go beyond those boundaries. So
The thing is, teaching basics is to remove the osteophytes, then do assess the balancing. But that's the only caveat that we should balance.
so preoperative planning is with the osteophytes, but then intraoperatively you can remove the osteophytes after you have done the registration.
Yeah.
Then you can remove the, but you can't remove the post-osteophytes.
Sometimes they have a huge osteophytes, loose body behind the PCL also. It just opens up. How often you change the poly? If you plan for 9 poly, how often is the poly
So
changed?
I would say in about anything between 20 to 25% cases.
Okay.
Yes, because it's not a tension-based system,
Yeah.
and you know that sometimes you feel that no, I need a slightly thicker poly.
Yeah,
So you won't just go by numbers. So in that case, your surgical instinct it takes the precedence.
And the fixing that leg in autonomous system, they're putting the extra rod. So when you do after the burring, you have to remove the rod every time and do assess the status?
Yes.
Yes, that's one thing.
Yes, but that doesn't matter as long as your markers haven't moved.
Yeah. Okay.
If the markers move, then it becomes difficult.
Yeah. So yes.
Shekhar, great presentation. An extension of what Ashok asked you, oftentimes you will have a posterior tibal slope which is in excess of 12 degrees. You know, you have these sort of completely posteriorly inclined metaphysis. What is your threshold? From there, where do you go in terms, you said you adjust the slope. How do you adjust the slope? How do you get your, I'm assuming you're retaining a PCL here. So what is your threshold for PCL tension?
For PCL tension,
Yeah, in terms of the slope. So if you start with a slope of, let's say, 12 degrees or 14 degrees, which is not uncommon in our scenario.
preoperatively.
Yeah, pre-op. So from 12 degrees or 11 degrees or 14 degrees, where do you get that in your scheme of things to be able to get the balance, particularly a flexion gap? And the second is again a question that Ashok touched on. There are multiple holes in terms of, does that not worry you that there are large holes? Because one of the x-rays that you showed post-operative, they're pretty large. Does it worry you? Do you do anything specific? Do you graft those holes? Because I'd be worried having those kind of, particularly in osteoporotic situations.
The first question about the slope, sir. So we know that sometimes we also give flexion to the femoral implant, and then the tibial slope is also there. So in sagittal plane, usually I try to keep the combined flexion not more than 10 degree. So even if it is 12, I will just bring it less than 10, it will maybe 8 or 9, not more than that. So that's my limit. I don't go beyond that. I don't know whether our implants are really designed to take that kind of load if you put them in their natural slope. So it's not that we have to exactly match the patient's anatomy. We have to keep into mind that the
So does that mean that you're taking off more anteriorly than you are posteriorly to reduce the slope?
yes, sir. In relation to the native anatomy, yes.
So you're
Yes.
actually, it's a wedge which is thicker anteriorly than it's posteriorly. Is that what you're saying?
If the slope is beyond 11, 12 degree, then yes, I will reduce the slope. I won't put it in that much of slope.
Does that worry you that you're opening yourself up to flexion instability then? Because if you do that,
Sir,
potentially,
it will, I think, lead to flexion tightness, perhaps, because
if you do that,
Mhm.
you've changed the slope of the tibia from what the native 11, 12 down to about 5, 6. You're taking an incongruent wedge of bone which is thicker anteriorly than it is posteriorly.
Sir, I have a feeling that the implants which we use are not really designed to take that much of load in, say, around 10, 12 degree of slope. So I try to keep it less than 10, say 8 or 9 maximum, not more than that, sir. And secondly, as far as the holes are concerned, yes, that is a big factor. So now what we have started doing, we are using the clamps instead of the holes. The pins which are used to fix the robo are the bigger pins, and the ones which show on the x-rays. And so instead of that, now we are using clamps. The pins which were used for the marker, they initially in our starting cases, we used to put them in the diaphysis in femur, and we had a case of sharp fracture, stress rise because of the stress rise.
Sir, kindly summarize, sir.
Since then, we have started putting those pins only in the metaphyseal region. Yes, the tibial pin is in the diaphysis, but these pins are smaller in caliber.
One last one. The practical tip. If you want to increase the slope after trialing, do you go back again, fix the leg, go use the burr to do it, or do it with the free hand?
So you are a surgeon,
Yeah.
so
Okay. So, but as a beginner, somebody wants to do with autonomous, again have to go fix the leg,
so
do it
as long as your tracker markers have not moved,
Yeah.
you can take the recut.
Take the pins. Okay.
Yes, but
Yeah.
if the tracker markers have moved, then you can't.
Okay.
Yeah, thank you.
Thank you, sir,
Thanks, Doctor. It's very good.
for such nice demonstration. Moving on, our next speaker is Dr. Amit Pispati, sir, who will be speaking on dual mobility, practical insights from my experience.
Good morning, everyone. Dual mobility cups, also called as the unconstrained tripolar implants, have now become very popular and viable options in the prevention and treatment of instability in both primary and revision arthroplasty. The main thing is that they offer the benefit of increased stability without compromising on clinical outcomes and implant longevity. And interestingly, they got a US FDA approval also many, many years ago, which is now considered to be a very important landmark. I'm sure you'd all agree that looking back at registry data, instability and aseptic loosening have been areas of concern. And looking at the AOA data, 2019, dislocation was the second most important cause of revision. If you see this newer paper in the year looking at the NGR data 2023, the incidence of revision hip replacement actually decreased by 25% from 2012 to 2019, possibly because of better cross-linked polyethylene. On the other hand, there was a rise in the incidence of dislocation and instability, unfortunately. On the other hand, on the other side of the Atlantic, over years and years, dislocation rates were actually kept very, very low, and that was because of the use of the dual mobility implant. That was called the French paradox.
These tripolar implants give greater stability with increased range of motion, and an overall dislocation rate can be as low as 0.1% for primary THR and up to 3.5% for revision arthroplasty compared to the parent native standard total hip replacements. So what exactly are these DM implants? You have a small head that articulates within a retentive polyethylene, and thereafter, once it reaches its end of movement, the polyethylene liner moves in the metal back shell in a non-retentive way. Looking at the results, there's large number of cases, multiple studies studied extensively over years, and one can see that at 15 years you have as good as 81 to 96.3% survivorship with very low dislocation rates of 0 to 1%. There's a separate dislocation incidence of the femoral head within the polyethylene bearing of 0.5 0 to 5%. There's a newer study published this year, 2025 by Philippot, which shows 98% survivorship at 10 years and 96% survivorship at 13 years, and no cup revisions whatsoever at that landmark time due to aseptic loosening, and only 3 dislocations in the patient population studied. Again, good numbers have been reported for revision THR, and you have 94 to 98% survivorship at 5 to 7 years with only 1 to 5% dislocation rates. Until the year 2018, there was a rising trend in the DM implants for primary THR. After that, the trend has plateaued for primary hip replacements after seeing a few complications in them, because people are now aware of when to use them and when not to use them. On the other hand, for the revision arthroplasty, there has been a tremendous jump and increased take-up in the use of these implants. They're particularly used for dysplasia and for revision hip arthroplasty for instability patients. So the indications would be any patient at elevated risk of instability undergoing primary or secondary THR, patients with recurrent hip dislocations, neuromuscular disease, spasticity, Parkinson's, Alzheimer's, dementia, cognitive dysfunction, patients older than 75 with prior hip surgery, even high BMI patients. Nowadays, patient over 60 years with transcervical fracture neck of femur, especially patients with abnormal spinopelvic alignments, fixed alignments, stiff spines, previous spinal fusions, and DDH patients. A word of caution, one must take care in doing these in patients younger than age of 50 years, because there's a rising trend in this part of the world to do them at any age in any patient. And if you did these in patients below the age of 50 years, there's a very high incidence of polyethylene wear and osteolysis, as much as 10 to 13% in 8 to 10 years time duration. So patients less than 50 years of age, caution, there's high poly wear, and patients more than 70 years will usually not need a revision if it's done into them in their lifetime. The newer polyethylenes have certainly decreased the use of the wear, and ceramics also has decreased the wear rates. A specific complication noted is intraprosthetic dislocation, which can happen because of articular failure between the femoral head and the polyethylene liner. And this can come at 15 to 20 years and is seen here as a typical bubble sign. Here's a female of 85 years old. She had a large head metal on metal hip done on her 15 years ago. She had no complaints whatsoever. And you can see at the time it was implanted, it was a Dorby canal. I was able to remove this very successfully. At the time that we revised it, it was a Dorsey canal. She was elderly, and it was revised to a dual mobility system with a cemented stem, and she was happy thereafter. There's a 78-year-old female, cemented bipolar periprosthetic fracture with loosening, and that was revised to a dual mobility system with a long uncemented stem. Female 79, comminuted intertrochanteric fracture, and this was treated with a primary bipolar hip replacement system. Unfortunately, at 3 weeks it dislocated, and I had to go back and revise it to a dual mobility system, and that solved the problem. Male 67 years old, transcervical fracture neck femur, hence treated primarily with a dual mobility. Female 90 years old, she had some element of cognitive dysfunction and early dementia, and hence the choice, and she was in severe pain with great difficulty mobilizing, hence a primary dual mobility was performed on her, and she was satisfied with that. Female 74 years old who presented with a large metal-on-metal dislocation about 16 years after it was done. She was treated by revision of the cup. The stem was retained as it was good, and we found that this dislocated thereafter. You can see the small bearing has come out, and this is something that I wanted to show.
I assembled the
You can
metal
see
dual
over here
mobility today.
how there's a play of the ceramic
this
head
the
within
sort of
this,
play
and
that
if I pull hard, the
would be
ceramic head will even
expected
come
in the
out.
system?
So the message is to choose your system
Would this
very,
be
very
normal?
well. Otherwise, the ceramic ball will pop out of the polyethylene liner. So all DM systems are not the same. Female 72, cemented bipolar, which sank down after a fall at 10 years, and this was revised to a dual mobility system. Final case, male 70 years old, who presented with this. At the time of removing the implant, we found multiple tears in his abductor mechanism, hence he was revised to a dual mobility with the long stem monomod. There's neck notching also occasionally because of impingement after dual mobility, hence caution in terms of how you place the implant. Absolute indications for these are revisions, abductor deficiency, spinal fusions, and considering TC fractures. Watch for cup position, impingement, IPD, and occasional metal ion elevations. In conclusion, these give significant reduction in dislocation rates, and from the economic perspective could be good as they reduce the dislocations, and newer implant modifications in terms of cross-linked polyethylene and ceramics have increased their longevity. But due diligence is recommended in terms of long-term performance before we can justify their use routinely in patients below the age of 50 years. But in general, I think that these are winners. Thank you.
Thank you, sir. Any question from audience?
Amit,
Yes, sir.
if there is abductor deficiency or we call it as a bald trochanter, so there is nothing on the trochanter, this implant does not work.
Absolutely, sir.
And we need to go to constrained liner, or you reconstruct the abductor the various
yes.
ways Whiteside and
So,
other people have
So
described.
gluteus maximus transfer is also an option.
Absolutely, otherwise this
Yes.
implant does not work.
Yes, agreed, sir. Absolutely. So in these cases that I showed, none of them had an abductor which had been completely pulled off.
Thank you, sir.
Thank you so much.
For our next talk, I would like to invite Dr. Simon Thomas, who will be presenting his talk on high dislocation risk, selecting between dual mobility and constraint liners.
Good morning, everybody. Thank you, Dr. Pachore and the Ortho Trends team for having me here. I think a lot of what I'm going to talk has already been talked by Dr. Amit, and there's going to be a lot of repetition. As he already told you, dislocation is a problem. Although the incidence is not that great, when we go in to do a surgery of a total hip replacement, we are not really bothered about a hip getting dislocated because the incidence is very low. But still, for people who actually have a dislocation, it is catastrophic. And not just for the patient, but for the surgeon also. A very good, nice surgery done, a juice is taken out by simple dislocation. And these are the data. I think you can go through this. Causes of instability, if we see, actually there are multiple instabilities, multiple reasons for instabilities, but we can actually grossly divide them into surgeon factors and patient factors. If it's a surgeon factor, then you have to do changes in your surgical technique and implant armamentarium. There is no armamentarium, no dual mobility, no constraint, which can actually tackle a badly done surgery or not a great implant position. But for patients with abductor deficiencies, these are patient factors, not the surgeon factors. Abductor deficiencies, multiple surgeries, patients with neurological problems like a Parkinson's, stroke, cognitive dysfunction, patients who are actually hostile. With patients with cognitive dysfunction, sometimes they squat, sit cross-legged, they will not listen to you. Seizure disorders, peripheral neuropathy, patients who undergo a spine fixation with an altered spinopelvic anatomy, these are the patients in whom actually technology will help you. And this is where, to reduce dislocation rates, we somewhere along the line moved from a primary cup to a dual mobility cup. We all know about it. There are two articulations, a small head within a mobile polyliner. The mechanism is that there are two junctions of movement, so it gives you more range of movement. And also the head size actually increases, so the jump distance is high. And that's how dislocation reduces. It is not a panacea to prevent or stop dislocation. The indications, as I already told, neuromuscular disorders, Parkinson. This patient is a poliotic patient, and he walks next day with a dual mobility. A patient who's undergone a PFN once underwent a spine fixation when somehow she felt that she wanted to get the implant removed. She got the implant removed, and she had a pathological, neck of femur because of the severe varus in the neck, and we had to use a dual mobility because of the altered spinopelvic, anatomy. This patient is 38, fractured neck of femur 20 years back. The abductors have not worked for long. The trochanter is, very highly migrated. Getting that back, we don't know how the abductors are going to work. It is always safer to have a dual mobility. Sequelae of childhood diseases like a Perthes or a Scuffy. what happens is that the anteversion in a patient who has not loaded this hip is much different than what is for a normal patient. So in this also, doing a dual mobility actually gives you more and more safety in terms of preventing a dislocation. Fractured neck of femur in elderly, this was a problem patient because the dislocations used to happen frequently. Now with lax tissues and patients who have collared dysfunction, dislocations are high. So in a fractured neck of femur elderly patient, dual mobility is actually an indication of choice. Failed fixation, again, a dual mobility is there because multiple times surgeries have been done, the adductors are weak, there have been scar tissues, and once you release everything, it becomes very lax actually. Sometimes failed revisions, a bipolar which is broken many years, there is no trochanter. At the end of the day, we try everything back and there's a dual mobility on. This patient is a fractured neck of femur, fractured dislocation of the head, lying like this 5 months down the line. The abductors have not worked for so long. The surgery has been done. When we go inside, we find that the abductors are totally actually scarred and we had to rely on a dual mobility. Ankylosed hip, this guy has never walked like straight and the abductors are tight. We bring it back. A dual mobility is the implant of choice because it gives you actually more safety. The constraint liner, basically the liners were mechanically locked initially. In this, you used to put a head and that used to be locked into the head and it would not dislocate. But the problem is that a lot of strain is actually passed on to the implant bone junction and that would lead to higher implant loosening rate at a shorter time. With the newer generation, the constraint liners, this is to be, this is reduced to some extent. And what are the indications for this? Multiply operate patients from 92 when she was 48 to 2024, she presented with this, a 15-year follow-up, and she's infection. At the end of the day, everything comes out. What is left with this? And she walked next day. I thought she'll never come back for a surgery. 3 months down the line, she's back to my door, wanting to walk again. And this is how it is. No trochanter, no soft tissue at all. And this is what she undergoes, and this is where a constraint is the answer of choice. This is a post-operative X-ray looks like. There's a day 1 and there's day 3. This is the week 3 of this patient. Another patient, neurological problem, cerebral atrophy, a bipolar done, dislocates, multiple closed ductions done. It did not work. When we opened the bare trochanter, as Dr. Pachore said, we actually put a constraint liner. Again, the point to be noted is that this constraint liner has to be aptly placed. You cannot get away with a bad position. Secondly, you should also make sure that you put back the muscles. You should cover this. We had taken a vastus lateralis, actually the aphasia on that, actually turned it out, made a fascia, covered the implant. Don't rely on the, just on the constraint liner to hold you on because it will loosen very fast. And this is how a patient, again, 45-year-old lady, she had a fractured neck of femur, went, somebody did a valgus osteotomy, it failed. The valgus osteotomy was done again, it failed again. A third valgus osteotomy was attempted. They abandoned the surgery in between. This patient did not have anything to do but other than getting a total hip replacement. And by this time, there was no trochanter, no abductors. We had to use a dual constraint liner. This is a day before yesterday's follow-up. She's 6 years down the line. She's doing well. She's 54. Hopefully, she continues for some more time. A 70-year-old lady, tumor excision, absent trochanter. There was nothing else but a constraint liner to be used. This is an algorithm. I'll not go into this. But now, just like Dr. Pachore said, maybe we're a little younger. We're trying to actually extrapolate the indications now. I've seen in endoclinic a lot of bare trochanters being done with actually a dual mobility. This is a bare trochanter, tumor excised, no muscle. We actually did in a dual mobility, and she started to walk. I hope she has a long follow-up with this, but I have somebody else who's got a much more longer follow-up. This I operated 10 years back, pathological fractured neck of femur for a GCT. She underwent a tumor prosthesis. She came back to me this May for a lysis around the stem. We revised the dual mobility cup because the dual mobility shell because it was actually having a loosening. So this trochanter is bare, and we have put it back, and this is how the post-operative looks like. And she's a 10-year follow-up, and there is no abductors. She does not have abductal lurch, and she walks nice. The data can be actually confusing. Constraint liners apparently have more dislocation rate, maybe because they are done in more different or difficult situations. The complications, I think Dr. Amit mentioned, intraprosthetic dislocations, we see them, especially even the material is not very good. So Indian companies and some companies, the material is a problem.
Sir,
in this we see
kindly summarize, sir.
Thank you so much, boss. I'll just take one last message. Dislocation is a rare but a catastrophic complication. Good implant position and surgical technique is paramount for preventing dislocation. Technology like dual mobility and constrained liners will help you, but your surgical technique has to be immaculate. Thank you so much for your patient hearing.
Thank you, sir. For the next, we have symposium on complex THR. I would like to invite Pachore sir on the podium as a moderator. And on the panelist, I would like to invite Dr. Rajiv Sharma sir, Dr. Harvinder Chadda, Dr. Kyle McGibbon, Dr. Sanjay Agrawala sir, Dr. Amish Chatri.
I think Dr. Rajiv Sharma sir is not here. I would like to invite Dr. P.S. Ashok sir on the podium as one of the panelists to make things more interesting for us.
Okay. Good morning. Greeting from Ortho Trends. We have an excellent faculty here. As Dr. Rajiv Sharma is there, not there, so Ashok is here. So Arvind Chadda is there. Dr. Kelly is there. Dr. Sanjay Agrawal, a close friend of mine, and my colleague Amish. These are going to be presenters: the Prashant, Kesavan, Navneet, Sandeep Kumar, and Kiran. These are the 5 presenters. We are going to give about 7 minutes to them for the discussion and presentation. Just a general guideline. We are not here to test somebody's competency. Your views, experience, evidence-based opinion will share to the delegates. Short and very quick answers will be appreciated. I may not ask same question to all of you, so do not feel about that. So we will move to the first presenter. Can I invite Dr. Prashant? All cases are very straightforward. There is no googly, so nothing to be worried about it. We just want some message to be passed to the delegates.
Good morning. Today, thank you for Dr. Pachore sir to invite me here. This is the first case, 60-year-old female, pain and difficulty in walking since 10 years, not sat cross-legged since 40 years, and she's having, so this is the X-ray. Unfortunately, I don't have a CT scan, so please, we'll start from.
Yes. So, this is just X-ray. What are the thoughts, Kelly? What will be the roughly a diagnosis, and what will be the future action for this patient?
It's a 40-year-old, sir.
Yeah.
So secondary OA, probably some female patient, probably some dysplastic changes may be there. So for taking points at this stage of X-ray, we need to do a CT scan. It's mandatory, now the CTs become. So based on the CT scan, you can see subtract the head and see the acetabular. Acetabular will be very good in this. So second comes the planning of the implants. Look at the offset of other side, other hip. You have to restore the offset, and you have to be prepared for a standard uncemented cup, and the primary low offset stem is required in this case here.
Sanjay, you want to add anything?
Yeah, I think all of us as orthopedic surgeons keep seeing X-rays and CT scans. Clearly there are soft tissues involved. Someone who's not sat down for a long time wants to start doing it. There is not only the muscles, the soft tissue tensions, but there is the sciatic nerve. So all these need to be kept in mind, and I think you need to be very lucid with explaining to the patient's relatives that there are certain things that you cannot do. Now, when you come to what you can do, clearly CT scans, etc., are required so that you know what the lay is of the bone. Also, these are the kind of cases where if you're going to lengthen it, which this needs significant lengthening, You do the adductor tenotomy prior to the positioning. So I think those are the things that I would keep in mind. Of course, then the discussion will be which implant, whether you use dual mobility or constraint. Those are secondary considerations.
Okay. Kelly, you want to add anything? You would like to add anything what the discussion is?
No.
Okay. We'll just move. Go back. There's one important sign. If you look very carefully, there is a double sclerotic line here. This is on the teardrop. This is one more. That indicates there's a big medial osteophyte, and this is more likely to be a dysplastic patient. That is one of the important signs that you have a very, very large medial osteophyte. I think we just, next. We just classify for the sake regarding dysplasia. This is just grade 1 dysplasia, so nothing to worry about it. Next. So this was discussed, and this is what one must follow the protocol of CT scan, which gives a couple of ideas, very important ideas. If you look at that medial big osteophyte, this is not the same patient, but this is something we added. So you look at this big medial osteophyte, you can see the version. Most of the time this dysplastic will have excessive anteversion, so you have a documentation of that anteversion. You can measure the size of the implant, what you are likely to. So CT is one of the important what the faculty discussed. Agreed. Next. This was the medial osteophyte. Amish, how will you tackle this medial osteophyte? Once you know there is a medial osteophyte.
What I usually do is I take a drill and just drill it inside and just know what is the, and preoperatively on the CT itself we can know what is the amount of the size of the osteophyte, and just the reamer should be perpendicular to the floor. So that is, and you see till the pulvinar fat is seen. Once the pulvinar fat is seen, that means you are on the right on the quadrilateral plate, and then you go on your the sequential reaming with the reamers.
Yeah.
Or you can do with a gouge also. If a very big medial osteophyte is there, you try to put a inferior spike over there where you can see the transverse acetabular ligament, and you can ream it inferiorly and the medially. So that will help us to identify the tail also.
Yeah, thank you. This is the surgeon did this cemented orthoplasty. Dr. Chadda, any comment on this?
It seems like the anaversion is lacking on the acetabulum, but I don't know what the femoral anaversion was there, so it may correspond. Distally, it looks like there's still length is almost there, and the offset is probably achieved. Pretty close.
Yeah, okay. Anybody wanted to point out the cementing on the acetabular side has any prediction, Sanjay, so that you can say this is a post-op X-ray, you can say that this patient, this hip is going to last for 10 years, 15 years, 20 years, whatever.
So when you talk about the cement mantle, you clearly need 2 millimeters, understood. But if you remember from our earlier Charnley teaching, you needed peg holes. And we don't need really the peg holes that Charnley used to make. But if you have some drill holes, that would help anchor the cement. And clearly, everything else seems to look very good here, except for the cup anteversion. I agree.
Yeah, next. So this is a 14 years follow-up of this patient, and absolutely still going very, very strong. So that is the what Sanjay said is very important is the cement mantle. And next slide. This is a prediction. Anybody knows about it? Any of the faculty? This is the post-op X-ray, and you can tell on the first post-op X-ray if there are no radiolucent lines across all 3 zones. You can predict this hip for lasting for 20 years, at least 85% of the patients. That is very important for cementing, and this is one of the predictions which Ranawat wrote in way back in 1988 or so. Next. Ashok, these are the couple of cemented hips for grading wise. And what is your prediction of these cemented stems? I know a lot of people are not using much cemented.
It's a forgotten art by next generation, sir. That's a true thing.
Anyhow, this is a great prediction. If you have a whiteout cement, something like this, these hips are going to last for more than 20 years or so. And these hips who are varus with a deficient cementing are likely to fail in just 6 to 8 years time.
This is a 14 years follow-up. Patient is sitting very comfortably. There is no any pain, and she's walking very comfortably. So this is the case.
So could we just go back? Could we just go back on the pictures of the cement, the cementing pictures that you showed us? Now, there was one more picture before this, perhaps. If you look at what we were talking about, anti-version of the cup, it was later on realized by Charnley and subsequent consultants that if you had that wire, that C-shaped wire which is there in the post-op 19 years, right at the bottom, you can see that you can then judge the degree of anti-version. So that wire was incorporated in the Charnley cups thereafter so that you could judge the anti-version on a radiology, on an X-ray. And go back again, please. There's something else which is interesting for many people who haven't seen these. You look at the picture on the right-hand side of your screen where 19 years is mentioned, and what I was telling you about the Charnley peg, the Charnley peg was then, because it would then otherwise get the cement to go into the pelvis, you had a cap. So the Charnley cup used to come with a metal cap, which you then plugged into the lug that you had created, because you needed to ream on that lug, and then this cap would prevent the cement going in. So every single Charnley cup would carry that cap. It was called the Mexican cap.
Thank you. Because of lack of time, we'll just move quickly.
Please move to the next case, please.
46 years male present to the outpatient complaint. The right hip pain, difficulty in walking since 20 years. Increased over the last 2 years. Pain and limp have made day-to-day activities painful and restricted, not responding to the medical management, not able to sit cross-leg. On clinical findings, patient mobile with limp and lurch, right lower limb shortened by 1.5 inches, severe tenderness. And this is the X-ray.
Yes, go ahead.
So surgical options. And we did the uncemented hip. This is a consensus hip just now. And this is the second post-op, and this is a 6 months follow-up. And this is now the result of this patient.
Thank you.
Thank you.
Can I invite Keshavan?
Please be on time. So try to maintain the time, please.
Yeah. Thank you.
Morning all, thank you sir. Without much ado, this is a X-ray of a 55-year-old male who presented with this picture. He had an old fracture in the distal femur, treated conservatively, but we are now going to restrict ourselves to the hip. He presented with pain and stiffness, and there is an obvious protrusio. The question comes, what is the diagnostic criteria for a protrusio? How do we make, what are the lines? Do we have any radiographic markers? We'll just, so there is the ilioischial line, the acetabulum and the femoral head, which is positioned medial to this ilioischial line, or the Kohler's line, is a pathognomonic of a protrusio. Clinically, we see that as the protrusio advances, the hips become more stiff, so there is less pain, stiffness becomes more prominent, and the limited movements is a very marked indicator. It is classified as mild, moderate, and severe by Charnley and his fellow, as depending on the extent of the medial displacement. If it is, with another thing, radiological marker is the center edge angle. We note that as the head grows medially, the center edge angle increases, and there is a negative roof arc angle. So, is there a role of a CT scan?
Yeah. Again, Mr. Kelly, is there a role of CT scan for these protrusions?
For that particular X-ray, I don't think so. I think I'm fine with plain films.
No, for this city, for patient is okay. For any protrusio which is little worrying you,
If I'm worried about deficiency, then yes, but for that, no.
yeah. Anybody from the faculty?
We see the sequential X-rays sometimes, and then we can see the medial margin of the acetabulum both in the AP and the lateral view. If it is not perforated or means the ilioischial, it goes beyond that. And sometimes we see guarded protrusio. In those patients, a membrane well bone formation is there. So in those patients, we might not require CT scan. But where more protrusio is there for the breakage of this medial wall, we can have a CT scan.
The CT scan shows very clearly the medial migration of the femoral head, and another good indication that we have is a trochanteric rim distance.
Let's slide. Okay. This is very important. What is pointed out is this distance is very important. If this distance gets reduced, it is very difficult to dislocate these hips and expose this hip. So this is one of the important factors of the CT. And again, not this patient, but the medial wall. Sometimes you have almost like a pelvic dissociation. So that is very important for the implant inventory to be kept ready. Go ahead.
So the pre-op planning, what is the goal? Is there some goals that we have?
Yeah. Anybody from the faculty? We need something planning for this patient. Ashok.
So this patient, thing is, CT is being, it's a protrusio, long-standing protrusio.
Yes.
We need to have a peripheral fit, not the deep fit. And second thing, key in all the protrusion, exposure, and it's a malunited femur, even difficult to turn the leg.
Absolutely.
So distal malunited is there. So exposure is a key thing to work in this protrusio. Intercalated osteotomy can be done, or whatever, gradual release and expose it. And the cup wise, I think it's a standard, straightforward. It's a peripheral fit is aimed, not to get the deep fit.
Right. Okay.
So our goal is to normalize the biomechanics and optimize the range of movement. Aim for a rim fit, as was rightly pointed out. In a regular hip, as principles of low friction arthroplasty of Charlie, it was to medialize, but here it is only a rim fit. If there is a difficulty in finding the center of the cup, then we can use the isosceles triangle of Ranawat.
Yeah. One important message of all this protrusio, which Chit Ranawat wrote long back, normalize the center of rotation. That is one important. Second is medial bone grafting, and what Ashok said is the peripheral fit is very important, and don't violate the medial wall. So these three important things which you have to keep in mind for any of the protrusio which has got a long-term results.
And to use a CM if required most of the time.
Yeah, okay. Go ahead.
So surgical approach, we went through that, short touched upon it. So it's crucial to mobilize the femur. It's a medially migrated head. There is a very small distance between the trochanter and the acetabular wall. Careful detachment. We either do a controlled dislocation with a bone hook or do an in situ neck osteotomy, and in very severe cases, a trochanteric osteotomy. So trochanteric osteotomy is only for the severe cases. So the acetabular preparation is the key. We try to do a peripheral reaming only, remove the cartilage, and the important thing is to use bone graft. Very often we have a primary hip, so we have the autograft. We do a reaming of the head and pack it inside the femoral head.
Okay. Anybody agrees, Sanjay Agrawala, regarding this technique of reaming and putting this graft? Sanjay?
I think this is the only correct way of doing it. You shouldn't use too large a morselized graft because that will become sequestrum. Two caveats here. Once you have this mush, you should squeeze out the fat. So you put it in a gauze piece and squeeze it out. That is one. The second is that if you wish to use this graft with a cemented cup, then you must have a mesh between the mush that you have and the cemented acetabulum.
Any
So
of the
that's-
faculty would like to add whether these grafts are okay or you would like to have something else?
Actually, what we do is that we prepare a particulate graft. We remove the cartilage from the head and just take sliver of sections from the head of the femur, and then we make it up to 3 millimeter of particulate graft.
Yeah, yeah.
And those we get lot of graft, and if the defect is that is grade 3, very rarely we need some allograft. Otherwise, the head is sufficient for the usual this type of cases.
Anyhow,
And
we have actually stopped now reaming this. The ideal grafts are the slurry graft or called mastic graft, and most of the people have left doing this actually a morselized graft with, because there is hardly any mechanical stability. So most of the time now it is a mastic graft and a reverse reaming. Go ahead.
So we place that in the graft, do a reverse reaming, and if there is medial wall, sclerotic wall, we do a burring to an exposed bleeding surface and use an uncemented cup. Important thing after reduction, because it's protrusion and medialization, we want to avoid impingement, and after we do the final implantation, closure of rotators may be an issue because of the lateralization of the hip. Post-op weight bearing as tolerated. Is there any specific protocol that the faculty would follow? Would you delay mobilization?
Dr. Chadda, do you delay mobilization for these patients?
Cautiously, I do allow it. Whenever I get good stable fixation along with it, I tend to use more of a structural graft, and usually if it is still a little bit soft and I put fixation on there, then I'll usually not weight bear him for about the first couple of weeks, and then progressively weight bear him after about 4 to 6 weeks.
So this is the post-operative X-ray, peripheral fit with medial grafts. You can see them in the gap. And this is a similar case, a similar example, protrusio with grafts and uncemented cup. This is a third case, post-traumatic, neglected acetabular fracture, head in the pelvis partially. So that was this. We used a dome augment like which Professor Malhotra was telling yesterday, and reconstructed. Thank you. So in summary, we need to do a lateralized cup with medial grafts and avoid impingement. Thank you.
Thank you. Thank you. Can I invite? Yeah. Come.
Good morning, everybody. I would like to present a case. 42-year-old female with bilateral hip pain and mobility challenges persisting for last 15 years. There was left hip pain which was first, and the right hip pain started within the 6 months. The patient sought no treatment, and the condition was exacerbated, and progressively worsening symptoms were there, and stiffness in both the joints in the last 1 year were there. On examination, the gait was stiff. The right lower limb was shorter than the left by 6 centimeters. The anterior superior iliac spine was at higher level on the right side, and there was a fixed flexion deformity bilaterally. On further examination, there was FFD of 60 degree.
Just mainly down.
Yeah. So finally, there was mainly a wind shift deformity and stiff with flexion deformities on both sides. So these are the X-rays.
Ashok, these are the X-rays. We are worried about only on the, we are going to tackle right side first. So that our concentration is on this side. What next do you feel?
So standard protocols, do a CT scan.
Correct.
Yeah, it's a post-traumatic.
No, not post.
Not a post-traumatic.
No, no, it's not post-traumatic.
And it's been lying down, it's high riding for a long time. The hip is pelvic obliquity is there, and no spinal pathology.
No.
No spinal pathology. So CT scan for the study purpose, probably everything is walls are intact. Look for the columns and thing. So explain to the attendants, like Agrawal sir said, there may be a sciatic now praxia if you get down the hip to original position. So I'll control the standard uncemented cup and the offset with the stem, controlled offset stems to be used, what is required. Second thing, to lengthen as per the sciatic nerve tension. I don't want to lengthen it. So surgeon's independence, intraoperatively, how much length to be done based on sciatic nerve field.
Anybody just we just pointed out a teardrop. Anybody wants to add here? Looking at the teardrop, looking at the whole thing is migrated superiorly. Anybody?
The reduction will be a difficult task, and to bring the center of rotation, if we bring to near the teardrop, we might see some superolateral defect as we go on reaming medially and use the posterior wall and column to try to get the AP fit of the cup. We might land up in some superolateral defect. sometimes, and that has to be grafted with depending upon the amount of defect.
Mr. Kelly, do you want to add anything? Because looking at the teardrop, looking at this pathology, how?
No, I think potentially depending on how much length you can get back, there's a decent technique that's been described of double cup and maybe potential for that.
Okay. One important sign in this, if you draw an inter teardrop line, if this is the lesser trochanter is quite above, this patient will have a very difficult time to reduce this hip, and probably we'll have to keep in mind of subtrochanteric shortening. Go ahead.
So, this is the CT scan.
So CT was done definitely.
So hip joint was assessed right side. The ligament teres was identified and traced to locate the true sternum, which was found to be very small and dysplastic. So the pseudosternum was deemed until the punctate bleeding was there, and structural graft was harvested from the ipsilateral femoral head, and it was secured with 4 screws. The native sternum was deemed, and the established shell was implanted using a press fed technique and secured with 2 screws. And the inferior hip center of rotation was achieved. So these are the intraoperative. As you can see, there was a sternum which was very high, and the lower native sternum was covered, and the upper part, the upper sternum, pseudosternum was graft was placed there and secured with screws. Later on, okay. Then reduction of the proximally migrated greater trochanter was not feasible without excessive sciatic nerve tension. Therefore, subtrochanteric osteotomy with shortening was performed and stabilized using 6-hole plate. Cemented exeter stem was used, as it was not possible to use the uncemented stems, as the femoral canal was very narrow, and bone grafting was carried out, incorporating the graft harvested from the subtrochanteric osteotomy. This was the subtrochanteric osteotomy, and this is.
Any comment, Ashok? Quick. This is a cemented stem was done, and this is the center of rotation normally brought. Anybody
When was this done? This recent years?
Yeah, this is 9 months follow.
Oh, okay.
9 months follow. No, this has been described by the Exeter group and Wrightington group that cemented stem can be used in subtrochanteric shortening. So there is no question about it. It's a very long follow-up also. One important thing, the surgeon did a great job of putting this graft. Look at the direction of the screws. Very important to get the direction of the screws sacroiliac, toward the sacroiliac. These are the grafts are going to survive much better. And normal center of rotation, even though it is a small cup, normal center of rotation, subtrochanteric, and they are able to manage the fairly good biomechanics.
It's a great artwork, nicely
Yes,
done, good
yes,
job, sir.
yes.
So probably we have done a standard, the bigger uncemented cup. One, we used a C-arm intraoperatively to get this, better to use a C-arm to get the cup orientation, and uncemented stem for the sorting, yeah.
So we don't have.
So this is the learning, what we learned.
I would
from
like to
this
just
patient.
add one thing, sir, if you permit. I would like to add, when we are putting the screws in the sacroiliac joint, we should have a pelvis model in the OT, so that sometimes you tend to put it horizontally. So right in this, if you want to put, if you keep whatever the position of the patient is there, and that will help you to guide the screws as well as the IIT.
Thank you. Can I invite the next?
Okay. Thank you.
From Dr. Vijay Kumar's unit. Yeah.
Good morning, everyone. I would like to thank Pachore sir and Professor Vijay Kumar sir for this opportunity. I'm going to present 25. We have seen a 25-year-old male who presented to the OPD with complaints of restricted bilateral hip mobility and lower back stiffness for 8 years. He was a known case of ankylosing spondylitis for 4 years, and there was a left lower limb shortening, true shortening of 3 centimeter. These are the X-rays at presentation.
Yeah, starting it's a stiff hip.
Is there more ankylosed?
Yeah.
Both ankylosed.
Yes.
And one side, this implant, a lot of people may not know, but I can tell you, this is, Sanjay Agrawala will know probably.
Wainwright's spline.
Yes, yeah, because he was there in Liverpool. So this is the thing which is there, and probably this is a post-osteotomy. Any other thing you would like to, any more investigations you need to have?
Yeah, same, the spinopelvic assessment, one, CT scan, two. So I'm giving, the ground is the stiff hip and the ankylosed hip. So you have to take out the bony ankylosis. So again, as sir says, Sanjay sir said, tell the attenders all the, what is the expectations you're going to get after this surgery in this hip. So again, use a standard cup, use intraop C-arm to get the hip.
Yes. Patient has a history of left suprachiasmatic. 4 years back, he had a history of left suprachiasmatic femur fracture, which was fixed with plating. And this is the previous X-ray. And there was some osteotomy at bilateral neck, maybe a McBurey osteotomy.
This is the time the patient came to their unit. After this refixation, the Wainwright's plate was taken out, the refixation. So we have bilateral problem of ankylose and the post-osteotomy. Any important investigation, what you mentioned is the CT scan is very important, post-osteotomy. Just go next.
Which side we're doing, sir? Done, both the sides done?
Both the sides.
Both sides done, TH.
Yes.
So in the sequential planning, do we need any extra imaging, CT scan? Is there any role of ESR, CRP or aspiration? Do we need to do aspiration of it before surgery?
There's no role.
I think there's always a role for ESR and CRP. That's going to be hard to find a whole lot of fluid with aspiration. I would worry even if ESR and CRP are elevated, but I'd try if they were.
No, aspiration probably with this implant is not recommended, and the second is the ankylosed hip. So there is no question of getting anything there. But I agree with CRP because multiple surgeries, agreed.
These are the spine, AP and lateral spinal X-rays and the CTs.
One important message I would like to pass to all the delegates. Post-osteotomy CT scan is very important. Reason is you should be able to get a coronal and sagittal both plane at least 6 slices that the canal is open. Then you will not be able, you don't have to redo osteotomy of these patients. You will be able to get the canal. You may have undersized stem or cemented stem option, but CT, coronal and sagittal both planes, at least 6 sections, you should have a canal opening. And these patients also have the anteversion problem, so you have to be careful and measure your anteversion accordingly. This is one of the important messages for post-osteotomy patients. Next.
So in the planning strategy, we have following questions, which, whether we have to do it single stage or 2-stage THR, whether do it as a cemented or uncemented THR, what is the implant of choice, and what are the important intraoperative steps that we need to tackle, and what is the post-operative rehabilitation protocol.
Only we want faculty to just, will be the surgical, how do you get the true acetabulum, how do you get this, somebody from the faculty can give some idea.
Go
ahead.
Good. So first we see whether the hip is fused in external rotation or internal rotation. First you see whether the hip is fused in external rotation or the internal rotation. If the hip is fused in internal rotation, then you are able to see the neck and you can use the posterior approach. But if it is in external rotation, it is very difficult for the posterior approach to be taken. So what I do is I go for an anterolateral approach, and then I release the medius and the capsule, drill hole in the neck, identify the neck at the end, make a napkin ring osteotomy, and then there is a cortical, I remove the cortical ridge with the help of a nibbler, and then go on reaming and find out medially, and then find the pulvinar fat, and once my cup is prepared with the trial cup, I will have a look at the IIT.
Okay.
So,
Anybody wants to add quickly?
single stage or two stage, surgeon has to decide depending on the length of the surgery. Single stage is preferred. Cemented, try for uncemented. Bone quality is not good, depending on the surgeon's one. And implant choice, again, you're shown a good cemented stems. Uncemented, remove the proximal screws, put a Cohn-Wagner type stem. Intraoperative decision, use a C-arm to get the same teardrop principles to get the flow, everything. Rehabilitation, based on the intraoperative bone quality, you decide how to do the mobilization. Yeah.
Is there any intraoperative crucial step that we need to look before surgery or during the surgery? In the X-ray, there was LT, lesser trochanter flat side was fused to the ischium. So we need to consider this fact before going. We have done, we did single stage THR with SROM and with long stem, and we did orifice plating with bone grafting. This is the, and after 2 months we did right side THR with SROM.
Yeah, look at the sleeve. They have reversed the sleeve because this is a post-osteotomy. One of the very important for SROM to get adjusted for this, especially with the post-osteotomy. And also you should keep a cemented option on the table. This is one of the difficult problem, you know. Next.
These are the X-rays of 1 year follow-up and 3 year follow-ups.
Any last comment quickly?
Fantastic. I think great job done, incredible job in fact.
Thank you.
One question, one observation. Everyone's concerned about infection. The one test is not the aspiration, not the CPC ESR, because here you have an ankylosing case. The ESR could very well be high, including the CRP. The one test that you need to have access to is the FDG leukocyte scan, if you're concerned about infection.
Go ahead.
Thank you.
Thank you.
Thank you.
The last case, Mr. Kiran. You have only 5 minutes.
Yeah.
Go ahead.
Good morning, everyone, and thanks for the opportunity. Presenting a case about a 29-year-old man who had come to us with limping, severe pain in the lower limb and not able to walk since last 2 years, and he had previous 2 surgeries.
Go ahead.
Next slide, sir. We'll see the picture. He had a vestibular fracture for which plating was done, and it got infected and the plates were removed. After 2 years, the plates were removed. So with that, he had this injury when he was 19-year-old. He had come to us when he was 29. So once he had presented to us, and he didn't wanted any further osteotomies. So can I have the slide? Previous surgery. This is the X-ray. And I would like to know, ask the faculty what they would have planned for this.
Dr.
It's
Chadda?
a straightforward case, but yes. Shortening of around 6-7 centimeter pre-op.
This was a post-acetabular plate removed. Now there are no signs of any infection. The CRP, CBC, CRP, ESRs are normal. Any other investigation which might help you?
A CT scan is a good thing.
Absolutely.
No need, it's like a standard like X-rays.
Yeah.
And advent of 3D printed augment, study the columns. What is the state of the columns, both the columns?
Yes, this is
So it's a huge, large defect. I think now we have a 3D printed custom augment.
Yes.
A cup is there. It's the ideal case to get the 3D printed cup.
Yes, agreed. Totally agreed. If you look at this city, transverse cities are very, very important to know. You look at that. There's nothing on the posterior side, and the whole thing is migrated superiorly. So what will be the strategy? Sanjay Agrawal? Sanjay?
We need a CT scan.
Which
of
are already
course.
there.
No, which we have. Based on that, we should have a model as well.
Yes,
That would
agree.
be very
Yes.
helpful.
Helpful,
And
agreed.
most big cities have this facility.
Agreed.
So along with the model, then you need to have the implant.
Agree, totally agree.
So we have to restore to the original hip center, what are the opposite sides, a young fellow, so that 3D printed augments are much better now. So you can get, not to use a big augments in the defect and all, we can customize the cup as well.
Okay.
The patient, obviously working at corporate, Cost will also be a constraint because he was a cash patient. I didn't think of getting a 3D model for this patient. I felt we could just go with the sim. The head quality was good. I felt I can just place that.
Go ahead.
Intraoperative pictures. You can see it was proximally migrated. There was a deficient posterior wall, and initially what I did was just created the discuss with Dr. Ashok.
Yeah.
So I shaped the femoral head, but the bone grafting was done. The stability of the cup was really good. This was done.
Yeah. Just leave that in the next section. Okay. Ashok, you have a little experience of that unit. This is the surgeon did this, and he left it. Is it okay?
Yes, sir. It's okay.
The delegate should know that this is going to be a two-stage procedure.
Correct. So since you don't have augment all these things you have planned, this is the situation given only the head is left out. It's better to reconstruct the acetabulum with the head and the cup, do a multiple screws, let the bone to get incorporated solid. Then taking the load bypass, you're just taking out the neck. Now the entire integration happens to the cup. Once the foundation is stable, then you can come back and put the stem inside here.
Okay. Kelly, do you agree a two-stage procedure for such a patient, or you will do the single stage? Single stage.
I prefer to do it in a single stage.
Single stage. Anyhow, go ahead.
This case we just tried to do single stage. My intention was to get the cup on its position. The teardrop, you could see it has been pulled down, and with the bone grafts, the stability of the acetabular fixation was really good on table. I was very confident. Even I tried to put the primary implant. The patient was very clear. He didn't want the osteotomy. So I explained him subtrachenteric osteotomy, but he was absolutely clear I didn't want it. I felt with lots of soft tissues, the fibrosis, the surgery, 2 surgeries, previous surgeries, and a gap of 10 years. The patient was limping with a 6-7 centimeter of shortening for 10 years. So on table I tried Cohn Wagner, I had all the implants, but the thing is nothing was going. I was not able to reduce it. So what I did was, did extensive soft tissue releases, went ahead and put a skeletal traction for 1 month, tried it, then was able to achieve further. But yes, definitely I have accepted 2 centimeters shortening, and this is the final picture. Patient is comfortable walking around, and 2 centimeter shortening is still present. So
these are some couple of papers. Go ahead. Okay. Actually, this is I had just added my case to make it more interactive. So this is that you look at the CT and other thing posterior. So you have to put this graft and bring the normal center of rotation. And just last case, Ramnik's case, I told you, putting the screws in the direction of the sacroiliac. And if you have autograft, they do extremely well. That is one of the important things. Thank you. Thank you for all the faculty and all the presenters. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Sanjay Agarwala, sir, for presenting his talk on transforming AVN, the medical solution to a surgical challenge.
Thank you. So I think we have seen a large number of cases of AVN in the last 4 or 5 years. Clearly, with 140 crore people, if you just look at percentages, we should be seeing a lot of AVN, but I think COVID has really changed what has happened. And essentially, when you talk about bisphosphonates, which I will be speaking about, it is repurposing the bisphosphonate drugs. These are the process of finding new therapeutic uses for existing drugs. And we've seen repurposed drugs all our lives. I grew up on aspirin. We didn't have paracetamol when I was a kid. Chloroquine, used for malaria, 4 stat, 2 after 6 hours, 1 BD for 2 days. Malaria used to get cured, but you know that chloroquine is used even for rheumatoid arthritis. The doses and the durations are different. So all repurposed drugs are safe, but the dosage and the duration is different. And bisphosphonates have approved uses for all these conditions. You may have treated these kind of cases earlier, but I have repurposed bisphosphonates for these 8 conditions. Not only avascular necrosis, but also transient osteoporosis and all these 8 things which are mentioned here on this list. In fact, one study that got published in 2021 was the paradigm shift in osteonecrosis treatment with bisphosphonates. This was a 20-year study, and I think it's very difficult for orthopedic surgeons to clearly publish something like this. So I have this kind of experience, and now it's 25, so I have another 4 or 5 years of experience. And we recognized that a large number of patients were getting post-COVID osteonecrosis, and for which no other treatment was being offered other than drilling, which doesn't work, replacements, which is very severe sometimes, and I am a surgeon. Surgery is what runs my household, but we had bisphosphonates to offer these patients. And these are the series of papers that I have, starting from 2001, on the use of bisphosphonates in these various conditions. And this is the natural history of AVN. You get collapse of the femoral head at 3 years in 75% of cases. Untreated, good results are only 25%. And major surgical procedures occur within 3 years, and more than 50% require a THR within 3 years. And now all of us who are practicing surgeons know this. And I've quoted Mont, I've quoted Merle de Bunier. In cerebral stroke and myocardial infarction, there is an acute event. The treatment principle is revascularization. In avascular necrosis of the bone, the diagnosis is late. It is so late that you cannot think of revascularization, and therefore giving aspirin and things like that for AVN does not seem to be the right thing to do. All these drugs have been described, but you have not heard of them because effectively these did not work. So there has been no benefit. And core decompression, the results have been inconsistent and variable. And this is taken from literature. You have Mont, you have Ficat, all these talking about very poor results when they did this surgical procedure. So there's no added advantage of surgery over the natural history of AVN. And this is the pathophysiology. There is critical ischemia, followed by necrosis. And bisphosphonates work as both an anti-inflammatory and anti-osteoclastic. And this is what helps in your patients when you start this kind of treatment, preventing collapse and also help neoosteogenesis. In the JBJS 2021 and subsequent papers, this is the degree of success with my regimen of bisphosphonate. And if you don't remember what it is, you just go to ChatGPT and say Sanjay Agarwala regimen for bisphosphonates and you will get it. We've had no cases of atypical fractures or osteonecrosis when we use it in my doses. The treatment protocol is 3 years. We give small and frequent dosages of alendronate because that is absorbed better. Calcium and vitamin D is required, otherwise it doesn't work. And our rationale is that the IV zoledronic acid gives you early pain relief and early blood levels, whereas the oral alendronate prevents collapse. And the rationale is 2 drugs because it has been shown that in rat animals, if you wanted resorption of necrotic bone to be prevented, you needed doses which were 4 to 50 times higher than for osteoporosis. So this is the natural history of AVN and the established safety of bisphosphonates. So we'll just show you a couple of cases. At 0, 3 years, 12 years, patient can then sit and use his leg normally. And the management of avian, I think the chapter has been rewritten. We've used it in transient osteoporosis of the hip. Clearly here it works faster than for avian. We've used it for spontaneous osteonecrosis of the knee. It has worked. We've used avian post-leukemia. Here you have very young children who will be suffering from this. And I showed you this yesterday. Here you have a patient at 21 years. You wouldn't have offered him a hip replacement, and nor would you ask him to be a cripple. So the avascular necrosis, other than hip, is also where it works in talus, it works in scaphoid, it works in lunate, and we've published all this data, post-COVID avian, as you're aware, published in the BMJ, no less, and in the JBJS, which I think for orthopedic surgeons is a big thing. We've seen post-COVID SPONK and post-COVID TOH. Again, the drug works. The duration of treatment is 3 years for these first 3 conditions. Other than hip, shorter period of time, and in these, which are 5, 6, 7, and 8, 3 to 6 months works. The treatment protocol, as I said earlier, and if you don't have it, go to ChatGPT or Google, and I think there has been a paradigm shift in osteonecrosis treatment with bisphosphonates, and I think if I can offer this to a young boy rather than a hip replacement is the way to go. Thank you very much.
Thank you, sir. Any questions? Thank you. Moving on for the next segment is periprosthetic joint infection. I would like to invite Dr. Ashok Rajgopal sir on the podium for his presentation on the evidence-based consensus of PJI.
Thank you. This is really an abstract of the recent ICM guidelines that came out in Istanbul. So this is really, we had 92 questions, and I'm going to quickly run through some of them. It's not going forward. Right, so we've had various iterations of the MSIS, the 2011 that defined the denominations of a sinus tract and a certain number of defined major and minor criteria. Then we had the 2013, and they had 2 major or 3 or 5 minor criteria, which were diagnostic, sinus tract being the constant. 2018, so they improved on that major criteria, and the minor criteria gave points. Anything more than 6 was infected, 2 to 5 were possibly infected, and 0 to 1 was not infected. So what was the relevance? It improved over time, both in terms of sensitivity and specificity. So here are some of the questions. In doubtful cases of periprosthetic joint infection, what is the best test? And the report, 66.5, you can see there was a pretty low percentage, leukocyte esterase, synovial fluid analysis, and frozen section. Is there a role for joint-specific cutoffs? No justification for establishing separate cutoffs or thresholds for serological tests. So unlike the earlier iterations, this had a pretty strong strength of recommendation. Which serological tests should be obtained? C-reactive protein and ESR. So you can see, in spite of all the development that's happened over the last almost 20 years, we still go back to the CRP and the ESR. When you look at, is there any role for fibrinogen D-dimers, the answer is yes. The D-dimer is recognized for its sensitivity, but again, if you see the strength of recommendation, it's only 66.5%. The accuracy of synovial biomarkers and serum biomarkers. Synovial biomarkers such as synovial WBC and molecular markers offer greater diagnostic. 80%. Our cutoff threshold was 80%. Is there a role for joint-specific cutoffs based on the literature? The current criteria is CRP greater than 10, ESR greater than 30 are appropriate for use in both PGI of the hip and the knee. Should joint aspirations be done? Absolutely, that should be done in all cases. Should saline be injected for a dry tap? A routine installation cannot be recommended. When taking the cultures, how many samples should be taken? And this is a very important criteria. It's recommended to have at least 4 to 5 samples for each particular individual. What is the optimal duration of holding the cultures? 14 days if you're suspecting fungal or mycobacterium, it should be 4 to 6 weeks. Strong strength of recommendation. Optimal duration of holding cultures, patients are undergoing revisions. For patients with this criteria, the incubation period should be extended to 14 days to enhance the detection of low virulence organism, very high recommendation. And should intraoperative cultures be taken, samples should be taken in all cases of revision, even if they are aseptic. And again, a very strong strength of recommendation. Is there a role for established diagnostic protocol, algorithm, strength of recommendation? Yes, it is. Is there a role for histopath? Histopath for deep tissues can be a useful confirmatory for diagnosis, particularly in seronegative. Again, a very strong recommendation. What are the thresholds for neutrophils? Greater than 5 per high power field is recommended to differentiate septic from aseptic. Recommendation strength 94%. Is there a role for using molecular techniques? Yes, there is. Again, very high recommendation for particularly in culture negative. Is there a role for neutrophil lymphocyte, monocyte to lymphocyte ratio? Again, yes, there is a strong recommendation. What imaging has the best available ability to diagnose osteomyelitis? All modalities are useful, though the role of WBC scintigraphy is somewhat diminished. Is there a role for bone scan? Strength of recommendation is 75%. They do not recommend bone scans. Role for MRI, again, has limited utility. Is there a role for CT scans? Yes, particularly for diagnosis of periprosthetic joint infection. Strength of recommendation is 92.6%. Aspiration should be done in primary cases, but not prior to reimplantation. What metrics are used? Serological and synovial markers cannot be relied upon. So you look at diminishing D-dimers, synovial fluids, and strength of recommendation again is very, very high. Do the thresholds for serum and synovial tests used apply for reimplantation? They do not. So you go more for clinical situations rather than bio studies. What candidates are candidates for DARE? Again, gray area, but infection done early with an onset of symptoms less than 7 days. Acute postoperative periprosthetic joints, early intervention and for performing one-stage exchange arthroplasty. Who should have DARE is an acceptable procedure, particularly in acute PGI. However, on average, it has almost a 40% failure rate in this population, particularly in infections with Staph aureus. What is the optimal surgical protocol for performing debridement? Should be done early and whenever possible combined with extended systemic antibiotics. Modular should be changed, absolutely recommended whenever feasible. Does the DARE influence the outcome of subsequent exchange? Again, gray area. Prior DARE may increase the likelihood of failure, but the recommendation strength is only 70%. Does the type of infection influence outcomes? Yes. Type of infection does influence. Are there any absolute contraindications? No, we do not feel there's any absolute contraindication to one-stage exchange arthroplasty. Can it be performed in culture negative? Yes, there is evidence, though the strength was only 76%. Should collaterals be removed? This is again a lot of debates around this. Evidence indicates that single stage using hinged implants gave good outcomes. How long should antibiotics be continued? Should be continued enough to maintain levels above the minimum MIC levels for at least 8 to 12 weeks. Is there a difference in success of two-stage extended static versus articulating spacers? Yes. They recommended articulating spacers as better functional outcomes. Is the role for 1.5 does not show inferior results, so you may consider it. What are the indications for exchange of cement spacers, particularly in patients where both the surgeon and patient should be aware of the lower rate of eradication, again 80%, just about the threshold. What is the ideal optimal antibiotic? This is one of the works that me and my group worked on. This is cephalosporins, particularly cefazolin. And you can see there's almost complete consensus on this 98.3%. Recommended duration should be given. One perioperative antibiotic should be sufficient for patients undergoing outpatient arthroplasty. Is there a role for extended antibiotics? Insufficient evidence, 94.8%. Is there a role for intraosseous? Yes, increasingly, particularly in these patients, the role of intraosseous antibiotics, particularly vancomycin, is strongly recommended, though there was consensus of strength was very, very low in this. What is the optimal duration for antimicrobials? Again, this was quite debated, and this was particularly seronegative, culture negative. A combination of glycopeptide and gram-positive antibiotic, and what's the optimal duration? A minimum of 12 weeks is recommended for patients undergoing debridement. Again, a low consensus. What's the optimal duration of antimicrobial treatment for patients undergoing single stage? At least 6 weeks is recommended. Finally, what is the optimal duration of antimicrobial between stages is unknown. You would rely more on clinical guidelines and lab values. Is there a role for 2-week antibiotic holiday? There's no conclusive evidence that 2 weeks of antibiotic holiday improves the outcomes, and very strong strength of recommendation. I'd like to thank you for your kind attention.
Thank you, sir. Any question from the faculty? Moving on, our next topic on the periprosthetic joint infection is surgeon's role in improving culture yield in periprosthetic joint infection. I would like to invite Dr. Adit Menon sir on the podium.
Thank you. Thank you, Ortho Trends, the organizing team, for having me here. It's a different talk. Generally, this talk would be taken by microbiologists, because the question is, do we as surgeons have a role in improving our culture yields? Basically, do we find a pathogen in the reports, or do we get a no growth? The answer for that is, generally, we don't play a role. That's the general consensus. It's on the lab. It's a difficult bug. We really don't have much hold in that. And more often than that, the answer that I get is, maybe we may have a role, but I don't know. So my brief is to try and convince you to convert yourself from a no to a maybe, and if possible, to an absolute yes, that yes, we can control the outcome of that culture report. So let's go through some scenarios. This is an early PJI. Frankly infected, was not on antibiotics, multiple samples taken. I'm not going to go into the surgical details. And cultures grew one of these, and targeted antibiotics were given, and patient did well. We were happy as surgeons, and this is an ideal scenario. You've got the bug, you've given the antibiotics, and patient has done well. But more often than not, what we see is, in spite of being frankly infected, we don't get anything on the culture reports. We've sent multiple samples, but we don't get anything. Is there anything else that we can do as surgeons? Yes. Don't forget the fluid, the synovial fluid. It's been stressed upon earlier as well. Don't send it just in containers, send it in blood culture bottles. You can ask the microbiology department to send you these bottles beforehand, so it's available. They come in various forms, aerobic, anaerobic, microfluidic, and they have a culture medium. In short, it's like a micro lab on wheels. The minute you get that fluid, just inoculate it in the operating room. This is not a sterile bottle, so it's kept outside. You've got to pass the sample out of your table, and that's inoculated, and the bugs are already growing. So it's not just synovial fluid. You get any deep collection, a deep hematoma around the joint, aspirate it, and the minute you remove the cover of the blood culture bottle, ensure your staff has cleaned it with an alcohol preparation, because that rubber cork is not absolutely sterile. So you don't want to push in a pathogen which may be a contaminant over there. So you don't want a false report. So clean it, aspirate, and put it inside, and that's your bug growing there already, and that's really helped us improve a culture yield. Let's look at another scenario, very common. Patient has frank infection, but on multiple antibiotics in an early case. You can't wait for long, you've got to operate early. So use an advanced form of these blood culture bottles, that's blood culture plus bottles. So they have some resins, they inhibit the antibiotics, and again, come in handy. But there are scenarios that in spite of that, you may get some negative cultures. Use molecular diagnostics, and that's at our disposal very easily now in the main centers, in the main cities. We started using the BioFire GI panel or the joint infection panel. Use it in, get the fluid, send it in sterile containers, send it to the lab. All you need is 0.2 cc, not more than that. It's used in septic arthritis in native joints and PGIs, and covers almost all of the common bugs that we see in India. Going to another scenario, which is slightly different from what I've shown. So this is a chronic infection going on for many months to years, has a sinus, probably taken the entire pharmacy till now, and is still on antibiotics when that patient comes to us. So this would be our first reaction when the patient comes to the OPD. Take a swab, rub it into that sinus deep in, and send it to the laboratory. I'm going to make a controversial, maybe a bold statement, which may not be liked by some here, that there's only one place for that swab stick in the operating room or in the OPD, and that's in the bin. Deep aspirations, deep tissue samples are the only thing that will help us get the right bug, and there's enough evidence on this that these swab sticks have no role. Loan it out to your ENT friends if you wish. Next question. Patient on antibiotics is stable. Should we operate immediately? The answer is absolutely no. Wait it out, give an antibiotic-free period for 2 weeks or 3 weeks if possible. Yes, there are exceptions to this scenario, where you have an early infection like we had seen earlier, or patients in sepsis or severe pain. In those scenarios, you can't wait, and you use the tricks that I had shown earlier. Use the blood culture bottles, plus bottles, use the GI panel. But the minute you ask the patient to be off antibiotics, make sure you tell them that they see these red flags, any pain, fever, increasing discharge, they come back and you operate. The idea is to get some antibiotic-free period. Anything is better than nothing. So you push it to 2 weeks, 3 weeks if possible, or go in maybe in a couple of days as well. So this was a patient, chronic PGI, had a failed air on multiple antibiotics. We got a leukocyte PET CT. Now this is being used more frequently at our place with implant-related infection. It surpassed the regular PET CT and the MRI in finding infection around the bone processor interface, and it's very, very specific. So we went in, gave an after 2 weeks of an antibiotic-free period, send multiple samples, and the imaging helps us tell where to get that sample from. There was medullary infection as well, so all of that was scraped out. Put an articulated spacer. On the same day, we got the GI panel saying that this was a highly multi-drug resistant Klebsiella. Same confirmed on the multiple samples that were sent, targeted antibiotics given. So protocol helps improve a culture yield. You've got to make your own protocol. But in spite of sending multiple samples, in spite of asking for an antibiotic-free period in such chronic scenarios, we still end up getting nothing. So my last take-home message is actually the first message. But I've gone reverse for a reason that we find it difficult to ask for help, but this is something that should be done in every infected scenario. Before the patient goes for surgery, the patient must be evaluated by somebody who has a degree other than orthopedics, so a medical specialist, whoever that person is. Because they go into the details, they go into nitty-gritties of the history, they'll help us choose what test to be sent, they will write it down and give it to you. All we have to do is follow it blindly. And what did this patient have? This patient had a non-tuberculous mycobacteria. The therapy is absolutely different. They're tough bugs. They require a combination. Don't forget the histopathology. That also helps us find the granulomas. And in spite of having a targeted therapy, she developed side effects. Therapy wasn't adequate. She went on to have a recurrence. So even after finding an uncommon bug, the answer may not end there. So form your protocol, see what works in your scenario, but ask for help. So ultimately, a protocol that we've implemented for the last 5 years across multiple departments, ID, micro, and orthopedics together. We've managed to push the culture yield to 90%. In the last couple of years, we've hardly had any culture negatives or detected on the GI panel. So coming back to the question of this talk, do we have a role in improving culture yield? I think we do if we choose when to operate, if we can give an antibiotic-free period that helps. If we can choose to send tissue and a fluid adequately, yes, we do have a role. Can we influence the number of tests that we ask for? Yes, by asking for help. And that's the most important thing. Try working as a team in these scenarios. Most other surgeries would be a 1% or 2% job, but PGIs are a teamwork, and we choose to work as a team at Hinduja Hospital. And eventually, if you are able to influence all of those factors, then yes, as a surgeon, we can improve our culture yields. Thank you.
Any question from the audience? Thank you, sir, for such engaging presentation. Moving on, our next talk is Guided by Evidence, Antibiotic Protocols in Arthroplasty. I would like to invite Dr. Arvind Kumar, sir, on the podium.
So greetings from the Department of Medicine, AIMS, New Delhi. But Aditya, highly impressed, at least you gave one slide to internal medicine, an ID physician. Thank you very much for that. So this is something that I always start with, that unnecessary antibiotic kills, and we need to understand this. In my small experience, I can disclose that we need to be now more and more careful while we use antibiotic. So this is not a global epidemiology, but a concern that even if you deal completely right with your culture alignment, you are going to fail in 1/3 of your PGI cases. We need to understand that. So the burden is high. We are seeing patients in our ID clinics where the whole younghood has been gone. Almost from 10 years, he is being managed for PGI, from 25 to 35. So what I need to emphasize is that we need to tackle these cases very, very, precisely. So seeing the microbiological profile, we are more onto, the more and more bugs which we see is gram negative compared to the overall international data, which is gram positive. So based on that, the prophylaxis which is based should be on institutional microbiological profile basis. What we do at AIMS New Delhi is give a MSSA coverage with cefazolin, along with that MRSA coverage vancomycin. But as we are seeing surge, and we might also see a surge of ESBLs, you can simply replace this cephalosporin with carbapenem to tackle down the gram negatives along with MSSA. And this will also cover your MSSA and MRSA. So depending upon this, you need to change your prophylaxis which you are doing in institute. After that, one thing which we always see in the orthopedics prescription is an antibiotic post-surgery for 7 to 10 days. It is highly discouraged, and we have evidence for that. So please don't give antibiotic for after that if everything is fine. So coming to management of PGI, whatever previous two speakers told, it makes me easy to tell this. And just to simplify it, if you have either a strong clinical criteria or a lab criteria, either of this, in which sinus is there, and if you have percolating discharge along with visualized processes, you can confirm that it is an infection. Or you have a cerebral count, amounting to be a TLC of more than 3000, in which neutrophil is more than 80%. Or you have 2 out of 5 culture positive. So either A or B tells you that it is a confirmed infection clinically, and anything less than that is either a likely or an unlikely infection. So based on this, you make a decision that it's a infection, it's a PJI. So whether to just be with synovial aspiration or go for a debridement has to be taken a call by ID physician along with a orthopedician, mostly orthopedician. So once we have decided that it has to be only aspiration or a debridement, based on that, you plan that what kind of antibiotic course you are going to give. Once you are out of this, that means you need to do a stage surgery. That means the infection is of more than 2-3 weeks, or it's a late PGI. Then you come in these lower 4 categories where you need to have a stage surgery, either a 1-stage or a 2-stage surgery interspersed with some duration gaps, either 4 weeks or 8 weeks, depending upon the morbidity and the resistant microorganisms. Based on that, Most of the courses comprises of 1 or 2 weeks of IV antibiotics, and now we have immense data to suggest that you can complete a 3 months or 6 months of antibiotic course with oral antibiotics. So this is, I mean, there enough to suggest that we have data for that. Those patients which cannot be taken for, they would be given a chronic suppressive antibiotic therapy. Those patients where only debridement is being taken and the infection is partially subsided in 3 months, you also need to give a chronic suppressive therapy. So before you go to antibiotics, what is a must for all of us is to understand which antibiotics does well in the bones. So for gram-positive, we have linezolid, rifampicin, and vancomycin. For gram-positive and negative, we have Septran, minocycline, as well as fluoroquinolones. We need to understand the need of biofilm tackling in case of PGI infections. So rifampicin is going to be the mainstay of the treatment, but it cannot be given a monotherapy. So along with that, we need to understand what are the other antibiotics which takes care of biofilm. So you have to combine in case-to-case basis, which is optimal for that patient. So this is something that all internists, practice of escalation in gram-negative, from penicillin to a higher cephalosporin, then to a BLBLIs, then to a carbapenem, and then you go to a higher BLBLIs. Along with BLBLIs, you add some BL to tackle MBL producers, and at the end, you go with polybenzene cholesterol. So this is something we always follow in gram-negative escalation empirically, which all clinicians should know, even that lies true with the PJIs. So what is important for us to understand is that the duration of antibiotic is clear. It's 12 weeks is always superior than 6 weeks, except for a few cases where infective load is less. So this is proven beyond doubt. And besides this, you need in some cases chronic suppressive therapy after even 3 months. So this is something important. So what we do at our center is we start with a gram-positive coverage, either TICO or vancomycin along with a carbapenem. And after 1 or 2 weeks, we need to add rifampicin to take care of your biofilm formation by gram-positive bacteria. Outside, the concern is less, so they go away with third generation cephalosporin along with vancomycin only. So there are many culture negative scenarios where we need to take care of fungal as well as NTM infections. So these things you better know than me, what is the role of pellets or spacer or antibiotic coated pellets. What is important for us to understand is the data, the evidence is not very much robust. What can be told is that it has to be given definitely in a dare kind of surgery where you need to put it and then take it out after some time. You need to take care of the infection load and while you use the other adjuncts of antibiotic cementing and prosthesis. But what evidence say that I am not robust to really say that cementing is a very, at this stage, a very, so what the take home message is that the surgical management requiring chronic bone and joint infection, essential to send multiple intraoperative cultures as told in the previous lecture. Antibiogram has to be tailored as per the reports. One word about BioFAR, early infection, yes indeed it is a very good mode. We do it at our institute and it helps us in gram-negative and early infections. Thank you very much.
Thank you, sir. Any question? For the next talk, I would like to invite Dr. Pranay Gujjar sir on the stage podium. Second stage revision arthroplasty, when to do, when not to do.
Good morning, everyone. So we all know two-stage revision is a gold standard treatment for chronic PJI of hip and knee. In literature, failure rate of two-stage revision is around 20 to 25%, ranging from 0 to 40% in various literature. We have very limited treatment option after failed second stage, and they have poor outcome and high mortality. You can see in both the papers, failure rate is around 20 to 25% after second stage. That means only 7 or 10 out of 10 have infection control after second stage. PGI surgeons across the world are trying to get this failure rate down by ensuring complete eradication of infection before re-implantation. Currently, two principles are practiced. One is conventional with antibiotic holiday, and one is more aggressive without antibiotic holiday. ICM 2025, as Rajgopal sir mentioned, there is no role of routine antibiotic holiday in the treatment of PJI managed with a two-stage exchange. In our institute, we follow more conventional approach with antibiotic holidays of minimal 2 weeks and ensuring clearance of infection by blood, synovial markers and cultures before we go for reimplantation. We do serum, CBC, ESR, CRP, synovial fluid total count, PMN count, culture and biofire if required. It is very easy to decide when markers are beyond normal range on either side. In cases where synovial fluid markers are increased but not in infection range, we can wait for a few weeks and repeat the aspiration. In case of pre-op dry tap, we can take intraoperative sampling, synovial fluid analysis of or routine micro. It is very important to take proper informed consent in such cases. So in our setup, we have a lab inside the hospital only. Usually when in doubt, we send samples intra-op and we get answer of our synovial fluid routine micro within few minutes. As we see in ICM 2025 consensus, D-dimer is one of the markers can be used to check for the persistence of infection. However, we don't use this routinely in our institute. Despite of all the efforts to ensure the infection clearance, we still fail in around 20 to 25% cases. The failure can be a recurrence, it can be a de novo recurrence, or it can be a mechanical failure. Factors described for failure of second stage are nearly similar across all major literature and are on similar line. They are a compromised host, a difficult to treat organism, number of previous surgeries, and compromised local condition. There is a need of an objective guideline or a scoring system that helps the surgeon to predict the failure of two-stage revision and helps to make an informed decision to offer alternative surgical procedure early in the course of treatment. So we designed a scoring system after multiple pilot projects at our institute to predict the outcome of second stage revision. This score includes 4 objectives. They are number of previous surgeries, score increases with number of surgery, skin condition, skin healed with scarring and skin grafting were given higher number score compared to skin healed with flap. Comorbidities, modifiable risk factors were given lower score, while non-modifiable risk factors like chronic kidney disease, chronic liver disease, recurrent cellulitis of seam limb were given a higher score. In microbiology, resistant Staph aureus, ESBL and CR gram-negative bacilli, non-tuberculous mycobacteria, fungus, polymicrobial infection were given higher scores. Carbapenem-resistant gram-negative bacilli group and polymicrobial infection had poor clinical outcome. If we see the results, in our study, we had total 57 patients. In category 1, it was a low risk of failure. We did total 42 knees. Out of those 42 knees, we had only 2 failures, and the infection clearance rate was around 95%. If we go on category 3, where the score was very high, out of 8 knees, we performed arthrodesis in all those 8 knees. There was no recurrence of infection. So we can say infection clearance was around 100%. In category 2, where there is an intermittent risk category, we did second stage procedure in 4 patients and arthrodesis in 3 patients. So out of those 4 patients, we had failure in around 3 patients for second stage revision. So overall infection clearance rate was 57% and 75% for second stage. So no mortality or limb loss noted in our patients. So why we are talking about alternative procedures? In one of the most recent articles of JOA, it has mentioned that infection controlled after failed second stage was around 20%. So only 2 out of 10 with 30% mortality. We believe that offering an alternative option to patients at high risk of failure, we can reduce the failure rate and get better infection clearance than reimplantation if required. So to take home message is, 2-stage revision is still a preferred treatment choice for chronic PGI cases with good success rate. Pre-implantation investigations can help to confirm the infection clearance. However, they do not predict the recurrence. Difficult to treat organisms, compromised host with multiple previous procedures can be offered an alternative to second stage during early course of treatment. So we can go through this case. This is one of the case which had primary surgery followed by a spacer exchange, skin healed with primary scarring, no comorbidity, and organism was, according to us, it's a low virulent MRAC. So total score falls in a low risk group. We went ahead with a second stage revision. In the next case, this was a patient with multiple prior surgeries like primary plus debridement, followed by second stage. Skin healed with grafting. Patient had chronic kidney disease, and patient has carbapenem resistant Pseudomonas infection. So total scoring is falling in high risk category, which is 55. So rather than offering a two-stage revision in such patients, offering an early arthrodesis can prevent the failure of second stage. Thank you.
Thank you, sir, for such comprehensive talk. Moving on, our next talk is periprosthetic joint infection hip, excision or spacers, my preferences. I would like to invite Dr. Ramneek Mahajan, sir.
My laptop. Okay. Good morning, everybody. Thank you, Dr. Pachore, and everybody, sir, for having me here. So when I thought, what am I going to speak here, when I saw it for the first time? So PGI, we all know, we've been hearing, it's a surgeon's nightmare. You get it, and you are scared. What are you going to do? They come in all shapes, all fashions, and you'll have them there in your OPD, and then you are thinking. 1 to 2% of all your primaries will get infected, and by 2030, $1.85 billion would be the cost of hip and knee PGI. Kyle, you are lucky enough to be there. So 2-stage is the gold standard historically, and 20% is the failure rate we just heard. So how to manage your PGIs? Long-term suppressive antibiotics. Acute stage, you do a DARE. Resection, arthroplasty, a single stage revision, and a 2-stage revision comes as gold standard. But if you're early, you're on time. If you're on time, you're still late. So what is resection? Problem with resection, I feel, it causes true shortening. There is more scarring. Length is then difficult to achieve later. Instability of hip, and it's a difficult revision. I'm not saying it is impossible, but it is still difficult. Look at this patient, a 43-year-old male who came to us, got a resection somewhere, and now he wanted a second stage surgery. It was tough, we managed. Look at all these criteria that we have to go through this patient. We did a subtrochanteric osteotomy, got him down, and had a cage on top. So he went on to do well, but definitely it was a challenge. Another 26-year-old male, 1, he got a hip, 2, he was HIV positive, 3, he got a dislocation, 4, he gets a resection, 5th, there was a proximal femur fracture, and the surgeon just left it alone. Then I inherit the case. So what do I do? Again, got everything out, got him back, and look at what I did as well. The shortest possible stem with the bow that the femur had was hitting the cortex, so I went out, plated it so that I don't want a fracture. So what is a spacer then? Spacer maintains tissue tension. It maintains the length. You can give local high concentration antibiotics, maintain the soft tissue planes. Your mobility in the interim period can be achieved, and in unfit patients, you can continue with these as well. I'll just show you. So you do an aggressive debridement, put in a spacer, give your antibiotics in whatever dosage that we've just heard. A drug-free interval I always follow. Then I remove the spacer and reimplantation. So what are the types of spacers? Cement can be used as a spacer. We just showed you. A cement mold is available to assemble this prosthesis. You can put, I'll just show you how. Then custom-made articulating spacers are available, like Kumar's or the Kiwi technique, customizable, and of course standard implants can be used as spacers. Then there is Prostelac, where a prosthesis of antibiotic-loaded acrylic cement can be put in. Problem with Prostolac, selective regions, the availability, limited sizes, and customization options. So what are choice of spacers? A static or a temporary, which is a non-articulating type of spacer. We have a dynamic and articulating spacer. So what you choose when you choose a spacer? What are your goals? What are you looking for? You're managing a bone loss, a soft tissue condition, a need for joint movement, availability of prefabricated, and the choice of antibiotics. So this is where actually you can play around with. Like increased surface area and a higher drug elution is possible with a static or a non-articulating spacer. Used when major bone loss or tissue loss is there. It helps in the healing. Problem becomes the soft tissue contractures and the disuse osteopenia and the chances of dislocation. Articular spacers, they allow you ambulation, maintain the soft tissue tension. There is less arthropibrosis. It actually facilitates a smoother second stage and less chances of dislocation. Problems in the ready-made ones is the limited sizes, doubtful delivery of the drugs. If you are ready-made, the only good thing about them is they are easier. You just open a box, fill it, shut it. But it is difficult to forget it. If you make it on table, they're costly. But if you make it on table locally with the things that we have available in India, we are all make in India, we get everything available. It is quick, cheap, but it is very difficult to match the size with these. Then that becomes the problem. So antibiotic, these are antibiotic loaded spacers. If you see the image, these are the kind of blocks that are available with us. We just pack them with cement, put an endoskeleton with like a K-wire or anything, or SS wire or a rush nail, put them inside. Use a heat stable broad spectrum antibiotic. You can give higher concentration. There is no systemic toxicity. And Palacos becomes my choice of cement because of its high elution, high porosity, and easy molding. This is one, I'm just finishing after a couple of minutes. So this is where the custom available implant, you can put it in. This is again one of the cases. A 54-year-old female with a bipolar. That's what we made, handmade. And this is the ease. Whenever you put all these cements, the ease is that you just knock off the shoulder. You have put it in, somebody can just hold it, and most of the times you're just able to pull it out. That is how easy it becomes. This is, and then the patient gets a revision. These are silicone molds, I don't have them available. This is how you can see the endoskeleton. I just cut it open from the inferior side just to see that the endoskeleton still remains there, cement is well molded. This is one of the young boy, got a hip, got a fracture, got a improper fixation of the fracture, landed up with infection, and I inherited the case. And so, this is what we did. A K-nail, bent the K-nail, long nail inside, like a masala nail, went in, and we actually bypassed. And this is where we ended up. And then after this, a secondary revision was done on this patient. So Kumars, the articulating spacers. This is what I prefer, a kiwi technique. I just use a stem off the table, whatever stem you have, I use my Exeter, cemented cup, do a poor cementation, but it is very easy to extract and it gives you all benefit of an articulating. That is the kiwi technique, a poor cementation, you can just pull them stem out later and you can just take the cup out later. The benefits, this actually helps you in mobility and it prevents all the problems that you can associate along with subsidence and unplanned reoperations. Actually, it helps. Antibiotic elution peaks within few hours, finishes by 4 weeks based on the type of cement that you use, and of course superficial antibiotic coating. So when we mix the cement, you first mix the cement, then you put the powder in so that you have more of surface coating of the cement, of the antibiotic. And this is a slide which I just picked up. So all the antibiotics, the only thing that I want to understand, make you people understand in all the international papers that we hear, and people pick up tobramycin from that paper. In India, we cannot use tobramycin because we don't have the powdered form of tobramycin. The liquid form of tobramycin is not heat stable, it is heat labile. And powdered form, we don't have it available in India. Now preferred combination, this is what is, I prefer 2.4 gram of tobramycin with 1 gram of vancomycin is what I picked up from the literature. I've just taken away the tobramycin, added more of vancomycin into it, and I can just go ahead and do my packet. This is, I'm not going much into the detail, but the good thing is, when do I go ahead and re-implant? When it is a persistent infection, a wound has some issues, a draining sinus, a mechanical failure, you can wash, pull out, and re-implant inside. Duration, I've just mentioned, but the problems. A spacer can dislocate, a spacer can have a fracture, A patient can migrate, patient can have persistence of infection, and of course recurrence is possible. This is one of the picture I picked up from a book. I still have not seen it. A migration into the pelvis. Sir, you wouldn't have seen it. That's a spacer fracture. And these are the complications of dislocations and fracture. This is one of the patients that I got a DHS which got infected. That's a bipolar used as a spacer. Another patient with an AMP got infected, again a bipolar with like a spacer. You can see there was very poor cementation there. So this is 67-year-old female. This is how I inherited her. She was operated, revised, and then I inherited this lady infection. And this is where I used out-of-the-box thinking. I put in a small mesh inside. Mesh acted as my anti-protrusio there. After absolute debridement, packed it the same way with a spacer inside, loosely, poorly cemented. This is at 8-month follow-up when she came back for a revision. And then she was revised, and I bypassed the stem with a plate because she was very short-statured. So I had to give her a support. A 70-year-old male doctor, again, the good thing, this is a 2-year follow-up. If they are so happy with the spacers, they somehow just don't come back. This is a picture which I got from his house yesterday. I called him up. I said, at least send me your photograph if you don't want a surgery. So he sent me this video yesterday. Another patient which was at infected THR, operated 5 times with multiple discharging sinuses and HIV positive. This is the benefit of these spacers that I feel. We removed everything, did an ETO, put a spacer, a long stem, very thinly made, 8-month post-operative, ETO healed, doing well. And this was when he came back after 8 months. He was so happy with no sinuses. This was his gait. We expect that after 5 surgeries. But he wanted a second surgery now, and I was very happy. I went ahead, operated, and used a constraint only because this was the 6th surgery in his life. So another one, so I will not go much. So this is actually a very interesting surgery if you really pick it well. Thank you so much.
Thank you, sir. Any question? Thank you so much. Moving on, the next segment, I would like to invite Dr. Ravi Kumar on the podium to present his topic, Advancing PJI Care, Latest Diagnostic and Treatment Strategies.
Thank you, Ortho Trends, for the opportunity. As all of us know, the PGI is emerging even in India in multiple ways. So presently, the India needs its own consensus than what we are following from others. So when you take the staggering statistics, so we know that around 5% of the failed orthoplasties are due to infection in the hip and 25% in the knee. So we take the mortality rate of 5 years, it's anything higher than any of the common cancers. The economical burden is substantial. We need to quantify that as well. So when you dissect between 2018 consensus and 2025 consensus, 2018 consensus focused more on diagnosis and its sensitivity with 2 major criteria and 9 minor criteria, whereas 2025 focused more on biofilm degradation, biofilm eradication, biofilm targeting medicines, biofilm targeting instruments, biofilm targeting monoclonal antibodies. So with this, what is emerging as a biomarkers and sensors is multiomics and profiling, so which may come in the future in India as well. It will definitely differentiate between aseptic and septic loosening. The most promising synovial marker is synovial calprotectin. So it is available in India as well. I Googled it. It's available in one of the labs in Pune. So it is more sensitive to leukocyte test. It is easily available, 15 to 20 minutes intraoperative test. And as there is alpha definition availability is not so much good in India, so this can be a greater test for the intraoperative test. What is futurist tools? Futurist tools will be in PGI will be more non-invasive. So it is real-time intra-articular pH sensors have come. The X-ray based chemical imaging has come, and urinary peptide biomarkers. So we are heading towards non-invasive techniques. So of course there is availability of piezoelectric scalpel. As I was talking about biofilm eradication, what is the role of the surgeon? The role of the surgeon is to eradicate the biofilm in every way, like debridement using piezoelectric scalpel, which is available in India as well. It's around 5 to 6 lakhs, but it is worthwhile to invest. So coming back to the cultures remains the indispensable gold standard. Why? Because This is the only test which can give antimicrobial susceptibility, and it is highly specific, and also it is easily available. So, but there are definitely cons. So cons are, turnover time is 14 days. We have to wait till 14 days. Highly susceptible for prior antibiotic usage, which was told by Pranay recently. And culture negatives are humongous because of the inadequate inoculation, improper culture methods. So since 2018, in our center, we started doing sonication. Sonication is nothing but we take the metal the implants and send for sonication, which will extract the biofilm and helps for yield, like the better yield or better sensitivity. With this, our culture growth, which was 2018 before was around 60%, has grown up to 90% now. So it is an amazing method, easily available in any of the multi-speciality hospitals, in a microbiological centers, can be used for Indian scenario as well. So increased yield, and it's highly reliable, but it's I mean especially useful for molecular test. But of course, the medicinal chemicals what we use to dislodge the biofilm will affect the gram-positive cocci. We have to keep in mind. Coming to the PCR, there's a lot of talk about biofire. Yes, of course, it is very useful. It can detect 31 specific bacteria and 8 antimicrobial resistances. But the problem is, India, we are famous in growing the superbugs because of the irrational antibiotic therapies. These 31, presently what we are growing, the bugs may not fall in this panel. If they don't fall in this panel, so we are at toss, and it's very expensive as well. So unmatched speed is the advantage, 100% unmatched speed, and I feel the biofire is very useful when the patient with septicemia, the patient comes to your hospital with a prosthetic joint infection, patient is in septicemia, there is no time to do other tests. So biofire can be used to differentiate whether it is a bacterial infection or a fungal infection, and at least we get an idea what antibiotic to be started. So, and it excludes Staphylococcus epidermidis and Cutibacterium, which are the major part of the prosthetic infection in India. Coming to the next gen sequencing, it is an amazing test which covers everything under the sun for prosthetic joint infection. Expensive but available in majority of the metro cities. But unfortunately, a lot of false positive. It detects the dead DNA, and you should take it very cautiously. I think its use is only in culture negative. So speed is once again 24 to 48 hours. Odds ratio is highest among the molecular methods what we are using. Once again, artificial intelligence gives AST, that is antibiotic sensitivity. There is no antibiotic sensitivity as per the NGS. So now the main agenda of 2025 is biofilm eradication. It should be aggressive debridement. It should be like biofilm targeted medicines like rifampicin and synergetic antibiotics like daptomycin and fosfomycin, which can kill the biofilm and help us for preventing the infection. So when we go, the summary of advances from empiric consensus, what were there, now we are heading towards personalized strategies. Why personalized strategies? I will be telling with an example. So our future research should be validation of the future test and also the cost-effective analysis in a country like India, and also it should be targeted studies and should be combinational therapies other than single therapies. So let's go by this example. 72-year gentleman operated somewhere, bilateral TKR, comes with the right side repeated effusions, no history of fever, chills or trauma, and he's been multiple aspirations were done and no cultures, and there was no growth till he reached to the hospital, and he had a painful restriction. Then we thought like we'll open up and see the joint. So as soon as you open the joint, you can see there is a huge gush of blood coming out. Even after 1 year of the surgery, there was fresh blood. So we thought there might be some issues. When you go into his biochemistry, CRP was normal, total count was okay, ESR was within normal. Then we sent a fibrinogen of 290. The first time we grew the organism that is called as Rossoltinia picatia. So now the problem was huge. There was because it is a infection-induced hemophilia. That's called as acquired hemophilia. Acquired hemophilia, there are two types, hemophilia type A, type B. Type B is like only hemophilia and local, like wherever foreign bodies are. So, and I went in literature research, there is no study in the world which is published, which calls acquired hemophilia. So this, probably this will be our first case to publish in the world's literature. So that's why we need a personalized therapy. So another gentleman, 72-year-old, multiple comorbidities. It's our own case. We did bilateral TKR. 6 weeks later, he comes with sinus. We did a DIAR, and DIAR he was doing well. And then once again infected. We debrided, put a 2-stage with a 2 months gap. 1 month of the second phase, he came in septicemia. Till now, he was not grown any organism. In this case, biofire helped us to differentiate between Staphylococcus hominis and Candida. So, and we started combination therapy, and he survived, finally fused his joint because of the so many issues. Third case, 65-year-old, TKR done one year ago elsewhere, multiple aspirations bent, no cultures grown. I also aspirated before surgery, I also not able to grow any organism. Intraoperatively I sent the deep cultures, especially we sent tissues, fluids, and implant for sonification. In the sonification, we grew organism called as Aeromonas sorbia, so which we treated with proper antibiotics and spacer. And finally, we were able to achieve the infection eradication. And she came with a broken spacer 1 year later and revised. She is successfully doing very well. So in SPARSH protocol is we divide the sample into synovial fluid, synovial tissue, implant for sonification, and we keep a reserve sample for PCR if we are not able to grow any organism in first 5 days. So we sent for aerobic, anaerobic, intraoperative inoculation, fungal cultures, TB gene expert for every case. And integrated algorithm used to do all the three sections and come for a diagnosis. My take-home message will be it's a multidisciplinary approach. Even though there are multiple people involved, you are the team leader. It's your baby, you have to take care. Final decision should be based on surgeon with a combination of additional information. We should make every attempt to grow the bug despite of whatever difficulties we have. Culture still an indispensable gold standard, we should rely on that. Biofire in culture negative when report is needed in ours, especially in septicemia. NGS, it definitely helps for large spectrum coverage. There are a lot of false positives, we should be aware of it. So Indian consensus is the need of the hour. We should, as a country, we should produce a gold standard Indian consensus which will help for our patient. Thank you one and all.
Thank you, sir.
Any questions?
Thank you so much. For the next, we have case-based discussion on periprosthetic joint inspection. I would like to invite Dr. Kaustuv Belapurkar, and for the moderation, I would like to invite Dr. Pranay Gujjar, sir. On the panelist section, we have, I would like to invite Dr. Arvind Kumar, Dr. Aditya Menon, Dr. Ramnik Mahajan, sir, Dr. Kyle McGivan, and Dr. Ravi Kumar.
This is our case, a 64-year-old.
Okay.
Yeah. So this is our case, a 64-year-old male who had underwent a right TKR 6 months back. He was recovering well, no complaints post-operatively, presented to us with complaints of pain and fever since past 3 days only. On examination, there was some local rise of temperature, there was effusion, ROM was painful and restricted. These were the clinical photos.
Next.
These were his labs and radiographs. How should we proceed now?
So show the labs. Okay. So Adi bhai, patient was operated 6 months back, presented with acute episode of PJI, looks like CRP is 199. So next. Okay. So wait here. So as just you mentioned, we'll be aspirating. So what all tests you would like to send here?
So to start with the simplest, you keep an EDTA and plain bulb. Don't forget the synovial fluid analysis. That would be the first. Along with that, you keep the blood culture bottles ready. Also send, if there's enough synovial fluid, I mean even half a cc, 1 cc in each bottle is enough. You would also send fluid in an extra sterile container for if they want JI panel, if that's available, or any additional mycobacterial test. Generally, this would be pyogenic, but you want to send an extra sample in case pyogenic is negative and you want to do extra testing. So
you always want send the samples in BACTEC bottles, right?
If there's enough fluid and these bottles are available, yes. Or you can send it in sterile containers and convey to the laboratory that assess in the standard method and plate it and culture in the bottles.
So the message is clear. Whenever we are aspirating any synovial fluid, we are suspecting an infection, the samples ideally should be sent in BACTEC bottles. Next.
So this is how we prepare for knee aspiration and send our samples.
So this is what we got. Patient is having a 6 months post-op, well-functioning TKR with acute symptoms, synovial fluid in infective range with methicillin-resistant Staphylococcus aureus, significant growth in 2 samples. I would go to Ramnik sir. Now, how will you proceed with this case?
See,
what should be the plan?
I would be actually taking this patient in. I would be removing all implants and putting in a spacer. 6 months, if it is infected, biofilm is already there. So I would actually not like to do a dare in this case. I would actually like to proceed, and I do good 2-stage, so I'm very clear. I would remove the implant, put in a spacer, follow the protocol, and then come back and do it again.
So it's a first episode in 6 months. Still you consider it as a chronic infection?
I would still consider it as a chronic infection.
Dr. Kyle?
Yeah, I agree. I think that DARE at 6 months has shown to have high failure rates. So 2-stage is standard of care. I think that there's options for single stage depending on comorbidities, but from what I saw, it looked like that's also a potential option.
Anybody from the podium will go for DARE? Ravi?
Yeah. DARE should not only depend upon the duration, yeah? And this asymptomatic period is very subjective. This asymptomatic period is very subjective in the Indian scenario. We have to go in depth of that. That's one thing. And as per the Coventry, so any infection which is less than 1 year has to be taken as chronic. So if they are asymptomatic for more than 1 year, so then we can take it as, because first 3 months it will go in recovery, another 3 months, it's very difficult to diagnose. That's one point. Second, we should also understand what type of organism you have grown. For example, if you are a very sensitive organism, host immune factors are amazingly good, there is no comorbidities, then definitely you can do a DARE with the explanation of 75 to 80% of success rate. But a infection like MRSA, I think we should do 2-stage.
Okay, so anybody for single stage revision? Dr. Kyle McEwen?
I'm currently involved in stage 2 of a study now where we're doing what is basically a 1.5. So we're removing implants, we're putting in a device that's infusing antibiotics. We're leaving that in for 7 days, and then we're coming back and implanting final implants. So I've been doing that with good success, but not finished yet, not published.
Okay, so let's see what these people have done. Okay.
So we underwent with DARE.
So we underwent with a DARE. I think we considered it as an acute hematogenous spread rather than a chronic infection, and went on to do the DARE. Now this is just a video, this is not a video of this case. We just wanted to highlight how we will see for a loose implant which is otherwise looking well fixed. We call it as a bubble sign. You can see implant, when we are trying to push it, it shows the bubbles. So this is how we decide in cases where it looks like a well fixed implant, but it's not actually a well fixed implant. Next.
Okay.
So suppose if you are doing a DARE, Adibhai, what will be your choice of chemical you would like to go for a wash? Any of this?
See, I think that's as controversial as it gets. We still believe on saline. That's good enough. You can add diluted betadine. There are some who use polyhexanide. We are just happy with pure saline as well.
Ramanik sir?
I normally like to soak after a good thorough wash with betadine and saline hydrogen peroxide. I actually like to soak my knee for at least 15 minutes in sodium hypochlorite solution.
What concentration you would like to go for betadine?
Betadine, I just dilute 1:1 with my saline and I just put it in. But then I soak the knee for 15 minutes in hypochlorite. I we change the drapes and everything before we come back and start the procedure again.
Okay. Next. So this is a culture report. I would like to go to Dr. Arvind sir. So what antibiotic will you choose in this case, and what will be the duration you will give? It's a DARE case. We have done DARE. Now we want to give antibiotics. Now it's in your hand to save us.
It's not visible, but the choice for...
You can see it from here, sir.
Yeah, the choice for MRSA, if it is vancomycin sensitive, so we'll go for vancomycin for initial 1 or 2 weeks. And after 1 or 2 weeks, if you have got a DARE, you have taken out not taken out the implant, then you have to go for a add-on rifampicin therapy to take care of biofilm. And once you add rifampicin on top of vancomycin, you need to take care of for next 3 to 6 months.
Okay, so we'll give antibiotics oral for at least 6 months, suppressive antibiotic therapy.
So, in case you have kept this implant in
Yes.
Sujana, so minimum 3 months and then you can go up to 6 months.
Dr. Ravi, what is the protocol in your institute?
No, whenever you retain the implant, it may be DARE, whatever. So our minimum antibiotic protocol should be for 3 months. Of course, with lot of monitoring is required. We should not cause one more problem while solving the other problem. So in that case, our ESR, CRP, or biochemical, clinically they are not improving. It is better to do 2-stage rather than giving antibiotics. So that is very, very important to have to take into account.
Okay, next.
So the organism isolated was MRSA, and our planned antibiotic therapy was injection linezolid and minos for 6 weeks, followed by oral antibiotics for another 6 weeks.
So whenever you get an MRSA, Ramanik sir, you go and search for the carrier state. When you are getting a bug of MRSA in your joint, go and find for the...
So that is a protocol actually there in our hospital, that the moment you find MRSA, you have to go ahead and search. So nasal cavity and everywhere, including the groin area and the axilla, we actually take a swab from there as well. That is a protocol that we follow. And of course, the protocol that we also follow is that if you are retaining the implant like you've done in DARE, we would give IV antibiotics for 6 weeks, followed by oral for another 3 months. And rifampicin would be added, and we would be monitoring every 2 weeks the LFTs and the KFT levels as well, along with whatever ESR and CRP we're doing.
Okay.
And with linezolid, there is another issue is that with linezolid, you also need to check the eye and the peripheral vision.
Peripheral neuritis
It's
is
a
a known
very
complication.
common
Yes.
reported with linezolid.
Next. So, Arvind sir, you would like to recommend central line for all cases when you want to give IV antibiotics for more than 3 weeks, 4 weeks, or you want to go for peripheral lines only?
In this case, IV line for 3 weeks, 4 weeks, I am not going to give. 2 weeks is sufficient. 2 weeks IV antibiotic along, if you are giving linezolid 2 weeks, it is sufficient. After 2 weeks, you can simply go for a oral Linox plus oral rifampicin. So this is something which is there, but descriptively, mentioned in almost all evidences now.
Okay. Dr. Kyle, anything from your side? In your country, how long do you give IV antibiotics when you are retaining an implant?
6 weeks typically.
So you go ahead with central line, or you want to...
Peripheral inserted central
Yes.
catheter.
Ramanik sir?
I agree. So we don't use central line, we use a PIC line.
Yes,
And we put
PIC
it
line.
to the PIC line. And I actually, sorry, but I disagree with the linezolid part, because the problem with linezolid is bacteriostatic. It's not bactericidal.
Yes.
So you need a sidal along with the static.
Static, yes. Next.
One point I can add here.
Yes.
If your drug of choice is linezolid, if you're not getting peripheral lines, you can give IV for 2 weeks and oral, because the bioavailability of IV and oral is almost same. For linezolid.
Yes. So according to me, drug of choice in MRSA should be vancomycin. If vancomycin cannot be given, it should be other glycopeptide, that is teicoplanin. Right?
So if you see the PK/PD of linezolid is a static beyond doubt. But once the duration you exceed for more than 14 days, 15 days, the inhibition is as much equal to a bactericidal drug. So this is something which is to be reviewed by all of us. So it's not that static, and we bluntly say that static will not work.
Okay.
The only concern which we feel internists is the neuropathy and thrombocytopenia, which mostly occurs after 6 weeks to 8 weeks.
Okay. So this has happened after a period of around 4 to 5 months, as we all were expecting. This is likely to fail, right? And it has happened. So patient appeared again with a raised CRP, fusion. Next. We aspirated again infection, same bug. Next. So why did we fail? Right? Next. It could be an inadequate debridement, inappropriate antibiotic therapy, or an unrecognized chronic infection to start with.
Most of the failures, dire failures, are polymicrobial, which we would have missed in the first instance. So we should make every attempt to grow the other bug if possible, or if it is there. So the second attempt, we should send the cultures in all the planes, from superficial to deep planes.
Okay. Next. So this is what we find: a lower success rate of debridement in implant retention in a late acute versus early acute PJI caused by Staph aureus results in a matched cohort study. So this is a case which all you were saying from the beginning, that it might be a case of unidentified chronic infection. Usually falls in the category of late acute PJI, where symptoms are not very acute, but you feel like that it is an acute hematogenous period. Actually it is not. Inoculation might have occurred during the implantation, which remained dormant for a period of 6 months and went on to have an acute PJI. A failure rate of late acute with MRSA is reasonably high compared to other organisms. Next. So now everybody is agreed to that we are going to go for a second stage revision. Ravi Kumar sir, what antibiotic will you add in your cement spacer?
See, vancomycin, as it is MRSA, So vancomycin is the best drug to add. It is very compatible with the cement. So around 2 gram for 40 gram of cement. So that can be added.
Dr. Kyle McGivan, any other antibiotic in your country you add according to bacteria, not about specifically this case?
Yeah, my standard is 3 grams of vancomycin and 3.6 grams of tobramycin per 40 gram batch. Some people add a gram of Ancef for porosity. It's not heat stable. And then tailored, obviously any fungal elements you're adding, I add voriconazole is my choice.
Adi bhai, in our country, tobramycin is not available. What an alternative you will select?
So gentamicin, generally most packets have gentamicin in it. You just add vancomycin in this case. Or if you have a multi-drug resistant gram-negative, you may add colicin. The other one theory is that the antibiotic in the spacer is to prevent the spacer from getting infected. But you can add calcium sulfate beads with the targeted antibiotics and put it inside the joint in addition to the spacer. So that's a surgeon choice.
So we usually add vancomycin for gram-positive cases. In cases where they are gram-negative, a medicine of choice in antibiotics in cement is colistin. However, if you can see this study, there is a last line, you can see gentamicin plus TG cycline, if we add together, it has admixing properties, mechanical properties, and synergistic illusion property. There is one very good article in Antibiotic Journal which mentions superiority of TG cycline adding into cement over colistin. Next. So we did with this. Next. So the final few questions. Ramnik sir, how long will you go ahead with the spacer?
As I said, normally 6 weeks of IV antibiotics, I wait, then I give serial monitoring, then again 4 to 6 weeks of oral, up to 3 months, then I have a holiday period. During that I'm serial monitoring, and then I do the second stage.
Okay. So we do keep spacers little longer. We kept it for around 9 months. Patient was mobile. Go ahead. So wait. So we do biofire before entering into the second stage along with culture and fluid routine micro, just to rule out any presence of, if remaining any polymicrobial infection. So this is one of the protocols we follow. So I think labs were normal. Next.
So if I could just add one point about the biofire before the reimplantation. Now that's a genetic test that we really don't know if it's positive at that stage. Is it live bacteria or dead bacteria? Because they cannot differentiate. So we've had one case where we've aspirated, found it, and we don't know what to do with it. So at reimplantation, we've generally not done GI panel only for that reason, because it's like a gene expert in TB. Whether it's live bacteria, dead bacteria is something, then you're confused.
We are also sending culture along with.
Correct, absolutely.
So this is also my take, that mostly we only, limit it to early PJI, and at the time of this reimplant we don't do it. And one more suggestion, we also in first case, we also do in all cases gene expert. Gene expert and AFBSTN we do in all cases who are after 6 months of PJI.
Thank you,
Any
sir.
question from the podium?
Any question?
Yes, sir. Sir is asking about use of stimulants when we are doing DARE. Ramnik sir, you want to answer?
I don't use, if I have to put something, I just make small bullets of vancomycin and push them into the gutters. But I don't use, because they keep on leaching out. And it's like weeping wound, and you really don't know what is happening.
Any PJI, in my opinion, nutritional assessment of patient is very important. And serum proteins and serum vitamin D3 level is very important before you start the surgery or think about surgery. And most importantly, post-operative very high doses of vitamin B complex and vitamin C are mandatory to have better recovery or better results. And vitamin B3 in very high doses, niacin, work wonders in MRSA. So remember that when you have MRSA, give 250 milligram of niacin daily until it is cured.
Thank you, sir, for such invaluable input.
Thank you.
Thank you, panelists. For the next talk, I would like to invite Dr. Pradeep Bhosle, sir, for presenting his topic on THR in post-TB sequel, management and outcome.
Thank you for invitation for Ortho Trend, wonderful meeting. I was in KM for 29 years and I had an opportunity to treat active and healed TB cases. And with immunology department, I had a lot of research and I found some good clues for treatment. So this TB bacteria is very notorious. It is not easily found in the blood and it remains dormant for many decades. And most important is the immunology behind the TB. There's a robust immunology pattern and body reacts very aggressively to TB organism, mycobacterium, and immunity plays a major role, and my main aim is on the immunity pattern for treatment. So every host immunity is very important thing. Diagnosis, there are various things. Blood is very poor for diagnosis for TB, bone TB. MRI, clinico-radiological is most important. MRI, ESR, serum prolactin, quantiferon, TB test, gene expert, MGIT. Most important is the histopathology, clinical. Medical treatment is very important. You must have a connection, as told before, infection team specialist. They can definitely give you an extra guide. And it is possible in active TB, you can do joint replacement in selected cases. And my research is mainly on that. So you must have seen reactivation of TB. And the few basic reasons are inadequate clinical selection criteria. If there's a discharging sinus, there are other organisms like septic organism, pyogenic organisms are mixed superficially and it is like a septic arthritis. Bone destruction, frank pus, so these are not good candidates for, and they can get reactivation. Inadequate treatment like chest therapies, they give only for 6 months. And it has been shown beyond doubt by Indian researchers that for bone TB you need up to minimum 9 to 12 months and maybe more. There is no effectivity assessment for anti-TB medication. Drug resistance is very common. No immunological status assessment and no streptomycin cement data. So CD4 count is a basic thing after HIV. You can clinically find out the immunology, host immunity, and there are various research and it has been proved beyond doubt. It's a small marker for host immunity and which we use it for tuberculosis. And in spine implant, there are many papers which are published which shows that even in presence of frank pus, spine implantation is done and it is effective. So last 36 years I have experience of about 140 THA patients and there was no reactivation of TB in any of these patients. So my protocol is active TB. Selection criteria is very important. Naturally, it has to be arthritic stage. Effective pre-op anti-TB medication of 5 drugs aggressively for 3 months, and then you give the other drugs. No discharging sinus, because if there's a discharging sinus, there's a superficial pyogenic infection, so it becomes a infected pyogenic. ESR at the end of pre-3-month anti-TB medication should come down to less than 50. C-reactive protein should be less than 10. So these parameters should come down with your treatment. There should not be any pus on MRI. MRI is very important preoperatively to find out if there is any pus. KZS granulation tissue is accepted. And one important parameter which I studied was with treatment, CD4 count also improves, but the host immunity should be good. CD4 count should be more than 500. Patient should be well nourished. That also gives a small parameter of good immunity. HIV negative, because it's very unpredictable. There's a very high chance reoccurrence. No large bone cavities, not more than 10 millimeter. No bone lesion away from cartilage from 10 millimeter, and no active pulmonary TB. So selection criteria for you have to give a post-op. Active TB selection criteria, debridement, everything is standard. Some example, Hill TB. 25 years ago, somebody had done revision, failed because of the infection, and they removed the and left it excision. Patient was dragging like this for 25 years, and we did a revision, and he is absolutely fine. You need to give post-op anti-TB medication for 6 to 9. Now these are active, very frank active. Clinically, anybody can diagnose very clearly. And with first 3 months of anti-TB medication, all the parameters agreed. And you can see bone formation even at 16 years follow-up. Again, one more case, classical anti-TB, 17 years follow-up, post-TB. This patient had a fracture here, diagnosis of TB, you can see pre-op, and it was on anti-TB medication, and he had a pathological fracture. He came to us, and this is a 15-year-old follow-up with the same protocol. Sometimes there is a spine involvement also, and hip, and active TB, proven, and 1 year post-op. And this is 1 year, 10 years, and 24 years post-op. Movies not moving. Wandering acidabulum. You can see classical active wandering acidabulum, and of course it requires a good reconstruction apart from the total hip implantation, and this is 12 years follow-up. Everything is, there's a good osteointegration. I was invited to British Orthopedic for the same guest talk 2004, and I've published this in Journal of Orthoplasty 2000A March 21 and old 1995 Journal of Postgraduate Medicine. So these are the results. There was a superficial infection but no reactivation. So conclusion, single stage arthroplasty can be considered in patient with good immunity. Hill TB, you need to give 12 months of post-op anti-TB medication. Active TB only selected, no discharging sinus, no frank pus. Pre-op 3 months of effective anti-TB medication. Post-op 10 to 18 months of anti-TB medication. Good immunity status. CD4 count should be more than 500. No HIV. No lesion away from articular surface more than 10 millimeter. So orthoplasty can be safely performed with above criteria. Thank you.
Thank you, sir. Any question? So moving forward, I would like to invite Dr. Simon Thomas, sir, for the symposium on the periprosthetic fractures. For the panelists, I would like to invite Dr. Anup Karkata, sir, Dr. Jay Kumar, and Dr. Rakesh Matu, sir, on the stage.
Rakesh Matu is not there? You can start.
Hi. You want to add a few more panelists?
You can start with, that's okay.
Okay. Good afternoon, everybody. I think we'll present some cases. I think I'll just present the case and then you can actually give your views and let's see how it goes. So he's 68-year-old gentleman. He had a bilateral TCAR in 2022. He presented this year, actually knee pain for last 4 months. And this is a current X-ray. The left side is painful. I don't know whether it's visible nicely or not. Left side, can't make out. Sometimes you can't make out.
Yeah.
We can't.
Probably a metaphysis sclerotic area on the left side.
Yes, so I could also feel that there was some line on the middle side. And I said that this guy was having pain and I said, you just walk. Just watch, and I ruled out, I got a SED rate and everything was fine. He was walking well, but he was in pain. This is now March 2024. This is after 4 months from the initial presentation. That's last year somewhere it presented. Now we could see it more prominent. The fracture line is seen visible. What do we do now? He's in pain. The pain is more. He's able to walk. He does not have a stick, but he's in pain. He says he's in pain. I've ruled out infection clinically. The SED rates are normal. I don't have the values here, but trust me on that.
I'll treat him conservatively, keep him non-weight bearing for some time and add up supplements to heal the fracture there.
We are 3 people around and if we all agree there'll be no controversy, then it's no fun. Anybody wants to operate it? Sir, you don't want to do something right now? I think we're very boring people. We don't want to do anything. We don't want to have a controversy. I also kept on actually conservative. So now this is May 25. What to do now? Now I can see the fracture line on the lateral side also. He actually he's a badminton player. The history is that he was on court. He took a high jump. When he came back, he landed on this. And he had some innocuous pain, which has actually got increased. I have never seen anything like this before this patient. And I am still it lots. Anything this could be? Now do we want to do anything about it?
How are you to do a CT scan and find out, like infection protocol?
Infection protocols are followed, sir. Trust me on that. The aspirate came out to be negative. I got an MRI done. X-ray was showing a cortical discontinuity. I saw it get an MRI done. It shows extensive edema. And I got from a good place. They said the tibia is actually starting to, shift a little place. At this point, I thought I will go and do a revision. Do I have a consensus on this from both of you, sir?
You need to go do a revision. That's the only thing left. You need to do it.
What do we need to revise, sir, now? We do an isolated component change. What do we tell the patient, and what is our plan?
Since the implant is loose, so we have to revise, of course.
Simon sir, I want to interrupt for a second.
Yes, sir.
Dr. Sandeep Kumar is here.
Oh, that is nice. Good to see you, sir. We missed you. Trust me. I'll just briefly summarize. This is the first case we are presenting. I was here only. Okay, that's great. That's great. So what do you want to do, sir? Now you've got a fresh blood on this thing. What do you want to do? The 6 months 2 years post-operative, 6 months he's having pain in the tibia. There is a fracture in the medial side, which is now looks like the tibia is loose also. We rule out infection. What do we want to do?
I think if the implant is loose, there's no other way than the revision. So the revision needs to be done. Do we have a CT also?
I have an MRI which I presented. The
So
CT,
what about the condition of the condyles here? The medial condyle, the lateral condyle?
I think the X-ray, let's have a little controversy here now. Why do we need a CT scan, sir?
I think both the condyles are broken and there is a cortical break down on both the
Absolutely nice, sir. What would the CT tell us more that the X-ray is not telling us?
just the pattern of the fracture, whether we can...
You're right. It will document it better.
Yeah.
Okay. I don't have a CT scan, sir.
Okay.
Do we revise the tibia only or we revise the femur also? It's 2 years post-op.
Femur is well fixed, we can leave it, revise the tibia alone.
I think once upon a time, isolated component change were supposed to give a bad result, but with more and more joints being done, I think we are coming to a point where actually we see more and more of isolated component revisions also. So we also went in and actually had a plan to revise the tibia only. Anything you want to keep as inventory as backup, now you have got a failure. Anything as backup in the tibia?
Of course, you will have all the things with you. The augments, the augments, the sleeve, everything, because you don't know when you open it up to what extent you have to go.
Okay, so if we have to use a sleeve, then we may have to change the femur also. So if we have, we will use, we can have a cone. Maybe we can have a cone. This is how it looks like on table. This is unstable. This is unstable. And I think this mainly because the tibia had sunken in so much, the spacer size has changed. And this is how it looks like. And I don't know whether I can demonstrate it nicely. It was very well visible. You can see the space between the patellar tendon and the tibia. It is mobile. And the tibia just came out in hand, and this is how it looks like at this moment, and there's a bone defect. So now, sir, what do we do? And this is how it looked like. Actually, I don't know whether the... So this is all cheesy material around the tibia, and I've never seen anything like this. Could this be an avian during cementing? Could this be an avian or something? I don't have an idea. Actually, it's open to the house. But I knew what we had to do. I had not seen anything like this.
But MRI will pick up an early avian change. You've already done an MRI.
The MRI did not actually say, it just showed that there's extensive edema in the metaphyseal region, that's a zone 2. And this is what the defect we are left with. This is a post-removal. Any suggestions, sir? Now what do we do? This is how the implant looks like. We put a long stem. This the implant looks like. There's there is actually a gap there which actually needs to be filled. And do we fill this with cement, or would you be thinking in terms of something else?
For cement, it's too much large defect, so
Okay.
the cement won't work. So I think augment with the. We have all sorts of inventory with us. So
We have everything in hand, sir. I think the point is well made by sir that when you have got a zone 2 zone 2 defect, these are all, we are actually going away from cortical bone, cancellous bone. Zone 2, zone 3 is mainly cortical bone, and you have to now rely on mainly uncemented fixation. It's not just that the gap is too much, it's also because the bone quality is going to be cortical, and if you try to fill this with cement, you will have an early failure. So these are the ideal conditions in which actually a cone, which is biological, which integrates to bone, it acts like a scaffolding, a metallic scaffolding, it holds onto it, and an implant can be cemented right inside the cone. And this is how the trial looks like. The only problem with the cones that we get from the foreign companies is that the sizes. Sometimes in order to put these cones, we have to remove lot of nice bone around so that we accommodate the smallest size of cone. Fortunately, in this patient, the bone loss was so extensive that we could have a smallest side cone fitting snugly. And this is how the implant looks on top of the cone. And we check it under C-arm, and this is how it looks like. Are you happy with this?
seems okay, apart from the alignment of the stem and the implant. More or less, it is fine.
Whenever sir walks in, I always feel intimidated, but I have no choice but to say, sir, you ask your questions.
No, Simon, I think you're doing a great job with this. I think today there is a defined algorithm for defects. I mean, I think Ridian has written extensively on this. So typically, you have a two-zone fixation. If you get the two-zone fixation in this particular case, because you have a lot of bone loss in the epiphyseal region of your articulation on the tibia, I think that's a great choice that you've used. The only other thing I would sort of comment about is you would then need a zone 3 fixation, which is your diaphysis. That stem would appear to be somewhat undersized. So you need a really good fixation, either using a hybrid fixation stem or a press fit, whichever you choose to use. Again, in the stem, somebody with a spline type of a stem would be a better option. So those would be the couple of comments. If you have a dangle stem, then again you're going back to a one zone fixation, and that over time it will toggle your articulation and you'll get a failure.
I think it's a very well-made point, sir, and I think we have followed that, because once you're doing this, we might as well, I'm still scared of getting a very good press fit stem because I'm scared of getting a stress riser at the end of it. I'll just ask my colleagues what their view is on. Would you like to use an undersized stem and cement it completely with a cement with a cement restrictor, or would you like to have a very nice press fit stem? What's your take on it?
As you rightly said, that there is always a chance of stress riser at the stem, if it is too press fit. So it depends upon the quality of the bone, as rightly said by the sir. If the quality of the bone is fine, we can go ahead without the cementation. But yes, if it is too osteoporotic and we think that even down below there can be a toggle effect, then we might do a cement also. So I think it's all the parop decision which you have to take.
I think one thing I wanted to point out is that the stem is definitely undersized, but it also looks in varus. Because there's a needle defect, there's always a tendency to go into varus. Even after you put a cone, sometimes you can't make it. It's always a good idea to see under C-arm so that you can correct this varus into a neutral position, because a long-term, a varus stem is not, a great choice to be. And this is how it is, and I hope I can demonstrate this video. After you put this cone, it is so snug that you can lift the tibia out. You can lift the tibia off the table without the cone coming out, and it is rock solid. And it has a great integrating potential, and it acts as a scaffolding on. And it is also like a cancellous bone into which your cement will go. And after that, the cementing is done, and this is how proud it looks like. The implant is sitting right on that cone, and we've not taken a big spacer here. The spacer is actually a smaller size, and this is how the X-ray looks like. A final comment on the X-ray, sir.
It seems well done.
Sir, I think we are agreeing too much. There is no fun if you agree to me everything that you say. You should counter me, then only there will be some fun.
Yeah, as you said, there is a slight amount of...
I could not correct that. I think that is a sore point to me. I thought I could correct it, but at the end of it, I think I could have done a little better job at correcting that varus on. And what is the post-op protocol going to be in this patient? Non-weight bearing or partial weight bearing for some time, sir?
No, you could lift a cone with the tibia. I think it's a very stable fix.
Absolutely, I totally agree. This is how it is, and at 3 weeks post-op, he's actually back to. And this guy came back from playing. Although I restricted him not to play, this is not to boast. We had to ask these patients to slow down. He goes to the court, but he's still not playing. I think I took him around 2 months to actually start playing, but this is the 3rd post-operative week, and he is actually relatively pain-free. So again, there's a 66-year-old lady, bilateral TKR was done in June 2023. Immediately post-operative, there's a periprosthetic fracture, which was fixed with a Phylos plate. And for the last a few months, she has pain on walking, which has increased. She says the pain never vanished after the first surgery, and this is how it looks like. Anything on the X-ray? I'll go back to the X-ray. Sorry, I skipped it. Sometimes you can't make out. Sometimes you can't make out. You have a patient who's come with a problem. The first X-ray does not show anything. But then she has been actually moving around. You have to give some seriousness to the thought, and you go methodical. So what you start is actually ruling out an infection. That's a basic. A painful knee for no reason, everything looking fine, please look for infection. Although it may look wonderful and great, the infection is always a problem. This is how the skin looks like. It reasonably well healed scars. ESR was 19, CRP was 13, TLC was 2000. What to do now?
Aspirate.
Yes. So we think that this may be an infection, and we tell the patient that this could be an infection. This is a synovial fluid analysis. Actually, a lot of, whenever I send a synovial fluid analysis, I never get a sugar value, I never get a total counts, because they give me a neutrophil value out of the, in the slide, but I never get a total TLC. TLC count is never got, because they say this is so cloudy that we can't actually make out a total count. But in this patient, they got a normal cell count, and the aspirate was sterile. With all precautions, she was not on any antibiotics or anything. And a bone scan was done. The bone scan, please, has no role in any infection. It cannot rule out or it cannot refute. But it has got a, there are two advantages of a bone scan. The first is it has got a negative clearance value. That means if it is normal, I can actually go ahead with it. There is nothing problem with the knee. Let's search for something else. But this patient had an uptake in the femur and femur alone, and this was demonstrated. So we don't know what this patient has, but there is something in the femur which needs to be looked forward. And when you say that and you show that on paper in front of the patient also takes it, that let's proceed forward. Now what to do? This patient has a bone scan. We again go back to the MSIS criteria. I'll skip this because we have a periprosthetic joint, which has to see. So we have the MSIS 2018 criteria. This could be possible infected scenario according to preoperatively. You don't have a culture, you have an elevated CR, you have CRP, you have an elevated ESR, and this is PGI score 3, which is possible infected. And when there's a possible infection, what you tell the patient is that we may have to relook into this. Maybe I do a stage 1 because you're having so much of pain, and if it is non-infected, maybe the femur is actually loose, and you go into basically a revision scenario. With this, we went into it. The patient took the idea. She was in so much of pain. She took that we okay to do something on table. This is how it looks like. Now we have to complete the classification intra-op. In intra-op, you have to go by your own look. We sent a frozen section, which was negative. The tissues look healthy. Obviously, the gram strain don't have a role, and the femoral component was actually, frankly, loose in this patient. And the intraoperative criteria of positive histology was negative. There was no purulence, and the culture, even if it come positive, this was less than 2. That means this patient is non-effective, and we went into a revision. We realized that the tibia has actually gone into a varus. The femur had gone into a varus, and the femur was loose. And I think I'll not go into this. I'll just want one opinion from you. How do you decide on the joint line in these patients, sir? So we have gone in for a one-stage revision. How do you decide for a joint line in this patient in whom the femur is actually eroded on the medial side and possibly on the lateral side also? What is your criteria to decide a joint line?
The only thing intact is the tibial tuberosity.
Okay, tibial tuberosity is
tuberosity
one thing.
And above one thing, patella, lower border patella.
Yes. I think, any other comments from some of the colleagues, sir? Sometimes patella can be scarred. Tibial tuberosity is a big thing. Medial epicondyle, lateral epicondyle, they look very good on theory, but I think on the ground when we do, what also works is the meniscal remnant. In however times a patient undergoes a surgery, the meniscal remnant can be felt and sometimes seen also. And if you can actually bring it down to the meniscal remnant, the joint line, then the chances actually that you're accurate is usually right. Because sometimes the x-rays may look fallaciously, the patella is baha because of the scarring, because of repeated surgery. So in these days, when I go into a revision surgery, I actually think of actually having a meniscal remnant, which serves me much more. And I think in a lot of the future conference, we'll be talking a lot about this, rather than actually the medial epicondyle, lateral epicondyle, and the patella itself. And this is how it looks like. The 2 screws were broken. This is how it is. We use the C-arm, and this is how it goes. And is everybody happy with this? Sometimes we can agree also.
The slight obliquity in the joint line is there, AP view. It's standing X-ray.
This is not a standing X-ray, this is a supine X-ray, this is an
you
immediate
can't.
post-operative X-ray. She's walking next day. This is how it looks like. I think our time is running out. I'll just go faster. But are we agreeing on me? Have I done a good job? I'm thankful for that.
Yeah,
this is how she presents me 2 weeks down the line. We go back to the pre-operative X-rays. We now go back to it. Do you want to think there's something goes wrong there? Or something could have been done?
Probably a stress racer, a longer stem.
I went into this. I thought I had a thinnest possible. This is a size 8 stem. I did not want to take out these 2 screws because I would have to go longer. I thought I had got away with it. I don't know. Some of my senior colleagues would want to have a, Dr. Wakankar, Dr. Rajgopal, would you like to make a comment, sir, on this?
I mean, in hindsight, it's always easy to say, oh, you should have removed those screws and put a longer stem. But yeah, I mean, in the given scenario, your reamer would be catching on those screws. You know, you would probably feeling the cluttering sensation as you put in the reamer. And, your difficult choice during surgery would be whether to remove those screws. Screws removal would mean that going much longer stem, obviously stress riser, periprosthetic fracture. So, you take these decisions, but depending on what the conditions are on the table. And sometimes those decisions do go wrong, obviously, as it did here.
Would you have removed the screws, sir, on table? What would you have done, sir?
I mean, theoretically, yes.
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 I think sometimes this is a lesson learned. Although we want to remove as minimal as possible, but makes me think. I've got away a few times with this kind of scenario, but this time was not. Maybe I could have removed it. The question is now what to do. How many of us are doing some trauma also out of the 3 of you? You do trauma. So I think you've got a mix on this thing. So what do you want to do, sir? You want to fix? If you want to fix, what do you want to do? Or you want to revise? If you want to revise, what do you want to do? A raise of hands of fixation. Who would want to fix this, sir? We are saying a bold thing in an arthroplasty conference. We are going to do trauma fixation for an arthro. So we are very bold people. That's wonderful, sir. Nobody wants to revise out of us? Okay. So what you like to do is 1 plate, 2 plates, bone graft?
Implant is well fixed, so I would like to use 2 plates.
Okay. 2 plates, which side, sir?
On lateral side and on either you can put on the medial or on the anterior surface of the
on the anterior surface. We all agree, have a consensus on this, sir? That's great. I think nobody wants to do a revision. Okay, this is what we did. I wanted to do a minimal invasive kind of thing. I do some trauma still, and I think we are happy with, we did not bone graft at all. I actually tell these patients that we want the tissues to settle down. We want the fracture biology, the osteoclastic activities to do, and we as trauma surgeons know that primary bone grafts don't make any, they've no place, whatever everybody must be doing, but primary bone graft don't have a role. So we tell these patients that we'll actually take you for a secondary procedure, maybe a few months down the line, if the fracture does not consolidate. This might take to the patient, she took it well, she's walking again next day. And this is how she looks like. We're happy with this? Okay, we're happy with this. This is how she's walking on a third post-operative month. She's walking well. She asked me now, do we want to do a secondary procedure? Do you want to do something now? I said no. Would you agree to this?
Yes. Down the line, 3 months, na?
I wouldn't allow full weight bearing. I wouldn't even allow toe touch. She needs to be non-weight bearing.
This is 3rd month, sir.
No, you showed within 1 week she was
sir,
weight bearing.
No. This is I am very candid. This is immediate post-operative.
Yeah, but even here, I think if she's non-weight bearing, I'm happy.
She's on toe touch ambulation, and sir, I think that's one thing I want to always say. When you do a non-weight bearing ambulation, you got almost 35 kilos of weight acting as counter traction. So you ask your therapist to actually do a toe touch ambulation so that the weight of the leg is actually neutralized, and it actually is more physiologically this thing. This is the 3rd month post-operative, sir. She's walking on a stick and she's taking weight on it. Is it too early?
Yes.
Yeah.
Okay, I think, and is it, this is the 4th month. Do you think I was too overzealous, that is why this is broken?
See, just before the x-rays, what we do after 3 months or so, if there is, because there's so much of implant, x-ray may not be able to give an idea of so we get actually CT scans for all our patients and see if the fracture line is still there. Go ahead, put an idea. What the trauma surgeon said, we use a dual plate actually for all these patients, and we do primary grafting because luckily we have a bone bank. So massive grafting required.
Again, Simon, to Dr. Pachure's very eloquent words of wisdom, always plate 2. I think that's where I think you slipped up. And I would do it medially because that's where the stress riser is. The bending motion is there. So if you use a medial plate and a lateral plate, you would have gotten away with it.
I think I have also learned as much as you, sir, but I have one point to make. What makes a plate break at 3 months? Stress. And why? When we do, this is what I learned from this case. I think I learned. I'll open out to you. See, I think why I failed in here was, I have a locking screw right adjacent to that one intramedullary blade. Had I not put that screw, maybe the screws would have failed, maybe the fracture may have actually not healed, but definitely the plate may not have broken.
No, you have to maintain the working length.
Yes, I did not maintain the working length. I thought I'd done a great job, but this made me think. So next time I put a screw, I'll make sure I don't have a screw anywhere near the tip of the stem, because at least the fracture may fail over a period of time, but definitely my implant would not have failed. Had it failed, I had always the opportunity actually now to put one more plate on top of it, add a graft. What I did not do first time, as Dr. Pachore said, I always had the chance to make it up in a second surgery, which I'd always explained to the patient. Now the question is, the patient is looking at me, the family has all come out. Now what do we do, sir?
Again,
Simon, can I make a point?
Sir.
Even if you had not put that screw, this would still have failed.
Yes, I totally agree, sir.
Yeah, because I think the biomechanical principles of fracture healing here are not really met. So, I mean, I take your point, it might have failed earlier or later, but it was inevitable that this would have failed over time.
I totally agree, sir. I just want to say that it would have given me a little more time to maybe go in ahead and add a secondary plate, do some bone grafting, which I did not do first time. That was the point I wanted to make.
Yeah.
I think now the medial plating is a standard concept for such fractures. So along with the lateral, as sir has rightly said, the medial plating needs to be done in the primary go.
I think
or she was fully weight bearing, only just a stick she was holding and putting all of the weight, even on the third day.
Usually, you complete yourself, sir.
So that is what, either a medial plate should have been there, or there should be a delayed weight bearing, at least not before 2 to 3 months.
The weight bearing started, that was the first day of weight bearing that I took a video.
Yeah, full.
That was third month. That was third month.
Initially also she was putting the
she was not
third day.
No. There's no point being overzealous, sir.
No, don't go theoretically, Simon, that weight bearing in what you said. Most of these patients should be totally non-weight bearing. What literature says 30% and all that, don't believe in that.
Totally.
And our patients are not reliable. They go home and they will do what they want.
Sir, for me, literature is you, sir, like a lot of other people. So I totally believe what he's saying, and I think what do we do now? I think we're coming to the fag end of it. Now what do we want to do? We should remember that we are an arthroplasty meeting. So now I'll remind you again. What do we want to do?
I'll revise the fixation with dual plating and bone grafting.
We are still agreeing to this? See, at the end of the day, when you have got a situation like this, when things have done, see, I do less and less of trauma work, but I do more and more of joint work. And when a patient comes to me, he wants something called a predictability. 1 surgery failed, 2 surgery failed, 3 surgery failed, 1 was done by somebody else. I give him a predictability, and that's where joint replacement stands out. We sometimes take the biology a little out, and we think of doing a revision. I gave them an option of a distal femur replacement. I think I'll run through it. We have medial incision, we have an anterior incision, we have a lateral incision, and we don't know what to do. What approach would you want to use? Like, sir, you would like to use which approach to expose this?
Anterior.
Anterior. I think I also agree that we went in anterior, we removed the entire thing. We don't need to have a lot of exposure to remove this. This is how it looks like, and this is how it looks like. We gave a separate lateral incision. We did not use a tourniquet. We actually took the the plate out, and the tibia actually came out. That is not a problem. The problem is removing this cement restrictor. That becomes a problem because you know to pass on a stem, it's a big problem. Any comments on how to remove this? I think we'll run out of time. I think any comments? Otherwise, I'll run through this. I could not actually, I could not remove this. I actually put a K-nail reamer. I thought I'll come out of it. I was scared of it. So we put a guide wire, we reamed over it, and we could put a cement scratcher below. Still, we could not take it out. And so these days, we don't actually put cement restrictors in our revision cases when you have to cement. We actually use a gel foam or a Surgy span. It is very easy to remove, or at least it does not come in the way if you have to revise this. So the cement restrictors, at least in my practice, are not used usually. Sir, Pachore sir.
You can use a biodegradable. Yeah, they're available. Secondly, if you are worried about this, make a very short, small window there. I have done many times for the hips, and just take it out, because they allow you to get into center.
Great, sir, great. But yeah, I think that is also a valid point. And this is a stem size of 8 into 102. The next size was 127, but it started from 11. And this is how I thought I'll take a size 11, or size 8, and I actually reapplied the plate. And the last two was gone into, so it did not bypass the fracture side at all. Give me 1 more minute and I'll finish it off. And so this is how it looks like. The distal femur component is 65, and an insert. This is a Stryker GMRS, which gives an insert also in between the femur and the tibia. And this is how it looks like. There is hyperextension. Anything to correct this now? So usually when there is hyperextension, that means your length is not adequately achieved. You have to increase your length. So as soon as you actually add a 40 millimeter extension rod, you actually get a straight a straight leg. And you then realize that you have got a fracture, you've got a joint line which is shifted proximally. What I did was that extended the 40 to 50 and reduced the spacer size by 10. From 24, I brought the spacer size to 10. So my joint line was restored, and this is how she looks like. And this time I had no problem in making her weight bear for 3 weeks. Is this the end of the story? Maybe it is, maybe it is not, and we'll see in next Ortho Trends. Thank you so much for your patient hearing.
Thank you, thank you. Thank you, sir, for such nice demonstration and presentation. Thank you, panelists. Moving on, our next talk is on Relive Surgery Primary TKR. I would like to invite Dr. Ashok Raj Gopal sir on the podium. And for the moderation of the session, I would like to invite Dr. Hemant Wakankar sir and Dr. Sunil Rajan sir. Kindly join us.
Well, good afternoon again. So this is actually a real life surgery. We did this only about 5 or 6 days ago. This is the new Shalby duronium implant, and this is a implant that has a coating. So we'll get started with this. So these are the preoperative x-rays of this patient. So the exposure has been the traditional, I use pretty much the midline anterior incision, anteromedial arthrotomy. The only point over here is particularly with obese patients, if you do a subfacial dissection of your medial flap, you take the entire vasculature along with it. So we normally make a smaller incision, but for reasons of visualization, we made a slightly longer incision over here so that we could have a good view of the anatomy. The second thing we do a little differently is we do not use Hohmann retractors in any of our cases, whether it's primary or revision. We just manipulate the window and the articulation. You excise the fat pad for greater visualization. You can strip the medial third of the tibial tubercle. It's very important to understand that you do not want to avulse the patellar tendon, because that's one of the most catastrophic complications. It really has very little by way of solutions to this. We still subscribe to the adjusted mechanical alignment philosophy. We have not moved on to alternate philosophies. Honestly, not really convinced that they do a great deal of difference to outcomes. So this is a adjusted mechanical alignment. By that I mean I use a 3-degree distal valgus cut. I use about a 1 degree varus cut on the tibia. So again, this is a manual technique. You place your intramedullary instrumentation just above the attachment of the PCL. This jig is set to 3-degree valgus. So this is a distal cut. My philosophy is to complete the entire femoral preparation and then address the tibia. I know there are alternate ways where you do the extension gap first and then you do your flexion gaps. We've always done this as our workflow. So we complete the entire femoral preparation and then go ahead with resecting the tibia and then balancing the gaps. So this is the distal femoral cut. You remove the osteophytes at this point of time. The next thing to do is to, you have excised your meniscus and so on, and then you do the femoral preparation. I must add that being the first case, I had the wonderful company of Bala, who was egging me along and correcting my surgical approach. So thank you, Bala, for that, and thank you, Deepak. I really appreciate that. So these are really, they're very simple instruments to use. Pretty much the philosophy here is like a lot of the systems. You're between sizes, you go up size. This is actually a posterior referencing system. Some of the knees, some like the Persona, for instance, which we alternately use, is an anterior instrumentation. So you've got your sizing right over here. You get your size. And once you've got your size sorted out, then you can remove this sizing jig and take out your femoral finishing block. This is a nice, elegant jig. So you fix this. You need to make sure that you're totally in contact with the resected surface of the femur. And so there's no real order to this. I mean, we prefer, in my practice, I tend to do the anterior chamfer, anterior femur, posterior condyle, posterior chamfers, so in that order. So that's pretty much what we're doing over here. But like I said, there's no hard and fast rule. You can do it pretty much any way that you're used to doing. So we complete the femur with this intervention, and once you have done that, you remove the jig, and it's particularly important in these instrumentations and implants in today's day and age that you try and prevent, and there are enough checks and balances to prevent anterior notching. It's a controversial subject whether anterior notching causes periprosthetic supracondylar fractures. There's enough evidence that it does not, but it generally looks a little ugly on the X-rays, and if God forbid there is a fracture, you're left a little red-faced. So it's always nice to have that little bit of flexion in your femoral preparation, whether you're doing this robotically or non-robotically. So that's your femoral preparation done. It doesn't take very long. This whole surgery, this step takes about 5-7 minutes, and to get to this stage. At this point, we remove all the osteophytes, particularly the medial osteophyte that is around the medial collateral ligament distal to the medial epicondyle, because that tends the MCL, and it'll give you a false sense of tightness. So release your MCL. I think you must have read and heard many times that MCL is not really ever contracted even in severe varus deformities. This patient had large osteophytes, and to be able to access that, we We do a posteromedial release, much less than what we used to, but we go all the way around so that we're able to get to the back of the tibia on the posteromedial side. You remove the meniscus, and once you have done the meniscectomy on the medial side and the lateral side, you can actually telescope this the tibial segment outside of the wound. Of late, we've already also started taking out down the lateral facet of the patella, particularly in some of these knee implants that gives you a very good patellofemoral tracking. This is one of the tibial jigs that I've used forever. I actually devised this tibial jig when I was working on the Persona model, so I've been using this since almost about 2005, so it's almost 20 years. It's a very simple, very elegant. You take the 2 millimeter profile to get your tibial resection levels. Again, just as a point of interest, if there is a severe deformity, I take out 6 to 7 millimeters. That gives you greater control on correction of the deformity. And once you have done that, then you do your tibial resection, typically about 8 to 9 millimeters from the healthy side and about 2 millimeters from the affected side, provided that defect is not too large. You never want to go to a base, particularly where there's a bone loss. So once you do that, you take out that wafer of bone. And as you can probably see here, that we have pretty much done all our resections. We have not used any Hohmann retractors. And this is our standard of care. We we never use the Hohmann retractors. So once we've gotten that done, your tibia is done, your femur is done. And at this point, you can do one of two things. You can check your flexion extension gap with a spacer, or you can just put in your trial prosthesis and make sure that it articulates well. So two ways of doing it. Once you have done that, you've got, again, that philosophy of the rectangular gap. We believe in releasing soft tissues to get balance, as opposed to the current concepts where you deal with this by altering your bone cuts. We really don't like doing that. So we've done that. Once you've done your resections and taken out all the osteophytes, you size your tibia. This is an asymmetric tibia that you have with this Duronium system. It's a very elegant profile. It's got a lateral relief that prevents impingement with your popliteus tendon. So it's a nice, elegant way of, you fix this, and then you have a keel, which is a cruciate keel. It's really quite simple. You just bang it in. And once you have done that, you remove the tibial keel, and you're now ready for your trial. We leave so there are two ways again of doing the tibial trial. We don't do the free-floating technique, because we believe that a snug tibia will go into internal rotation, and you don't want to use that as your landmark. We actually published the best way of getting your tibial rotation right in 2014 when we were talking about the Persona tibia. And the best way to do is to match the anterolateral curvature of your resected tibia with the anterolateral curvature of your implant. That gives you a tibial alignment which is native and personalized to that particular individual. So once you have done that, you put in your trial prosthesis, and pretty much your surgery is done. So that's your trial prosthesis going in. This system actually also has the added step of taking out some bone from the trochlear area to enhance trochlear configuration and conformity. So once we have done that, we check for the medial-lateral balance. You need good coverage. You don't want to overhang, because that is one of the causes of impingement of the soft tissues. Once you're convinced, you can make your lug holes for your definitive implant. And just take these through a trial range of movements. Before we do that, we need to make that little trochlear recess. So this is an additional step that is needed for this particular implant. And there is a beveled chisel which you can actually just take a knock out. It takes out about 2-3 millimeters from the trochlear notch. And it's really quite elegant. A lot of systems, this started off with the next-gen system, and then a lot of the other systems followed suit. So this is a nice low-profile trochlear area for the for your femoral preparation. So once you've done that, you can pretty much remove all the hardware, and you're ready for your trialing. You've done the trialing, you're ready for your cementation, and so one of the things that I believe is the critical part, and I don't think any of us talk about this. We talk about technology, and we talk about alignment, and we talk about stem fixations. None of us really talks about cementation. I think that is the key ingredient, because if your cementation is not good, no matter what technology you use, that interface is going to fail. So you make multiple drill holes, you have a completely dry field, you give it a good lavage, and you should be able to see the trabeculae in the bone. And once you are able to see that, have a completely dry field, and cannot overemphasize. Our go-to is we put cement in the canal of the tibia and on the surface. We typically use Palacos without cement, particularly in patients who are regular patients. Patients with diabetes, rheumatoid, immune compromised, we use gentamicin cement. On the femoral side, we put cement on the implant and on the posterior condyles. And you want to pressurize this. You really want to pressurize this. A lot of people talk about balance. My idea of balance is when you have done everything and you extend your knee and a certain amount of cement extrudes, you know your collaterals are in the right tension. You should be able to achieve full extension without actually pressing on anything, and you need to have good patellar tracking. So as long as you're able to do all of this, you'll know that your soft tissue balance is good, your fixation is good, and your tracking is good. If your tracking is good, it means your rotation is good. And if your rotation is good, that knee is going to last for a while. So that is your tibial base plate getting completed. The other point is the locking mechanism of this polyethylene. It's a vitamin E impregnated poly, and we'll have a little discussion with Hemant around this. So it's a feel-good factor. The vitamin E poly is really quite a nice way of having a stable articulation. So once you have done all of that, our tibia is done, then all that remains is for us to articulate the femoral component, reduce it, and our surgery is complete. So we make a bit of a big deal about removing the cement, because cement is the third body. Once it solidifies and it cures, it can actually scratch the surface. And I think I cannot overemphasize with articulations like this that are coated implants, the titanium, niobium implants. Any scratch can propagate and cause problems. So I think it's very important that you spend a lot of time removing all the debris, all the loose pieces of cement all around, particularly in the lateral gutter. Certainly for approaches like the one I use, you want to make sure every bit of that cement has come out, because if you leave any of it and it becomes a loose body, it can actually damage your articulation. So that is your articular surface going in. It just sort of bangs in, it just sort of sits very snugly. So once you've got that, you're ready for the femur. I know there are different ways to do it. You can do the tibia, then the femur, and then put the articulating surface, but this is something that we've done for the last 35, 40 years. So it works in my hands, but I'll be open to anybody else who wants to do it differently. So that's pretty much the surgery done. Again, on the femoral side, you want to make sure that all the cement is removed. I think you need to be particularly cautious, as I've said multiple times, that the coating is safeguarded, and cement is very hard, abrasive material, and you need to make sure that you've taken that out. So that is the post-operative X-ray, good articulation. We do not resurface the patella, and that's your surgery that's complete. I'd like to thank you for your attention.
Yeah, that was a wonderful demonstration, Ashok. As you said, you and me both don't have great experience with the new prosthesis. And anytime we have to use a new prosthesis, it's your feel, how you feel at the end of the surgery with the prosthesis, the way it articulates, the way it moves. So what would you say about how it actually functions at the end of the surgery?
So early days, honestly, like you said, but I think it feels good, looks good. I think the nice thing about this implant is the asymmetric tibia with the lateral relief, and I think that is a good, because when you look at conventional trays, I think one of the causes of concern is popliteal impingement, and a lot of our knees, patients who feel that little bit of pain, I've actually had occasions to actually go in arthroscopically and just chop that or resect that, release the popliteal tendon. We don't do it nearly as frequently as we used to back in the days, but I think with this kind of a implant design, that is good. The other thing I think, which I don't know if we are making too much of it, but the so-called issue of metal allergy, I think these coated implants are probably a boon in that direction. I know for a fact there's a lot of buzz in Europe. Germany is probably the largest users of metal allergy implants, as I understand. There are a lot of countries, a lot of surgeons actually say, does that really happen? What happened in all these 30 years that we've been doing it? Are we missing some low-grade infection? Are we looking at instabilities that are not quite defined? But I think in a increasingly sort of medico-legal world, and a lot of our patients, my patients, I'm sure you deal with this as well, they come and say, Dr. Saab, we have allergy to metal with gold, silver, and so on. When they say gold and silver, I say, thank God your husband is going to be happy with that, because you're not going to have to buy stuff. But on a serious note, I think it is a feel-good factor. I also want to make a comment here which may be in place, may be out of place. We have had experience with some of the other gold implants where revision rates are really catastrophically high. I mean, we've had revisions with some of the other alternative implants where when we have gone in, that coating of the gold has actually worn out. So you can actually see the chromium cobalt. And this has happened as early as 6 to 8 months. So I think there is something to be said of being cautious of the choice of implant. So the three things that appeal to me with this, instrumentation is very simple, it's very user-friendly. It is hopefully implant allergy safe. The lateral relief is good, the locking mechanism is good, and the vitamin E poly, again, between the hips and the knees, there is a huge difference. I don't think we have ever actually categorically defined the efficacy or superiority of the vitamin E poly in the knee scenario compared to the hip. But I think increasingly more and more of the surgical industry is going towards the vitamin E poly. We've used it for almost about 14 years. We have had no problems with it. So I think for want of anything else, we're covering our backs and using it. So overall, the answer to your question is, it felt good doing it, and I'm looking forward to doing more of them.
Sir, I would ask two questions. What type of population would be benefited with such type of coatings?
Sorry?
What type of patients will be benefited with such type of coatings? And also one thing that combining these traditional implants with the new coatings, how it's advantageous to the patients?
So great question. I don't think anybody knows the answer to that. We would like to believe that coating gives you a better coefficient of friction. It gives you more biocompatibility. And as I said, I think we will never be able to answer whether a patient is metal sensitive or not. I mean, Sanjay is not here, but Sanjay and I, we did some pretty extensive dig deep into a couple of patients with oxenium. And we know for a fact that oxenium allergy has been reported. And I think he had a series of 7 or 8 or 9 patients that we both worked on. He asked me to have a look at some of them. The chromium ions and the cobalt and all of those, that stuff was okay. We wrote to the company, they did their biomechanical studies and all of that stuff. We never really came to an answer. So some of what I'm saying is conjecture, but I think if history has got something to go by, as long as you have a stable interface, you're not doing worse off than a chromium cobalt implant. Is it going to be better? Time will tell, but for now, I think we are basically covering our tracks when we use this.
Yeah, question from the podium.
Sir, reason of being not using ligament retractor, and how will you compensate the not using ligament retractor?
I've never used one because when I started 40 years ago, I had no retractors. So we adapted our ways to doing it, and even in very, very obese patients, as you could see over there, there was really no challenge. My worry, so I have 2 worries when I use a retractor. One is in a soft osteoporotic bone, where you put 2 retractors at the back, you can dig into the back of the tibia. And I'm worried about the neurovascular bundle. The 2 reasons, and if you are looking at the lateral side, you can dig into the, particularly with the kind of patient population we have. And most importantly, I don't feel the need for it. I mean, I get great exposure. I can see all around the tibia and the femur. I have always believed, and I will continue to say this, that I do soft tissue releases. I have no shame in admitting it. I've done it for 40 years. We have 32-year, 33-year follow-ups with implants that are in place. Soft tissue releases are not bad, and I would stick my neck out and say that everybody does soft tissue releases. How else do you get posterior osteophytes out? When you take out the medial overhang or the posterior osteophytes from the tibia or the femur, how do you do it without releasing it? The minute you touch your medial meniscus, you excise your medial meniscus, and you take out even 3 millimeters, that is a soft tissue release. I take out 7, you take out 2. But to say that I do not do soft tissue releases is where I take exception. You have got to do soft tissue releases to access the back of the femur and the tibia.
And to claim that that is the sole.
And just one more point. We have a lot of history with doing ankylosed knees. And if you do ankylosed knees, Gil Scuderi and me, we evolved a technique that we called skeletonization of the distal femur and the proximal tibia. And we actually shelled out, it was like a subperiosteal resection, including taking down both the medial and the lateral collateral ligaments. We did a medial epicondylar and lateral epicondylar osteotomy. As long as your periosteal sleeve or the soft tissue sleeve was intact, the knees were stable. So I think we are making too much, and particularly with the advent of robotics, because you have to say something is better in robotics than non-robotic surgery. And don't mistake me, I'm not saying there is no place for robotics. It's a great place. But I argue with people who tell me that I do not do soft tissue releases. I argue with people who say that you cannot balance a knee unless you make alterations to your cuts. You can. And all of us have been doing it for 40 years. And if you can have a knee that lasts 25 years doing these so-called very old-fashioned techniques, you're doing something right. I'm not saying what you're doing is something wrong. I'm saying the results of robotic or alternate alignments prove to me they are better than what I'm doing. I'll join your ranks. But till I'm convinced somebody can show me evidence at 15 years that results of alternate alignments are better.
Do you use posterior Oman?
No, I don't use any Homan. Anterior, posterior, superior.
Yeah, it's just the technique that he has evolved for himself. I think, in my next talk, I'm going to show you how I use the spikes. But that's,
I won't argue with people who use it. All I'm saying is in my hands, it doesn't work.
Yeah,
I don't
fair
need
enough.
it.
Yeah, one question here from
Sir,
floor.
great to see you doing the surgery in a conventional way in this current world of robotic, people doing by robotic assisted surgeries. Since we are talking to the stalwart of knee replacement surgery, I want to ask you a very basic question. So when you are adjusting your alignments, the femoral component alignments, what attention do you pay to your femoral component rotation and your distal femoral cut in terms of valgus varus alignment in a standard varus knee? So how do you manage that given a lot of talks happening and a lot of changes happening in the current world of alignment philosophies and all?
So great question. So I'll answer that by saying that I work on what I call a default setting. All my life, I worked on an alignment which I use, and even today, regardless of which implant system I use, I always use a 3-degree distal valgus cut. Standard. Whether it's varus, valgus, anything. I do not change. The only exception to that is if there is a very severe fixed valgus, I will go down to a 2. Other than that, all my valgus cuts on the distal femur are 3 degrees. I use predominantly anterior referencing systems. The reason I do that is when you have a posterior referencing system and you have a severe varus deformity, there's an overgrowth of the medial femoral condyle, there is a defect on the posteromedial side and vice versa on a valgus. So if you were to use posterior referencing systems, if you are using in a severe varus, you tend to internally rotate the femur. So for me, there are 3 things in knees which are complete no. Internal rotation of the femur, internal rotation of the tibia, and overhang on the components. These 3 things in my book should not happen. If you do this and ensure that you're not doing these 3 mistakes, what I call mistakes, you will get a extensor mechanism which is aligned. So the best way to answer your question is if at the end of your trialing, you can take that knee through a range of 120, 130, whatever, and your patella does not move. It sticks to the groove. I think you have done a great job regardless of what alignment philosophy you used or whether you used robotics or not. I think the ultimate consensus in my head is your extensor mechanism. If that is in place, do whatever alignment you believe in, and you'll be a happy surgeon.
So as far as femoral component rotation is concerned,
3 degrees.
You don't go by any of the references, for example, white side line or.
I don't use white side line because that's often very hard. I just use the epicondylar axis. I use the epicondylar axis and I use the resection of the tibia. I use two lines. Because using one line, you might go wrong.
But you are a femur first surgeon, aren't you?
Sorry?
You are a femur first surgeon, aren't you, sir?
I'm a femur first surgeon.
So reference of tibia, you have already done your femur, so that would actually
again,
not help you.
Great point. So I didn't actually demonstrate it because that's pretty unconventional. So what I'll do is I'll put my tibial resection guide in place. I'll mark out with a cautery and I make sure that I'm parallel to this.
Right, so that is the kind
Yeah,
of reference.
I mean, I didn't show it here because that would be completely unconventional. Yeah.
Correct. Thank you, sir.
Right, I think we can conclude this session. Thank you, Ashok, for
Thanks,
a wonderful
Hemant.
demonstration. Thank you.
Thank you, sir. Thank you. Thank you, panelists. Thank you. For our next talk, I would like to invite Dr. Jayant Arora sir on the podium to present his talk on medial pivot knee. Does design translate to function?
No problem.
Good morning, you all, and it's an absolute pleasure and an honor to be amongst you, and especially amongst stalwarts like Dr. Rajgopal and Dr. Vakankar and many others in the podium, in the hall. So today I've been given this opportunity to speak about medial pivot knee, and the reason being that we have started noticing more and more companies coming up with this particular design. So I thought that we have developed the holy grail for knee implant designing, because 20 years ago, most of the talks was about knee implant design, and for last 10 years, it has been about, as Dr. Rajgopal said, alignment philosophies and how do we dial those alignment philosophies accurately using technology like robotics or AI or computer navigation and handheld navigation and whatever else. So all in all, a little bit about medial pivot knee. So it all started with this paper from Michael Freeman from UK, which described natural kinematics where there was a medial pivot and the lateral femoral condyle rotates around that medial pivot. And none of our implants, TKR implants, are supposed to emulate this type of natural knee movement. And then this is how it ignited some of the smaller implant companies to come and to devise and innovate knee implants to emulate this particular movement. So essentially, medial pivot knee matches the rotational axis not only in the coronal plane but also in the rotational plane. It gives lateral stability and it gives medial stability and lateral mobility. And hence, it tries to emulate natural knee kinematics. So essentially, the basic design component is a ball and socket type of joint on the medial compartment, which is essentially a single radius articulation. We have single radius articulation for very long. We know some companies making single radius knees for decades, but those single radius knees did not have this medial pivot function. And of late, more and more implant companies are coming up with this medial pivot function. Having this medial pivot knee implant design gives us an excellent antero-posterior stability, which was demonstrated by these two studies using KT dynamometer. You know, KT dynamometer is a standard device that we use for testing ACL reconstruction stability. So they used this device to test antero-posterior laxity after TKRs, and they found that the medial pivot knees were better than PS, they were better than CR. The only knee which was slightly better than medial pivot was a partial knee arthroplasty, where they had an intact ACL essentially. So theoretically, using a medial pivot knee will take care of mid-flexion instability, which has been one of the bigger problems as well as functionality, and patient happiness is concerned with our knee implants. Being a single radius knee, it also gives better biomechanical advantage to quads power. We have a better posterior condylar offset with these knees, and this was again demonstrated in a study by Hamilton with 212 knees, where the power output of a single radius knee was 116% of the contralateral leg, of the normal leg, and compared that to standard PS implants, which have J-shaped curvature, it's 90% of contralateral implants. So activities like climbing stairs, standing up from a low seated position, they become much more effective. Patients are happier, they have a better functionality score. As per this study, they should have. Now, whether they have it or not, we'll come to know of it. Now, it's a very interesting study by Pritchett. He did one knee middle pivot. On the other side, he did something else and found that 3:1 preference to middle pivot knee, whether we compare a CR or PS knees. Another large meta-analysis which compared nearly 4,000 knees, PS as well as MP from Ireland. Again, the results showed better range of movement, better kinematics leading to better KSS scores, and a comparable revision rate. And of course, there was a lesser of mid-flexion instability. Another large study, meta-analysis, more than 3,500 studies, which again reiterated these findings that a good survivorship, revision rates as less as 1.9%, and revision mainly happening due to infections, not because of any other implant-related failures, but mainly because of infections. Coming to registries, coming to the larger data, we are now starting to see middle pivot knees more and more frequently in all 5 big registries. The numbers are gradually going up. And on top of that, what we are starting to see is that at 15 years, these middle pivot knees have good survivorship, or they have the best survivorships at 15 years. It's in UK and Australian registries. And the crossover points between a CR and a middle pivot knee starts to happen at around 13 years. So as time has gone by, we are seeing that they are probably non-inferior survivability-wise to our standard implants. However, some of the studies also suggested, especially coming from Australia, that there are certain patellar tracking issues with these implants as well. So one has to still keep an eye on these things. So the question here is that, is this implant design for real, or is it something similar to various implant designs we have come and seen gone by in the past? Nobody heeds for them. And my thought is that it is probably for real. It offers some improvement, and we can judge that by looking at consistently increasing number of patients undergoing these procedures. These are the, we can see 9.8% of knees now are done in Australian and New Zealand general registries. 9.8% people opt for these implant design, and we can see more and more surgeons picking up these particular implants. So, and we also are aware that a lot of bigger companies are coming up with these middle pivot knees. So essentially, it's a good kinematically designed implant. If it is combined with our conventional practices, it can probably give a better kinematic functionality to the knee and overall a happier patient. Thank you.
Thank you, sir. Any question?
Yeah.
Thank you so much. So moving forward, our next talk is on the collared versus collarless stem, necessity and outcomes. I would like to invite Dr. Saran Patil, sir, on the stage.
Yeah, thank you again. And now let's move to the hips after a while. And this is collar versus collarless stems has become a question of debate these days, and we see more and more shift globally and in our own country. Is there really a need to change to collared stems? That's something which we will see. There is a compelling argument to change and what real value it has. So in 2025, we keep saying the hip and knee has become a very mature science, and we get very predictable results. In spite of all the alignment philosophies, everything seems to be giving good results. And when we are talking about all these alignments and everything else, is to see how we can fine tune and make it even better than what it is today. So a uncemented hip is pretty much felt like a solved problem, but still there are a few things which persist. The implant I use is a Corail implant, and this has been a wonderful journey, and it's got one of the best track records in the world. But still there are 3 problems which seems to persist even with Corel in the longer version of the game. Early periprosthetic fractures within 2 to 3 months with any uncemented for that matter, but that's one. Loosening of door A or door A mode of failure when there is distal welding of the implant and proximally it goes loose. Obviously that's another problem which has been realized more and more with failures coming in. And fracture neck of femur, when you have a very wide canal, how do you use an uncemented one? That seems to have challenges. If you look at the registry and these 3, what I just mentioned, periprosthetic fractures and the subsidence and also having a challenge with osteoporotic seems to be the highest number of revisions. It's the number 1 uncemented in NJR, Australian and Norwegian registries, number 2 stem in US registries, number 1 stem in India. More than 50% of the stems we put in our country are of this mode. And if you look at this, there is data of 15 years, and there is something to talk about collared stem. And at 15 years, that seems to have the least amount of revision as against others. And please note, even cemented stems have done so well. You have changed over and cemented is being done less and less, but one needs to understand it is still a very good way of doing a hip replacement. There are a lot of studies to see the stability and outcomes. When you seat the collar onto the calcar area, the micromotion seems to be much less. The stability seems to be much more. If you don't seat the collar onto the bone, then obviously it is comparable as long as you're able to fit and do the entire technique of an uncemented hip as done, then you can clearly see the stresses on this. So collared Corel specifically, or for that matter, it's a growing habit across the world. And we see more and more, and what's interesting is when all the companies are switching over to collared, you know it's getting very popular. Have they got enough reason? Let's explore in the next couple of minutes. But many markets have almost taken away the non-collared ones. For example, in France, there are no non-collared ones. Britain has switched so heavily towards collared ones. So let's understand what this is all about. So cylindrical, and when you have a wedge taper, typically a metaphyseal fixing, one uncemented one, we have a wedge taper. And if you understand the simple logic, when you have a wedge taper fitting into the canal, it's a round canal. So what happens is, if there is any subsidence, it's likely to split it open. And that's how you get fractures. So it's very different from cylindrical tapers. When a cylindrical tapered stem gradually settles in and there is a controlled subsidence, there is no problem. But when you're putting a wedge tapered one, a little subsidence also could have a detrimental effect and crack it open. And that's why it tolerates much less. This collar acts like a safety belt. It doesn't allow it to go beyond a point. And that's why when it's wedge, it splits open and causes fractures. Literature supports this. There's a lot of studies, in vitro studies, to show that the forces are so much more in an uncollared one, and it takes less force to settle an uncollared one as against the one which has got a collar. So we talked about axial stability. Let's look at rotational stability as well. Because the collar sits on the calcar, it acts like a torque limiter. It doesn't allow the stem to rotate. So there is rotational and axial stability with this. Evidence seems to be very compelling. There is a lot of in vitro studies and there are a lot of examples where this has been possible. So this argument seems to be getting stronger with so much of evidence. Let me take you through a couple of examples. This is a typical fracture which you can appreciate on a CT scan because patient had pain. There is a crack in the proximal femur, but it is collared, it has subsided as you can see 6 months post-op, but the split has not become more and it's completely healed up and patient goes away without pain. So this is possible with a collared one. If it is not collared, it probably would have split it open. So this particular one has got it open. Would this have done better with the collared one? Maybe. That's what is possible. And that's why I said immediate weight bearing in a hefty person, somebody who's very active also is subject to some amount of subsidence, and using a collar seems to help. So that's the movement. And fracture neck of femur, invariably the bone is not great, and also the anesthetists are not very happy for us to cement it. And if you are doing an uncemented one, pretty much today I always use a collared one because it's got some rotational stability as well. And collared one prevents subsidence that much better. So that's the one, as you can see it. Fracture neck of femur, like I mentioned, sometimes we are compelled with the patient's general condition, invariably osteoporotic, and that's what happens. So should non-collared corale be given up? I don't think so. I mean, at least I haven't had any problems. I must have done a few hundreds. And if you size it right and do it properly, no fractures, no subsidence, except Doré failure. But Doré failure has got a separate reason and nothing to do with the collar. So to give a summary of this, if it is a Doré, and that's a different reason, both collared and uncollared will work, but you need to widen the canal. If it is Dorby, both work again perfectly. There's no problem about that. If it is Dorsey, invariably you need to go towards a collared one. So collared one can be used everywhere, but uncollared one or a collarless one has still served very well. Unfortunately, the industry is pushing us towards a collared one always. As long as the cost is not a factor and we do this technique well, I don't have a problem. Calca fractures towards Dorsey, fracture neck of femurs, obese, high offset patients, highly active patients, maybe there is a case for collared steps. Thank you.
Any questions from the dignitaries?
I am Dr. Amin Shah. There were collared stems few years ago in the market, and they were driven out saying that it causes osteolysis and shielding just at the calcar region, which is supposed to be the most stable region.
Yeah.
Now again they have come. So what is that stress shielding effect which was there at that time?
I completely agree. If you do not have the correct fit, and the calcar goes and rests on the calcar, the remodeling does happen, but if the forces are not transmitted equally all around, you are going to have stress shielding. There are two major problems of collar. The direct anterior approach people somehow in the learning curve don't put the complete fill the canal, and they tend to depend on the collar for that, and that's not a good idea. And second thing is some of these makes have a very large collar, and that causes psoas impingement. And there are two things to watch out for. It doesn't take away the need for sizing it correctly and doing it. And one needs to see which are the makes which have a smaller collar rather than a large collar which can impinge on the psoas.
Sharon, thank you. Excellent presentation. The corale stem, collarless, has been doing so perfectly fine.
I agree.
Till the time we started seeing its late failures at 10, 12, 15 years.
Yes, yeah.
And that's a major issue.
Yeah.
Would you like to explain the
two
reasons
things.
for that? Yeah.
Door A has got a problem because
Door
this
A,
is
yeah.
completely coated and it tends to weld distally. So opening up the canal with reamers and making sure the tip doesn't integrate before, so there is some amount of gap there, so that it truly is a metaphyseal fill, then it works well. So door A, collarless does not matter.
Right.
So the other area is impingement, like I spoke about. So fracture neck of femur, door C, the collarless one is really doubtful how well it works.
Absolutely.
And that's where collars will have an impact. Yeah.
Thank you, sir.
Very much.
For the next talk, I would like to invite Dr. Harvinder Chadha on the podium to present From Data to Decisions, Significance of Joint Registries in Clinical Practice.
I think everybody knows about joint registries, and I'd like to just cover the advantages and where it's heading and where the participation can improve the outcome and the reliability. There's various registries, I think everyone is aware of them. I'm coming from the United States, and we're just starting out our registry. It has limitations, it has low numbers compared to the major registries, but I think we can improve upon it, and then I think it's a similar intake as what we've seen with the larger registries. In general, joint replacements are obviously the most successful surgery that we've done worldwide. So now we're growing, and the issue here is that the competition is limited. And I think it's a fault of our country where we limited the healthcare industry, but I think now we're expanding, and the registries have been advantageous and disadvantageous. The hope was to do implant surveillance worldwide, and the outcome has been variable, but I think we can improve upon it and make it reliable. The best thing is that we're putting in the data in every single one of us. So let's expand upon it. The background that this is a high value intervention, cost, so everybody draws attention to it. There are registries, and then how they relate to the clinical and healthcare system. Even in my country, it is basically a report card that is issued annually to us to see whether we meet the local criteria and the benchmarks, and then the bigger benchmarks. So we'll look at some of the innovations, and then where it relates to evidence guidance, and then finally we'll see some future direction. Where this falls into is that the hip and knee arthroplasty have grown considerably, globally, and we've seen the indications expanding. As they expand, we've seen that these implants are better and hopefully more durable. And as they become more durable, are they really durable? And when they get to the 10-year mark where we think that this is done, we still see complications. And I think these have been well discussed, especially even in the last discussion. Patients that are now becoming younger, they also have more complex comorbidities. So you have to kind of like see where this thing is coming, where your clinical research is coming, and then somewhere this fits in. And the best advice after looking at this topic, the best advice is the more we put in locally, the more reliable the data. So let's look at some of the definitions. It's longitudinal and it's systematic, and the patient's demographic and risk profiles are now starting to be entered. But there's still more general profiles. And what we really are interested, what I'm interested in is the implants, the bearing surfaces, and then finally the fixation types. Those are just starting to be entered in my hospital, so I imagine that it's still slowly improving. Surgical approaches are now also being entered, so we're starting to get more variables, and all those variables, as we enter all those variables, the larger that number, the more reliable the data. I still have trouble embracing the registries and when it shows a failure, and so what we want to do is also put in the complications, the revisions, and the mortalities, but these are still broad characteristics. Increasingly, we'd like to put in how the patients respond. And I think, the presentation with the medial pivot, it's really talking about the patient outcome. But now we can take that reported outcome and then pull back on it and say, okay, this is what, even though it is a different looking knee, it has kinematics, but what is the patient experience and why is it becoming better accepted from their perspective? We just look at the x-rays and the durability, we look at longitudinally, but does it really make a difference to the patients? And one of the studies that was in there, Pritchett, is actually a study where the surgeon was forced to use another implant. And so he had same patients, 2 different implants. And that study is valuable. And that is like a local registry study. So that's how you can increase the patient-reported outcomes. Why is this important? Well, I think you can drop down the diversity. The diversity, now we're worldwide. So as it becomes more diverse, do those papers that put out small data sets, do they really apply to different diverse populations? And I think they do, but again, it's not an assumption. So implants, performance, and surveillance. Obviously, we all want to know about early revision rates, and I think the ASR reflected that, the metal on metal. And what we really want is the post-market surveillance. Everybody says, you know, my implant and my surgery is the best, but does it transfer to the hands of other people? Evidence-based registry and procurement decisions can really be supported by this registry, but I still caution all that. One of the ways that you can see over time, not just the implants, but us operating, and you can see the UKA is done in the Netherlands. The top graph is in 2009, and then over time in 2019 and 20, you see the revision rates have decreased. That's our technique. Okay, we're getting better at it. So that's what I'd like to see, also in addition to implant surveillance. So what happens? Clinical decisions, we make different implants, we get diverse patient population, age, female, male. Now we can have a surgical plan that is based on longitudinal data. So we can have different bearing surfaces, and I think, you know, polyethylene has now dominated it. Cemented versus cementless. I was cementing when I started, and went cementless, and now I'm coming back to cemented, even on the hip side. So there are different patient populations that are better. We can inform and make some actionable items that become practice. But different places, when they start to put in the quality improvement across institutions, those increase what we can and cannot do. In Michigan, there is a registry where they make changes. So biopsying the prostate, using 1 versus 2 antibiotics caused the patients not going to the ER as much and getting sepsis from it. So those are the simple registry data that if you really embrace it as a community, as a state, then that will actually give you better data that's coming out of your registry. Again, patient-reported outcomes. Now, the last thing that this thing is doing is it's allowing us to do innovation. And innovation is where we're all here. And we want to do it better, we want to do it easier, we want it to be more reproducible. So I think this is the registry supporting innovation. And we can monitor it, we can quote it, and then we can eventually, hopefully, give us some surgical risk models where we can say, okay, this is going to fail, or this is going to be what the course will be afterwards. Finally, patient-reported outcomes.
So we'll request to summarize, sir. Let's get
Thank you. So the patient-reported outcomes, they're just starting, and it really is a shared decision-making model. Lastly, limitations. And I want to jump all the way down to the bottom. It does identify trends, and it's not cause and effect. So that is where the caution lies, and you really have to tease down what the cause is. And that's the caution. And there's been too many consequences of us drawing too much conclusion from the registry data. Thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Rajiv Sharma, sir, to present his talk on evolution of hip arthroplasty, past, present, and future.
Thank you so much, Dr. Pachore sir and the team Ortho Trend. I have been asked to speak on the history of total hip replacement, past, present and future. And you see that if we take a few steps in the history, you see the 1891, we had the first attempt on the hip arthroplasty. And as the time went, by 1920, we had the interposition arthroplasty. 1960 was the important date when the John Charnley came up with his low friction hip arthroplasty. Later on, fully cemented to cementless and hybrid. Further work on evolution of the cementless stems and how to make it better offset and better HA coating. And then nowadays what we are talking about is the robotics and AI. The important date of 1961, the first publication from Dr. John Charnley, it was the landmark paper, and that has the present day hip arthroplasty is so much dependent upon all the work of the Dr. John Charnley. It has shown us the very good results, long-term follow-ups up to 30 years. I have revised myself a few of the implants, cemented hip implants of Dr. Dholakia, done 25 to 30 years back. When we talk about the hip arthroplasty history, the Dr. Chit Ranawat name definitely we must take. And then after Dr. Dholakia from India, and many more surgeons from India and abroad. And here Dr. Pachore. I have been lucky enough to be in company of the giants in my early years of the practice. This is the picture of the 2004 Beijing APAS meeting. I started hip arthroplasty somewhere in early 1990s. And let us look at what implants came and with a big bang, and then they disappeared from the market. Now this implant, many of the senior surgeons in the audience will definitely recognize, and this implant is isoelastic hip arthroplasty. It started in India somewhere around 1994. It was started by Robert Mathis in 1973. It was the cementless with the stem made of the polyacetyl resin. And this started with a big bang that it will be one of the wonderful hip implant. But later with time, we saw some disastrous results of this implant. That's what you see here. And this implant has been creating not just the aseptic loosening, but a huge amount of bone loss. So obviously this implant has disappeared from the market very soon. The second I'll mention here, AML stem, which some of the senior surgeons have used for sure. AML was the precursor of the solution stem that is today the Dr. Ang's implant. This was a fully coated implant, stainless steel implant, and solution came up from the AML stem only. And that's what you see, the solution stem, which did help us in various difficult revision hips in a big way. It was a fully coated implant. Like you see in this difficult case, at a follow-up of 2 years, we could have the reasonably good result. But you see, the two major issues of the solution stem that were noted by all of us was the breakage of the stem and a very difficult to almost impossible extraction of the implant in certain situations where the implant has taken up very well. And one example, that is stem breakage. And this patient, in spite of our best efforts, we had to do the mega prosthesis, and that's what the patient is walking at 2 years post mega prosthesis. Metal on metal hip arthroplasty we must mention because it came with a big bang and went off. And how it was, the two aspects, one is the surface hip arthroplasty and the total hip arthroplasty. My patient of almost year 2000, I think, the avascular necrosis, arthritis of the hip, BHR, And this was the patient doing very well post BHR. He was doing excellent function, and today this patient is at a follow-up of almost 24 years and doing extremely well. Many other patients did well. Many difficult situations like this, the BHR was still functioning very well. This patient with the arthritis of the hip. And for the young surgeons, I'll prefer to explain them, because this is the implant which I think the senior surgeons have seen, and the younger colleagues may not have seen it, the surgical process of this. That's a 30-second fast track video of this BHR. I think it was taken up by me in around 2002. So this was a very, very accurately done. The hip, the femoral head was to be prepared and had to be kept under the fold of the glutei, and you just shape the femur, and then you fix the implant. Even in the conditions, the BHR, where you may have some amount of defect in the femoral head, the BHR still functioned very well. That's what the patient walking post BHR. Some examples: 15-year follow-up. That's another 10-year follow-up. But a badly done BHR, because this was a technically very demanding surgery. Here the surgeon who has operated this patient had probably reamed the neck, not just the femoral head, and that's how this patient had the fracture third post-operative day. And with this, the cue was taken by some companies, and they came up with the copy of the BHR, and then this was also added as for the total hip, metal on metal, total hip arthroplasty. Here, use the ASR cup and use probably this was the coral stem. And then this patient will do well. So, one very interesting case, long follow-up, infected case, solution stem and ASR cup. That's what at 1.5 years, and this is the 13-year follow-up, and you see at 20-year follow-up, this patient still did very well.
Sir, as we have packed schedule and we are running late, I would request to.
Yeah, just 30 seconds, I'll finish it.
Thank you, sir.
Yeah. So the various implants that have come up and went off were for a reason. The wrong choice of the implant or wrong technique. That's one last example of the wrong technique of the cases. And here obviously the ASR cup slipped. So the wrong implant and wrong technique both will lead to a major issue. Short stems came and went for various reasons that we all know. Now some of the good implants like the delta motion, ceramic on ceramic, was an excellently functioning implant, but this has been taken off the market because of the reasons of probably the stock was difficult for this, or the surgical technique probably. So in brief, if we look at the history of the hip arthroplasty, it has been a very interesting history. The implants have come up and went off. What is important is that whichever implant we choose, it must have a good track record, and the technique must be understood very well, learned very well, and practiced very well. Thank you so much.
Thank you, sir. Thank you for such a wonderful demonstration. For the next talk, I would like to invite Dr. Hemant Wakankar, sir, on the stage for his talk on Is Bilateral Safe?
At the outset, let me ask here, how many of you do one stage single anesthetic bilaterals? Yeah, about 30%, 40% maybe. Right, I've been asked to answer the simple question, is one stage bilateral safe? It's not moving. Okay. I'll be the first one to admit that this is a controversial topic, but the idea is not new at all. I mean, on the left-hand side is the paper more than 40 years old, and that's talking about single stage versus bilateral simultaneous. And a recent paper from 2022 is talking about outpatient one-stage bilateral. So we have come a long way in last 40 years. Patients do prefer bilateral surgery for a simple reason that it is convenient. A single hospital visit, both surgeries get done. Recovery is almost simultaneous, and it's certainly economical. Surgeons are reluctant in many respects. One is the infrastructure and the outcome of the surgery. If they're not confident about single, they may not be wanting to do bilateral. Experience is an issue, confidence in the outcome, and obviously concerns about morbidity and mortality. Economics certainly can play a role, especially insurance companies are creating a hurdle, and medical legal aspects, especially in some states where there was a problem some time back. In the registry, about a couple of years back, there were almost 18% total knee arthroplasties in this country were performed as a single stage bilateral. The question asked is it safe? My answer is yes, but the devil is really in the details and what you really do and how you do it. Patients and relatives have to be willing, first of all, and they need to understand the benefits and the risks that bilateral one-stage surgery poses. I'm going to present my experience. I'm not by any means suggesting that this is the way to do it. There are obviously many other ways of doing it. I'm just going to present my experience over the last 25 years. Two people have been instrumental in the really, enthusing me in one-stage bilateral. One on the left-hand side is Bob Booth, whom I visited in 2012. And second is Ashok Rajgopal, who has really, been the champion of one-stage bilateral surgeries. This is my record over the last 25 years. And as you can see, I started around 2005 with one-stage bilaterals. And over the last 15 years or so, I've been doing about 500 odd patients every year with one-stage bilateral. So my pre-surgery workup is this. I'll just go into the details a bit later on as well. My patient selection, I think the exclusions are that BMI above 40, I would not do bilateral. Absolute weight of about 90 kgs. It used to be 100 kgs. I'm just being kind to me now, and I'm reluctant to do anybody above 90 kgs, especially patients with big fat legs. HbA1c above 8, I would not do even a single knee. 2D echo ejection fraction has to be above 40%. Hemoglobin has to be about 10 for osteoarthritic patient. Any patient with obstructive sleep apnea, I will not do bilateral. History of DVT, PE, again single stage. Chronic liver disease and interstitial lung disease, especially somebody who's had COVID, I'm reluctant to do bilateral because even single can be a problem in such patients. You can please note the two important omissions here. One, chronological age is not a contraindication in my patient. In my series, I have done even 87, 88-year-old patients who are perfectly fit and healthy, one-stage bilaterals. And any previous history of angioplasty or CABG is not a contraindication provided their heart function is good. So I work in a 1,000-bedded private multi-specialty hospital. We have dedicated OTs with laminar airflow and HEPA filters. All our patients do have pre-op counseling. We admit the patients one day prior, chlorhexidine bath previous night and the morning of the surgery. Surgeries are done in the short-acting spinal. IV antibiotics and tranexamic acids usual, steroids as well. Topical tranexamic acid is routine in my use. These are the pre-medications that we give to the patient, nothing unusual here. We prepare both the legs together. I'm just going to show you my protocol and how I do it. Both legs are prepared simultaneously. And this is how both legs are prepared. We start with the one that is more painful as a first surgery, and second leg is kept wrapped up. We start the surgery on one side. We lavage the canal. This is a conventional surgery. Even the robotic I do exactly the same way, but just the robot added on. So we lavage the canal for conventional surgery with pulse lavage, and that prevents the fat embolism incidence. We take care of the lateral genicular artery in the bed of the lateral meniscus. Every single time I really cauterize that bed very well because that is one source of bleeding. This is the pericapsular local infiltration given. These are the components that we use. And that is given before implantation and at the end of the surgery as well. We flood the knee with tranexamic acid. At the end of the surgery, after the tourniquet is released, this is our typical tourniquet time. Provided all our parameters are fine, we proceed with the second side as my assistant is closing with the first side. So that is how I start the second side. And by the time the closure is done, I'm ready to implant the second side. So that is how we prepare both. Post-op protocol is patient is made to stand in a matter of 3 to 4 hours as soon as he recovers from the spinal anesthetic. We have to have twice a day physiotherapy until discharge, which is usually typically on third or fourth post-operative day after the bilateral surgery. Pain relief with various measures and discharge again on third, fourth day, as I said. I'm just going to show you results of last 22 and 23. The last death I remember with the bilateral was pre-COVID, and that I think was, all these criteria that have evolved over a period of many years now, and that actually was a patient of sleep apnea, and we then added that as a criteria that will not do single stage bilateral. So all these results are for those two particular years, over 900 patients, majority of osteoarthritis, previous orthoplasty and CABG, previous angioplasty and CABG in 30 patients. As you can see, age more than 75 in 12% of the patients, 117 patients in this. We had, this is the BMI, this is again 90-day mortality was 0. About 3.6% patients had needed blood transfusion. Let's see what the literature is suggesting. I think problems with the existing literature is that RCTs are not going to be possible in these patients. Most studies are retrospective. There are various biases that are introduced. This is, I think, an important paper that you can go through that talks about the consensus for one-stage bilateral. There is paucity of definitive evidence regarding safety. They have suggested that, good evidence for certain, like Ashok mentioned earlier, they have shown these evidences, and for age, there is no definitive age cutoff that is known. ASA grade, we all know that higher the ASA grade is poor outcome. Mortality, again, there is insufficient evidence whether it increases mortality or not. This is a paper from this year's Journal of Arthroplasty, and that has said that there is increased surgical mortality with one-stage bilateral. And what they're suggesting is that in-house hospital mortality is 0, but at 1 month and 3-month mortality is high. And I wanted to check those papers that are quoting higher mortality. So this paper they have quoted is from Weiss in 2019. I went back to that paper to see what they are actually saying. And this paper does not suggest higher mortality. So what this paper quoted in the original as higher mortality was actually not corroborated when I crossed back on the original paper. So there is a lot going on there. Why would they, give a wrong references only that they would know? There is definitely likelihood of increased morbidity with pulmonary disease, cardiac disease, and a history of thromboembolism. So these are my these are the exclusion criteria that they have suggested. And as you can see here, again, most of these criteria we have incorporated in our protocols. Funnily enough, there is in fact lower incidence of infections if you do one-stage bilateral as compared to stage bilaterals, and you can't really explain that. So conclusion, I think bilateral TKRs in my hands is safely undertaken in medically fit patients. Chronological age for me is not important if a patient is otherwise fit and willing. Potential benefits and risks have to be balanced in each case. Patient selection, infrastructure, and your own experience as a surgeon is critical. Are you going to deny this patient who actually is absolutely fit and healthy just because of his chronological age, bilateral TKR one stage? I think answer should be no. Thank you.
Thank you, sir. Any questions? Yeah.
Well, I can relate to my numbers and I can explain. This is what I have been doing. And in fact, today I have the problem the other way around. Patients who do not need the other side being done, just because in the community they have had so many patients with bilaterals, they come demanding bilateral, and I have to convince them that you don't need the surgery on the other side. But obviously you have to tell them that there is increased risk, but I have been doing this for a long time, and the possibility of something going wrong is less than 1%. That you explain even for a single knee.
Most of the patients ask for bilateral because
they are today asking for bilateral, and I have to actually tell them if they don't need a second side. Right, thank you.
Thank you, sir. For the next talk, I would like to invite Dr. Adarsh Anapareddy for his talk on role of robotics in revision THR.
Very good afternoon to everyone. I'd like to thank Dr. Pranay and team Ortho Trends for inviting me here today. So this is a topic which I'm quite passionate about, the role of robotics in revisions, because revision THR is much more challenging. It may benefit much more from robotic technology than regular primary THRs. It can help in better bone preservation and better placement of the implants, and this space is still not fully realized. Now, of course, there are robots coming up, there are upgrades coming for robotics in revision, but as of now, all the usage is off-label. So the challenges of using robotics for revision THR, because there are metal artifacts already there from the previous implants, it's difficult to take the CT scans. The registration of the bone or the implant surface, it's difficult because you have loose implants and the availability of bony landmarks are no longer there. And a new bony landscape after removal of the implants, which will not match the registration of the CT scan which was done before the surgery. So this is a case where we use this technology for revision. It's a 58-year-old lady, rheumatoid arthritis, cerebral palsy, so a lot of compounding factors there. She had a left total hip with us in 2016 and a bilateral TKR in 23. She came for a right conventional total hip with dual mobility in December. She had a fall and the right hip dislocated in May, and it was reduced, the closed reduction was tried, it was not stable, so they did an open reduction in Mumbai with a +4 offset. She dislocated again in June, even without any trauma. So this is a primary total hip, this is the right hip we're talking about, and this is the primary hip which was done. And when it was dislocating, this is the head which is removed, and they put in a +4 head. She dislocated again when she came to us. So we did a calculation. Obviously, we found that the initial cup was quite highly inclined. It was 54 degrees, which is way too high. So definitely the primary surgery which was done itself was probably not a great idea. So the sacral slope, the important thing over here is the delta between the sacral slope sitting and standing is 8 degrees. So that's a stiff spine. So that's another compounding factor. So these are all the points that we consider. It's dislocated twice already. There's spasticity because of cerebral palsy. The cup is already too vertical. So the question we asked is, can we use robotics to plan for stability and execute the plan accurately? So we did a CT scan with the MAS protocol, and robotic segmentation was done, and a pre-op plan was made available. So the robo assumes that this implant is a regular primary hip. So you can see how it looks once we're doing the planning stage. This is the actual implant, but the robo is considering it to be the bone. So this is the view intraoperatively. So most important part of any robotic surgery is the registration part. And as I mentioned earlier, the robot is assuming that the cup is actually bone. So you're taking 40 points on the acetabulum. So you're taking these points on the cup itself. So this is what we did. Luckily, this is not a case where the implant is loose. So we could manage to use the robot here. Okay, so you've registered the multiple points here. And once you've done that, you have to verify the points again. So all the 40 points are conglomerated into 6 bubbles. So you again check with the probe whether you're actually touching the implant or not. So you have to see that this distance to bone turns green. That means you're on the right depth. And once that comes correctly, your bubble becomes green. That means you've cross-verified whether your registration has been accurate or not. So once you've done the verification, we remove the cup, we remove the liner and remove the cup. We have to take out the screws in the cup. And then we have a proper bed. So then we go for the planning, where we actually plan for the proper size. So you can see the CT scan, you can see where the bone is. So you can actually plan in the transverse view, the sagittal view, as well as the coronal view, what the right size of the cup is. And also we can plan the inclination and the anteversion. So this is the sizing that we went for. We went for a 54 mm cup. Okay, and this is what a 54 mm cup would have looked like. Then the stem. So how do you plan the stem? The original stem which is already there is looking white. So all we do is we take the virtual stem, make it exactly parallel to the white stem. So we know exactly what is the stem version that we're dealing with. So this came to around 9 degrees of stem, 10 degrees of a stem version. So this is what we input into the robot. So the robot now has data about the stem version as well. So once we've entered the data about the sacral slopes and the stem version, now we take it through something called as a virtual range of motion. So sacral slope values have been entered now. So sitting and standing sacral slope. And then we take it through a virtual range of motion where we take, we see here in standing 15 degrees extension, external rotation, we're impinging posteriorly. So we've reduced our anteversion further to make sure that we avoid that impingement. Also, we've reduced the cup inclination because we found that our initial cup was quite highly inclined. So we've reduced that. So our final target is 35 degrees inclination and 15 degrees of version. Then we go for the reaming. So this is robot-assisted reaming. So we still have power to move around in a 15 degrees of a haptic. So it's not like you're stuck. You can actually move around within 15 degrees of a conical haptic. So you can see that green over here, it suddenly disappears because there's no bone there. So it suddenly disappears, and the remaining part is the part which needs to be reamed away. So this is what we do. We just take out that green area with the reamer while looking at the screen. Okay, so that's what we've reamed out. And then of course the impaction. Here, the impaction, the robotic arm is locked into what we have planned. We've planned 35-15, it locks into 35-15, and you just bang it in. It also lets us know how much deep we need to go further. The distance remaining, you can see over here, we're 3 proud. You keep banging it until it becomes 0. Okay, so once our cup is in, we put in our screws and we recheck. So this is what our implanted cup looks like. We put in our liner, and then of course the final reduction. After the cup is in, we put in a dual mobility head again. Okay, went in pretty well. And of course the stability check is the most important thing. So we check the extremes of movement to make sure that there's no dislocation. Post-op X-ray, as you can see, we've reduced our inclination quite a bit. We've reduced our anteversion as well, as per our virtual range of motion, and we got a good stable hip. So this is what we started with, and this is what the first surgery looked like, and this is what our final outcome looked like. Just if you we went through some literature to see robot-assisted revision total joint replacement. They've compiled together different studies where they've used the robot in total knee as well as total hip in revision, and they found that the feasibility of robot-assisted technology in revision total joint arthroplasty can help surgeons to perform preoperative plans and accurately achieve the operative targets as well. Thank you, and I'd like to thank our team, Sunshine. Thank you so much.
Thank you, Dr. Adarsh. Any question from the audience? Thank you. So we'll move forward. The next talk is fixed bearing UKR, surgical technique insights. So I would like to invite Dr. Rajiv Sharma sir on the stage for his presentation. Thank you.
Thank you to the organizers once again. I'll be speaking on the basic principles and surgical technique insights of unicondylar. Now, when you have this kind of a patient who has a primarily medial joint involvement, probably that is the right indication for the unicondylar knee arthroplasty. Initial Cozen and Scott criteria were quite strict: isolated middle compartment arthritis, no lateral joint tenderness, intact ACL, etc. But it was redefined in 2000, where the age restriction was not there. The weight restriction increased less than 90 kilograms, flexion contracture less than 15 degrees, varus and valgus 10 and 5 degrees each. Further revisions have happened which have further relaxed the criteria for doing a unicondylar. Now friends, how to choose the right candidate? Now this patient is a 58-year-old female having the mild varus. You see that medial joint is primarily involved. Must do the stress views and see that lateral joint is not affected. ACL is intact. Post surgery, you must ensure that the lateral joint is not overcrowded, and then you will have a reasonably good result in all these cases. Right implant for the right indication has the best outcome. Say for example, on the right side of this patient, the lateral joint is involved, so probably a unicondylar is not the best option. So in this patient, the side where it is indicated unicondylar surgery, and on the other side, the total knee arthroplasty probably is a good option. Bilateral unicondylar osteoarthritis in a 65-year-old female. Stress views are must in all the cases where you are planning and thinking about the unicondylar knee arthroplasty. Exposure, the lateral Homans retractor is protecting your ACL and also giving you a little bit of guidance where your medial, where your tibial component can extend to. The best bet is lateralize it as much as possible when you are doing the medial unicondylar knee arthroplasty. Make sure that when you are making the vertical cut, the saw is not cutting beyond your cutting level, and the medial Homans retractor is protecting your medial collateral ligament very well. In one go, when you take out this tibial cut like a biscuit and then complete it with the osteotome, Be careful that you are not damaging the MCL or damaging the posterior structures. That will minimize the pain post-operative. And see that how much the laxity, the flexion gap. And once you are sure, touch with the finger and see that how much tension, physiological tension of the MCL is acceptable. If it is too tight, that means that you have cut a little bit of lesser tibia. In that situation, do not recut the tibia, but go to the femur. That's what the femoral component. In the interest of time, I'll just forward it. Make sure that when you make the distal femoral cut, it should not be more, and you are protecting with the osteotome the tibial surface. And sometimes you have a very sclerotic bone, so your saw blade is ready to deflect. So be careful that you have cut it in the right plane. And once you do that, take the two spoons and then see that whether the extension gap is properly maintained. And once this extension gap is good, then you can choose to go for the further cuts. Make sure that the alignment of the femoral component is correct. And in this fixed bearing implant, you need to keep the femoral component at perpendicular to the tibial component. And once you are sure that your placement is right, then you make the cuts, the chamfer cuts and the posterior cut, and you see that the balancing of the implant is correct in extension and in flexion. Once you do that, you know that this patient will do very well. Younger patients, my very long back operated patient of the initial version of the preservation uni in 2004, she had a wonderful result even at a long time. Octogenarians, where you don't want to have the long surgery and you don't want to have the extensive surgery, probably a unicondylar could be a good option. Stress views, confirm, and then plan the right procedure. You see the excellent function. When you see the long-term results of the unicondylar, that's our 15-year-old follow-up, another 15-year-old follow-up, 10-year follow-up, and this is a 20-year-old follow-up. So unicondylar surgery is definitely to stay, and a well-done surgery will last for the sufficient number of years. Which patient to avoid? We know that patients who have the extensive arthritis probably are not the right candidates. The difficult questions are, disease is one stage or it is a progressive arthritis. Impact of the implant design. And I think today it is clear that a fixed bearing versus mobile bearing, a well done fixed bearing will give as good a result as we have seen the long term results as a mobile bearing joint. And damage to the lateral patellofemoral joint probably is a very important thing to be seen. So my suggestions to our young colleagues in the audience: operate uni after having some experience with the total knee. Initial practice, use uni only for the absolute indications as the indications of described in 1989. Fixed bearing and Oxford mobile bearing uni are having the comparable results. These are the indications that we must take up to begin with. And then as the expertise goes on, then probably you can take up the more difficult challenges like the octogenarians or a more extended indication of the unicondylar arthroplasty. Thank you so much.
So we'll break for the lunch here. We want to finish it by 4:10. So I would like everyone to join back at 2:30 for the session. Thank you.
For the first talk after lunch, I would like to invite Dr. Hrishikesh Saraf sir on the podium to present his talk on navigating the robotic arthroplasty learning curve.
Hello. Yeah. Thank you, Shalby and team Ortho Trend for inviting me to this August conference. My topic is navigating robotic arthroplasty learning curve. Every one of us knows that this is the era of information and technology, and we are now in transition phase from this era to the era of artificial intelligence. I was early adopter of the technology, and I started robotic surgery in 2018 with Navio, and now using Cori since 2023. Though today I feel proud about it, it was a very difficult decision because when I started robotic surgery, that was the time when even stalwarts in orthoplasty used to criticize use of robotics. But believe in yourself and world will follow you. I did the same thing, and I started using Navio, a semi-automatic, semi-haptic, imageless system, handheld burr system with exposure control and speed control, autoclavable handpiece, reusable sensors and burr. We can use them for 5 to 7 cases. Limitation was cost of the machine and disposable, insurance companies not paying for robotic surgery, and explaining the advantages of robotic surgery to all the patients. Definitely there was a learning curve, and though I was practicing arthroplasty for more than 15 years, I visited centers in USA for robotic surgery and done cadaveric workshops abroad and in India. I studied the techniques and technology, and being an arthroscopic surgeon, it was very easy for me to look at the screen and operate on the knee. So when we started the robotic surgery, initially the steps of the surgery, they are different than the conventional surgery because you have to open the knee joint, then you have to calibrate the handpiece, you have to fix 2 pins, one on the femur and one on the tibia, those are your fixed points, and then you have to collect the points for the center of ankle, center of knee, and you have to circumflex the hip so that you will get the center of hip joint. Once that is done, then you have to paint the femoral condyle and paint the tibial condyle so that the robot will give you exact idea about size of the femur and size of the tibia. Then you can medialize, lateralize, superiorize, inferiorize, anteriorize, posteriorize the femoral component. Even you can change the varus and valgus of the femur and tibia so that you can balance the knee joint in extension as well as in flexion. And once you are happy with the position, then robotic handpiece comes in the play, and you have to move the robotic handpiece on the femoral surface and on the tibia surface, and that will prepare your femur as well as your tibia. So, setup wise also, it is different. You have to train your staff, you have to train your assistant, and as a surgeon also, you have to plan your surgery, you have to decide the workflow, you have to follow the same steps every time and repeat the same sequence so that your staff and assistant will not get confused, and at the same time, you have to start using robotic technology in each and every cases so that they will get trained immediately. Also, you have to teach your staff about the maintenance of the robotic equipment and position and maintenance of the sensor fixation. So by the time I was doing, say, initial 100 cases, I used my robotic system for each and every surgery, and that increases the ease of using the system, and automatically the staff got trained. It reduced the time of the required surgery. Initially, when I started, the time was around 80 to 90 minutes for the first 1 or 2 cases, and it reduces to 35 minutes by the end of 50 cases. Relearning of the TKR and UKR, actually you understand the new concept, you understand that the releases are not required. In the morning session, Dr. Rajgopal said that releases are the main thing which is required in arthroplasty or total knee replacement surgery. I agree with him partially because during conventional surgery, we used to release much more than what we release now in robotic surgery is much less, and that is the difference. So, importance of removing osteophyte, and once you remove all the osteophytes, most of the cases, your knee get balanced. Cautious use in osteoporotic patients and in rheumatoid arthritis patient, you may need to change your pin position from metaphyseal region to the diaphyseal region. So let's see few cases. These are the simple cases with mild varus deformity, a routine arthroplasty case. The robot will give you idea about exact size of the femoral component, size of the tibial component. You can change the position of the components so that your knee will balance on the lateral side. If there is tightness present on the medial side, you accept at this level. First remove all the osteophytes, and at the end of the stage you will see that your knee is completely balanced. This is the another case with severe varus deformity. There is 23 degree of the varus with subluxation of the tibia. Again, with a robotic system, you can balance it with 9 mm insert without doing any release, just removal of the osteophyte, and whatever defect was there, that was reconstructed with a screw and cement system. The cases with periarticular implants, the plates and screws 30 years back operated, in conventional way, you have to remove this implant first and you have to do a two-stage surgery. You may need to add a rod on the femoral and tibial side, but with robotic technology, it is just a routine case. It is a surface replacement. You have to prepare the surface. You have to correct the deformity. At the most, you may need to remove proximal most screw from the tibia and the lowermost screw from the femur, and you can come out. I have published this case in IJOS. Severe valgus deformity, many a times it is a nightmare for the orthoplasty surgeon. The contracted LCL, lax MCL, and defect on the tibial side. But with robotic technology, definitely it is a simple case. You may not need a lot of releases on the lateral side. Medial side, once you balance it, lateral side tightness, you have to remove all the osteophyte. You may need to sacrifice the posterior cruciate ligament, and the knee will get completely balanced. This is the pre-operative video of the patient, and this is the post-operative video of the patient. How they can walk and we can correct. Severe varus deformity with complete loss of the medial condyle. You can see that patient has severe bows on both the knees, and there is a lateral thrust. But with robotic technology, definitely it is easy to do all these cases. This is the post-operative X-ray. On the 15 days, patient is walking without any support, and at the end of 3 months. So definitely there is a learning curve when you start any new technology, but more number of cases you do, the time reduces. Day by day, when you go ahead, you start doing unicondylar knees with the robotic technology. You start doing total hip replacement with the technology, and different ideologies of an alignment technique also you can use with the robotic technology. Unicondylar knee, though conventionally we used to do the Oxford knees, but with fixed bearing uni knee, by using robotic technology, it is a simple surgery.
Sir, requesting you to please summarize.
16 minutes required, few slides, and I'll cover. Similarly, the total hip replacement, it gives idea about the inclination, anteversion, limb length, and cup size. That is more than enough. Even revision surgeries, we can cover conversion of the uni knee into the total knee replacement surgery is easy with robotic technology, and difficult cases like unstable knee also you can manage with the robotic technology. So in short, the robots, they give exact amount of the deformity, gives idea about bony cuts required beforehand. Cuts are always perpendicular to the mechanical axis if you go for the mechanical alignment, and if you want to go for kinematic alignment or functional alignment, definitely you can give the precise results. Soft tissue release is like pie crusting of the NCL, can be done in a controlled way, no disturbance to the femoral medullary cavity, that avoids the chances of embolism, avoids recutting required while correcting severe deformities, so saves time, and most of the cases can be managed with 9 mm insert, shows precision by taking minimal bony cuts, so it is a bone saving. Thank you.
Thank you, sir. Any question? Thank you so much. For the moving forward, for the next talk, I would like to invite Dr. Aditya Bothra, sir, to present his talk on robotics in valgus knee.
Thank you, Ortho Trends, for the invitation. So, robotics in valgus knee definitely has an application, and why we will consider it. Principle doesn't changes, but philosophy changes. Robotics is just a tool for quantification, but not for the experience. Why robotics have application here in valgus deformity? Correction of deformity is quantified, functional alignment can be followed, extra-articular deformity and rotational mismatch can be balanced. Now, from where the deformity is coming, that we need to define on the 51-inch radiograph, whether it is tibial or femoral. From the tibia, whether it is extrametaphyseal or it is concentric peripheral condylar defects. Similar in the femoral cases. So what are the challenges in the valgoid knee? It is hypoplastic or short lateral column, one-off of the posterior femoral condyle contracted lateral structures, extrametaphyseal deformities, medial laxities, and associated rotational deformities. So the Ranawat classification doesn't carry much importance for the surgical procedure. What is important to us is the SO classification, whether the deformity is correctable and whether the medial envelope is intact or not. That gives us the idea for the management. Now, what is the difference between the conventional and the robotic way? In the conventional way, we usually do the varus cut, which are inappropriate because of the bowing or metaphyseal remodeling, reduced distal cut. But in robotics, it is always perpendicular as per the functional alignment strategy or mechanical alignment, and usually neutral valgus to mechanical axis. Posterolateral condylar hypoplasias, external rotation of the femoral component needs to be done in the conventional way, misleading because of the anatomical variations, epiphyseal mismatches. But in robotics, it considers all axes, all together, real-time ligament balance. So the envelope is maintained, all bony cuts as per the gap balance, and matches with anatomical trochlear groove. Hypoplasia of the lateral femoral condyle is whatever has been taught to us conventionally actually doesn't exist. It is because of the differences in the cartilage wear, relative shortening of the lateral column, or relative posterior position of the lateral epicondyl. Now the extrametaphyseal defects, conventional, it needs expertise, could be 1 stage or 2 stage because we need to correct the deformity also, so corrective osteotomy might be added. But in the robotics, all manage in relation to the mechanical axis, especially in the tibia valga, MPTA is very important to us, and in the femoral valga, MLDFA. Usually, these are the deformities, could be medial side becomes reference to us, and defects are managed either with the grafts or the cements. Now, the robotic assisted total knee arthroplasty, these improves the outliers of rotational alignment, especially in the tibia. And this has been studied very nicely with the 3D CT measurements. So why robotics? Valgus cut angle, high inaccuracy, bowing, metaphyseal remodeling with the conventional techniques, posterior condylar cuts, high chances of inaccuracy, laxities cannot be quantified, and rotational deformities. So all to one answer is robotics. So what are the principles here in robotics for the valgus knee surgery? All deformities is tried to manage on bony cuts with balanced ligament, dynamicity of the tissue envelope is maintained, and deformity is corrected with the principles without much expertise. Functional alignment till 3-degree valgus is acceptable to me. Internal rotation is needed sometimes up to 2 to 3 degrees. Tibia valga, my reference is the MPTA, preoperative calculated, and femoral valga, MLDFA. So these are some cases. Now, 57-year-old female, rheumatoid arthritic patient, windswept deformity, valgus knee, lateral tibial defect, tibia valga, MCL is intact. Now this is the video. So this is almost a 16 to 15 degrees of the deformity, but it is correctable. But as soon as we are leaving, so it is again going back into the deformed position. So it means that the lateral structures are tight. We are taking the ligament graph and the stress graph. So this is the non-stress graph. Here we can see that there is tightness in the lateral structures on extension, but as soon as we take the stress graph, the laxity is maintained in extension along the lateral side only, but it is reduced. So we are planning with this. This is the Cori AI planning that has been done, but we are changing it. We have increased the size because that red sign was an indicator of the notching. We have distalized, we have posterized the femur. So we have managed the flexion gap. Still, there is laxity along the lateral side, so we'll increase the rotation of the femur. We are increasing up to the 4 degrees. Still, there is laxity along the medial side and lateral side. Okay, so we will proximalize the tibia. We can see it here that we are not notching. So see the cuts, 5.5 mm and 8 mm along the posterior condylar cuts. And the extension gap, we have managed it with 1 degree of valgus. Still we are lax on the lateral side, so we increase our size to the 4. So we are little tight on the medial side. But we could see that our posterior condylar offset on the medial side has been well managed. our highest tibial point, medial point is matching with our implant position. And posterior condylar offset along the medial side, we have restored. So this is the patellar tracking and stability post-operatively. Final graph. We have achieved a valgus of 1 degree in this case. And this is the ligament balance graph post-operatively. Hardly 1 mm laxity post-operatively. This is another case. This is the post-op 51-inch radiograph of that patient with 1 degree of valgus. Another case, non-correctable valgus, type 2, extrametaphyseal deformity. Here we can see that in extension, both medial and lateral structures are tight, but as soon as we take the stress graph, it is tight in extension only. So this was the AI robotics Cori planning that was giving valgus 2 degree to the femoral component and 1 degree to the tibial component. But it was lax in extension along the medial side. So what we did reverse of that. We did the 2 degrees valgus to the tibia. So we were able to manage it, and just with that, we did our cuts. This was the final graph. 3 degrees of valgus was acceptable to us. We achieved the range. We achieved the graph. This is the video of that patient post-operatively. Another case, third case, 70-year-old female, right knee, severe pain, valgoid, difficulty with ADL, grade 4 ONE, severe valgus, 3 non-correctable, no comorbidities. Unfortunately, we lost a 15-inch radiograph of this patient. This was the degree of the deformity, 25 degrees of the valgus and 14 degrees of the extension. This was the intraoperative deformity, lax medially. We could see the graph on the medial side. Yes, this is last case. So we managed this case with 1 degree of valgus to the femur, 0.5 degree to the tibia. We started, because it was tight from mid-flexion to terminal flexion, we first did the TFL pie crusting. After that also it was tight, so we just did the LCL pie crusting and we achieved the gap. So this was the intraoperative correction and this was the post-op correction. This was post-op X-ray, long leg X-ray. Thank you.
Thank you so much. For the next talk, I would like to invite Dr. Narendra Vaid sir for his talk on balancing soft tissues in arthroplasty, robotic versus manual.
Thank you. So soft tissue balancing is the most crucial part of any, what? क्या हो गया? So soft tissue balancing is the most crucial part of the knee surgery. And we have been taught by conventional methods to tackle a varus or valgus knee. If there is an imbalance in soft tissue balancing, there will be pain, stiffness, instability, and early failure. It is one of the leading causes of failure if there is soft tissue imbalance in the knee. So our aim in conventional surgery was to get an equal and stable flexion extension gap with a neutral limb alignment. That was our goal for a conventional knee replacement. We have to get the mechanical axis, we have to restore it, we have to have equal tensions on the medial lateral, collateral ligaments, achieve equal gaps and maintain stable knee throughout the range of movement and ensure the patellar tracking is perfect. It was basically a conventional surgery. It depended on the completely surgeon's judgment and experience. The bone cuts were made and then we had to adjust everything on the ligamentous side. There was no actually objective sort of solution to the releases. We used to tell our subordinates that you do an adequate release, do a judicious release, but there was no measurement to that. And that is what the robot gives. In the morning, Rajgopal sir said that you don't require, it's not like that. We require releases which can be very well monitored and calibrated with robotic technology. You cannot say that, there is no soft tissue release is required. So every step and every action we are doing, we can actually go back on the robot and measure it. And that's the advantage of robotic assisted ligamentous balancing. So we can have a mapping in imageless systems or a 3D CT scan on robots, and then ligament tension is assessed throughout the range of movement. That is another advantage which will tackle our mid-flexion instability and the problems while getting up from chair and going down the stairs also, and the knee feels absolutely stable. Another thing is that with more understanding of knee kinematics, we can keep the calibrated lateral ligament calibratedly, measured lax by 1 or 2 millimeters. That's an added advantage. And so every action is a measured action, and we can actually judge it on table before even, implanting the final implants. There is a enhanced reproducibility every time we do it, whether it is a uni or a total knee replacement, or sometimes a revision replacement also. We can have a reproducibility, and always the X-rays are consistently, perfectly, done. The importance is even more in when we are tackling slightly difficult deformities like extra-articular deformities. Like here, it looks very benign, but actually, if you see the combined varus, there is 23 degrees, and this can be very well corrected in intra-articularly, because the long axis is falling within the limits of collateral attachments. So here the deformities is three-dimensional. It's not only the coronal plane, but it is also a sagittal plane deformity, where you can see the slope actually, if compared to the distal fragment, has gone up to 19 degrees. If we were to do a conventional knee replacement, I think there would have been a massive release which would have been required. The poly sizes would have gone up, and again the accuracy would have been a question mark. So these were the graphs initially. Anything below the line, center line, is tightness. So medially, as expected, you can see that it was very tight, and laterally it was lax. And then after balancing, it has absolutely perfect neutral graph is seen, and the X-ray is absolutely perfect. So this was this is another case with tight varus. You can see that everything is below the line. The patient also had a fixed flexion deformity, because both the columns, the medial and lateral, are below the center line, and that means that the patient has some FFD also, and you can adjust the bony cuts in such a way that your ligament release remain very minimal. On the varus knee, I accept around 5 degrees of combined varus, and the valgus side, my tolerance is little less, and I go up to 3 degrees. My rotation of the femur can go sometimes up to 7 degrees or 8 degrees also. I have gone with fantastic patellar tracking. So after this, this was the first graph. You can see the orange one going down the center line, and this was after balancing with just tweaking around the position of the implant. We had to do very minimal release, and every release step, whatever we are doing, is being calibrated, and that's a great advantage. So this reproducibility, irrespective of surgeon's field, surgeon judgment, surgeon seniority, this is completely taken care of. So the results will be optimum in hands of an experienced surgeon as well as a newcomer, and that's the greatest advantage. Robots also have been a great tool for teaching also for our fellows and students, because whatever we are doing, the action is immediately, reflecting on the screen, and it is showing that, okay, I'm releasing now, say, deep MCL, then this is what is happening. Now superficial MCL or a posterior osteophyte I'm taking out, and what is happening. So this is even, robots are teaching us how to do our conventional surgery also in a better way. And this is how you get a perfectly fine X-ray. Sometimes, the opposite things, that contracted or a varus rigid, it may be simpler case, but case like this sometimes may be very tricky. This was an extremely lax knee with a recurvatum deformity, you can see here, and such cases are more difficult, and I think the robots helped us to a great extent in this. In routine scenario, we would have required constrained or semi-constrained liners also. You can see the knee is so lax that video is not playing anyway. You can see that it's a very lax knee, and here, even if you touch the ligament, it is going to be a disaster. In such situations, robots become very handy. So when we took a graph, it is in spite of being, this is a slightly fallacious or misleading slide, because routinely we say that anything below the line is tightness. But here, in spite of the knee being lax, you can see the columns going down, and that is because our sensors on the femur and tibia are coming closer. So even if they are in FFD, they come closer. Even in recurvatum also, they come closer. So robot will give this picture. That doesn't mean tightness. So here, they have gone below because they have come near in recurvatum. So here you don't do any releases and just take minimal bony cuts and get your bony alignment in a proper way. You can see that sometimes the pictures also on robot also can be misleading, and you have to keep your brains, active. The robot doesn't have a brain. You do have a brain, so always use it. So see the tibia picture here on the right hand side, upper picture. It looks like the keel is going to come out of this. So you have to neglect such pictures. In Cori robot, the faint yellow, a bright yellow is actually what you are mapping, and a faint yellow is what is projected by a robot. It is having some sort of intelligence, so it gives a projection. So it is not a real picture, and sometimes you may get worried looking at this picture, but don't worry that this is not going to happen actually in the case. So we could get an absolutely perfect graph, and with a routine poly, we could get a absolutely perfect alignment. So robots definitely score, I think, compared to conventional ligament release. Robots definitely have a great advantage. The releases are very calibrated, and they give now reports, early reports, 5-year studies are showing more satisfaction. Some prompts have been reported that it is giving better satisfaction. Another thing which I have noticed in my patients is that they have a better, because you don't fiddle with the soft tissues, they get a better proprioception, because the proprioceptive receptors, they are in the ligaments, not in the cartilage or in the bone. And so the patients are very confident when you do a robotic TKR or a UKR, and they have a very good position sense. Limitations, of course, we all know that there is a learning curve, the costs come in picture, and so you have to have some adequate volumes, or resort to go to some center which has volumes and use the technology if you want to use a robotic system. So to conclude, soft tissue balance is a key for knee replacement. It is a soft tissue surgery, but now with the advent of robots, it becomes a limited soft tissue surgery, and we understand the soft tissues in a better way. Releases are going to be required, but they are judicious releases, measured releases, and they are giving uniform results irrespective of surgeon's experience, or surgeon, whatever he says that I am doing it right, and we couldn't, say challenge our teachers. Otherwise, our dissertation wouldn't have been signed. But now that is seen on this thing, so it is actually real-time evidence-based sort of practice. Thank you very much.
Thank you, sir. Moving on, I would like to invite Dr. Jayesh Patil, sir, on the podium for his real-life surgery on robotics unicondylar knee replacement. I would like to invite our moderators for the session, Dr. Rishikesh Saraf, sir, and Dr. Adarsh Shanap Reddy.
Good evening, everyone. So I'm going to present a video of robotic tuxplasty. So yesterday we had a wonderful session on robotic tuxplasty. So we've already done a robotic sawbone demonstration. So I'm going to show you. It's not started. So this is the patient. She has a complete range of motion, and she's having pain on the medial aspect of the knee. She has no pain while climbing the stairs. You can see that there is a limping while walking, and she has a typical complaint of pain while walking. Rest of the time she's comfortable. So we have chosen this patient for tuxplasty. These are the X-rays. This is a varus and valgus view. You can see that there is a bone-on-bone osteoarthritis on the medial side, and which is correctable. In the lateral X-rays, you can see there is no posteromedial defect, and in the axial view, you can see that the facet is intact. So we go with the preoperative planning. In the planning, we load the CT scan into the software called as J-Planner. The J-Planner gives us an auto segmentation, And in this process, it separates the bone from the soft tissue. So it creates a 3D bone model which is accurate to the patient's femur. So there are a few steps to consider here. We mark all the centers and bony markings to get the femoral mechanical axis, the posterior condylar axis, and transepicondylar axis in all the 3 planes. Depending on these markings, the software automatically gives us the size of the implant, and we check in all the views whether the implant is fitting properly, whether it is covering or whether there is any overhang or the rotations are perfect. So once we are comfortable, we can again check on the 3D model whether we are okay and we can go ahead with the implantation. We can adjust varus, valgus, we can adjust rotations, we can adjust flexion extension at this stage.
Can I add a point here, please?
Yeah.
Yeah, this is one of the advantages of CT-based unis. You can plan your sizing and everything before the surgery even starts.
That's
so
correct.
Pre-planning.
So we finish with the femoral registration and we go to the tibial side. Similarly, on the tibia, we mark the tibial mechanical axis, and based on this, the software will give us the size and fit of the implant. We can check the rotations, posterior slope, varus valgus, and coverage of the implant, and we can choose the appropriate size and go ahead with the tibial registration process. Once this process completes, so the system will give you a complete summary of the planning, and in that summary you will get to know what are the sizes, what are the angles, what is the slope, what is the gaps that you are creating, and what is the final result that you are getting. So this is the summary. So in summary, you can see that here we have chosen size 4 of the femur. Then the distal cut would be around 3.9 mm. The posterior cut would be around 5.9 mm. The implant is in 2 degrees of flexion. There is no varus in the femoral component. And on the tibial side, it's cutting around 3.3 millimeters. The process is a complete sterile process. All the instruments are autoclaved. The robot is draped. This is a robot calibration process. Now this process ensures that all the markers and tools are functioning properly for a smooth conduction of the surgery. So once this process is completed, we can allow the robot to act and go ahead with the patient's preparation and planning. This is the most important step. If this gets stuck, then the surgery won't proceed.
Just a small point on classification of robots. So this is a fully automated robot which he has just shown the QVIS.
Yeah.
What Dr. Shishikesh is doing is a handheld robot, which is the Cori, and Vaidya sir also. And what we do Mako is a semi-automated. So this is the gamut of types of robots.
So we go ahead with the medial parapatellar approach. The incision is slightly medial. You open the arthrotomy, and I prefer to go a little bit of mid-vastus. While you open the arthrotomy, just be careful not to damage the intact cartilage on the femoral condyle, so that we can preserve by using an artery and then cutting it under vision. So this is very important. Then we
to use my knife inside out. Have
take
you ever tried
knife?
that? Yeah.
Nice. So that also is a good idea. Then we remove the medial meniscus from the coronary ligament. So that completes our exposure. Now the next thing is we just need to confirm whether the plan is okay. So the 3 criteria should be fulfilled. There is bone-on-bone medial arthritis, the ACL should be intact, and we should have a pristine lateral cartilage, and the patellofemoral joint should be up to grade 2, not more than that. So we take our tracker placement now, which comes 4 finger blade below the joint line, so that it doesn't come in the way of the robotic cutter. The 2 parallel pins are placed on the tibial shin. The unicortical pin just touching the opposite cortex but not penetrating the opposite cortex. So do you have a similar, do you put unicortical or bicortical?
Oh, unicortical. Yeah. So we just graze the distal cortex.
That's correct.
Yeah.
Similarly, 2 pins would be placed on the femur anteromedially. So both the pin placements are extra incisional. We check over the range of motion whether the sensors are visible, the trackers are visible to the sensor, so that there is no obliteration.
There is a small difference. I put my femoral pin inside the incision. So they act as a retractor also. So they act as a medial retractor.
That may be difficult in unis, I think.
Definitely.
In
In uni
also?
In uni also.
Right.
Because you have small incision.
So we might have to increase the incision in that case probably, but it's a good idea. So we start with the femoral registration process. So this is a very simple process. The computer gives you the zones where you have to mark. Around 40 points you need to mark. So 9 points on the distal condyle. These points should be on, you should not penetrate the bone too much. It should be very superficial and it should just penetrate the cartilage if at all it is there. Then you mark the sulcus on the lateral side. Then you mark 9 points on the medial femoral condyle, and there will be around 6 points on the anterior cortex. Once this mapping is done, so the 3D bone model which you have chosen in the software and where you have planned will approximately match with the patient's bone model, and it will give you a RMSE, which is the error that you have achieved. So that margin of error is less than 1 in this case. So a final RMSE is 0.48, which is acceptable RMSE. So you can go ahead and do the verification step and go to TBL registration. So that is for, it's a safety feature and also accuracy feature. On the TBL side, you mark 8 points on the anteromedial cortex, which is the affected part. The 3 points on the lateral side. 4 points on the anteromedial cortex. And 6 points on the just medial to the tuberosity, and there will be 6 points on the anterior cortex, and 3 points on the tubercle. So the importance of marking these points accurately is to get the perfect RMSE. If the RMSE changes, you might have to re-register the process, because then the bone model will not match and the cuts might vary. So here the final RMSE is 0.33, which suggests that the points have been accurately marked, and we can go ahead with the verification process and allow the robot to attach.
Especially being a fully automated, you have to be very accurate, otherwise
that's correct.
So that's a safety mechanism, as you mentioned.
So next is an interesting step, which is the gap check. Now here we run the knee through complete range of motion and see if the gap that we have created with the implant position is adequate or not. So in case the gaps are not equal, this is the stage where you equalize the gaps. So you can change the anteriorize or posteriorize the femur here. You can get distalize or proximalize the femur. You can change varus valgus of tibia, or you can change the slope of tibia at this stage. And once you, in case both the gaps are tight, you can get the tibia 1 or 2 millimeter down. So once you equalize both the gaps, then you can go ahead with the cutting process. So in this case, the medial gap over the range of motion is around 9 millimeters plus minus 1. So we have accepted this after the adjustment, and then we give the command to the command to the software to go ahead with the cutting. So this is a C-clamp which is used to stabilize the bone, because the system is very sensitive. So even a small bone movement will not allow the cuts to go ahead. So once the C-clamp is attached, the cutting process starts.
Then
so
you have a cup of coffee here?
Yeah, no, not actually. You need to supervise this, because sometimes the bone is quite hard and then the burrs get stuck, and you need to stabilize the bone and maybe repeat the process of cutting. So there are 3 basic cuts. One is a distal cut. So it's going to remove 3.9 millimeters of bone distally, which we have planned. Then there is a posterior cut which is happening, and it is going to cut the same amount of bone that we had planned. The safety feature is that the burr doesn't go out, it leaves 1 millimeter to 2 millimeter of bone on at the periphery. So even if you don't retract, or even if you don't put anything for your soft tissues, the soft tissues are going to be preserved. Once you remove this bone, you can remove the other remaining part of the bone later on. So it gives you the accurate distal cut and the accurate posterior cut for the implant to fit. It also makes the 2 lug holes which are there. One is a 6.3 millimeter lug hole and 3.2 millimeter lug hole. That completes the femoral preparation by the robot. Now we go to the tibia. In manual TKR, normally we face this common problem that we don't have a control over varus valgus or the slope, which changes sometimes with a little bit of deflection of the saw blade. So here, this is the main benefit. I personally believe that if at all you want to take a partial tibial cut, any robot maybe is the best tool that you can use.
I think more than the varus valgus, that vertical cut is where the stress comes and causes fractures, and you'll never have it with this.
That's correct. So this will also do the vertical cut for you, and you don't penetrate the cortex, the posterior cortex, so that saves your bone there. You need to be patient while this cuts, because sometimes the bone is sclerotic and the robot might repeat the steps. You keep irrigating the field because there is a lot of bone dust that is there, so you don't want that to get stuck again. So this robot has come back and it's going again and it's cutting again. Just have to be patient. But the cut that you get is a very flat cut, and the implant sits perfectly on that cut. So which is the main benefit of this.
Is it an auto irrigating system, or you're giving it from outside?
Sorry?
Irrigation, is it connected to the burr?
There is a irrigation, but I think it got blocked, so I started giving it with the syringe from outside.
Because I see the pipe there.
Yes,
so
there is. Sometimes you need to help the technology.
One doubt was there, when it is doing tibia, does the robot visualize the femur also? Because that is one drawback in case of Cori or something like that. If you are doing a burring on tibial side, then that doesn't visualize the femur, and inadvertently you can, you know, burr some of the femur also. So here, how does this robot work?
So here I think we have done femur first, and we have removed the posterior condyle already.
When we are going
so you ask the assistant
it becomes slightly tight because already you have taken the posterior
correct,
cut,
correct,
and
correct.
leg tends to go slightly in internal rotation because there is a gap there. And when you go posteriorly on the tibia, the posterior femoral condyle can sometimes get damaged with the burr. That is my observation for Cori. I think
that's a good point.
You have to be careful for that.
Careful. I think we are doing it in a complete flexion. Yeah. Tunnel, yeah.
Tunneling, yeah.
We do the final preparation on the femur and the tibia. We need to do the final milling process, which is not there in the robotic burr. And after that, you do the trial.
The distal mill, you mean?
Yeah,
right?
distal mill of the particular size 5. Then you ask the assistant to remove the retractor as you put the insert and see for the balance. So this is the trial check. And you had balance for around 8 millimeters or 9 millimeters of poly, and it seems to be well balanced in complete range of motion. So this is what we go ahead. So I tend to keep 1 or 2 millimeter laxity in both flexion and extension. And patients really have a very good feel of this after you close the arthrotomy. This is the final step of preparation for the vertical fin. It's additional a fin for better cement fixation. We put multiple drill holes all across because the surface is less. We want the cement to integrate and penetrate. So this is what we do, multiple drill holes, very important. And this is the implant. This is a tau unicondylar knee system implant with vitamin E poly. So in the cementing process, just put cement on the implant and press it from posterior to anterior, so that avoids cement going posteriorly, and you trouble less removing that cement. So you can see that when you punch it, all the cement comes anteriorly. You can I prefer to use a cautery, bend cautery going behind, and just try to remove if there in doubtful cement remaining there. On the femoral side, put cement on the lug holes and then do the final cementing. We need to be careful not to leave any residual cement particles inside. So ensure that all the cement is out. Just irrigate and then prepare for putting the final poly. Poly you just need to slide and it is going to lock. Very simple locking mechanism, and this is your final after cementing gap check, and you have got a good correction of deformity as well as there is good balance over the range of motion. Hopefully this patient will do good. So I think
this patient will definitely be good.
This is the amount of control that you have, which in manual sometimes you lack. So those are the small skin incisions that you commit to the patient all the time. This is the post-operative X-ray. The implants look well fitted, well set, well cemented, and this is day 1 of the patient's range of motion. So because you're not cutting the quadriceps too much, I think they get a comfortable range of motion, and the benefit of MIS is not because of the small incision, but not cutting the quadriceps probably. They get good SLR, and she can walk the next day itself without any support. So it's very encouraging, and we should be offering this to more and more patients. Thank you.
Any questions?
There is
Please.
one additional point that nowadays the Journey 2 implant is available. So the advantage of Journey 2 is the femoral lug heals, you do not have to prepare it with the burr system, and you can put it you can medialize or lateralize the femoral component at the final stage also.
Intraoperative.
And then through that trial implant, you can take the lug holes. So that is one advantage there with it. And second one is to fix the insert. Here we have to push the insert by hand, but now they have an instrument, so you can just push it with the instrument like the older one with NextGen that was available. So that is 2 steps. They are really simple with that now.
Nice, nice. I'm sure innovations, micro innovations keep happening, and we are open to it. Any questions?
I have a question.
Yeah.
So this is a fixed bearing implant. So how strict are you about the ACL being present or not present?
So if you ask me frankly, at our institute, we don't tolerate ACL deficiencies. So we are not taking knees with ACL deficiencies. But theoretically, of course, you know that if there is ACL deficient knee, which is well compensated, we can still offer a uni. But only difference is that the tibial slope has to be less when you prepare. So tibial slope in a normal uni, we keep around 7. There you need to keep it around maybe 2 or 3 to avoid posterior-medial overload. So that is the only difference, but I personally don't do.
No, I totally agree with you. In this way, we can extend the reasons to do uni, but actually, what I feel that we should stick to the criteria and indications, and if there is a ACL intact and it's functional, then only one should go for the uni knee.
I also agree, but it's a hypothetical situation. A 75-year-old, proper AMI picture, but no ACL. Would you still hold off the uni?
That's what I said. Okay, it's a well compensated, balanced knee. We can still do it, but we have not been.
But you would not be. I don't think so. The question is, if you have a mucoid ACL, would you change your?
So I think 3
criteria?
things: inflammation, infection, instability.
Yeah.
So all these 3 cases absolutely contraindicated.
So if your ACL is hanging on functionally, it's okay. You can still go ahead. You can check with your ACL hook if you want, and do an anterior draws. The reason, just for the uninitiated, why the ACL is so important for unis is once it goes, the arthritis starts to spread posteriorly and sometimes to the lateral compartment. So it will not be restricted only to the anteromedial compartment. So that's the reason for that.
Simple way is to put a hook retractor, what we use during the arthroscopy, around the ACL and try and pull it. And if it is good, then you can go ahead with that.
One important benefit I forgot to mention is, while doing a manual UKR, many a times the blade slides and there is an undercut below the tibial eminence. So that is absolutely avoided because of the vertical cut, which is the burr, which has a control over the vertical cut and the horizontal cut. So that one benefit is there. In manual, yeah. So once you start doing manual, you start getting all those doubts, and then when you start doing this, all your problems suddenly are, disappearing. Thank you so much.
Thank you so much. Moving forward, we have symposium. How do I use my robot, QVIS, Mako, or Rosa? I would like to invite Dr. Narendra Vaidya sir on the podium. And for this session, I would like to invite our panelists, Dr. Vivek Mahajan sir for Rosa, Kori Dr. Aditya Bothra sir, Miso Dr. Shekhar Srivastav sir, QVIS Dr. Karthik Selvaraj, and Mako Dr. Adarsh Anaprekar.
I think Dr. Shekhar Srivastav is not there. So, Dr. Shekhar Srivastav is not there. He is a meso surgeon. I think Dr. Karthik can take care of meso along with QVIS.
So the way we have planned this session is that I'm going to ask the panelists various questions about robots. Instead of having unorganized sort of arguments, let's go as per the logical sort of discussion. It's a sort of new this thing. So I'll request everybody to comment on that, and I have tried to pull out some literature also around this. So just to ask everybody, how much was, now they are all using various robotic systems. So what was your learning curve, and how steep was the learning curve whether your staff of OR, when you started doing robotic surgery, started disliking you because of the preparation time, and they used to hate you that, oh, sir used to come and do the TCAR in 20 minutes and now it's 1 hour they are just setting up machines. So what was your experience about these factors?
So actually the OR team actually learned faster than us. The company people could train them very quickly. They were actually quite ready with the first or the second case. We took more time, and we have a very young team and they loved the tech actually. So
yeah, I think the younger the surgeon, the
Yeah.
adaptability is quicker and better. They are very proficient with their handling of computer and the machines. Others, about Meko, how much was the...
The first robo we got, the learning curve was definitely steep, around 50 cases to get time neutral. But then the second robo, like even though we went for different company like a Velis and then a Cubis, the learning curve was much less because we have some idea that robotics is a bit different. We got a bit of a hang of it.
Right.
So first one, 50 cases maybe.
Which one you are using?
Vivek Mahajan.
No, Rosa.
I'm using Rosa.
Yeah.
Well, I was using computer navigation since almost 10 years before I switched to robotic. I was using Ortho Pilot, which is also a gap balancing based machine. And Rosa just got into my OT. It was very easy for me to switch from computer navigations. I feel that it makes a lot of difference that if you're already using the technology, then using the robotic is just like upgrading yourself.
Right.
So for me, it was less than 10 cases before I got used to it.
Yeah.
Same to me, sir. I shifted from Kick 3 to Kori.
Right.
So my learning curve was little less.
Yeah, so people like even including me, I used to use Striker and Ortho Pilot for my cases, and the transition was quicker, but still tried to find out in literature. This is what has been mentioned in various papers, that Meko has got around 15 cases of learning curve, Rosa has got 20 odd cases, but it is not a very precise data. This is a judgment, and it's not a, you cannot quote it as a scientific data as such. Still, I think even if you are shifting from one system to another, again to understand that system also is a bit of initial 5-6 cases. It may be slightly different. Secondly, every system gives a different type of screen in front of you. The screens are not identical. Some people will give a vertical graph, some horizontal. So there may be some adaptability. Most importantly, I think what was important was to understand those numbers which the computer is throwing at you, and how much relevance and importance you should give to that number is also important, because now it is going to show you 0.5 millimeters or 0.5 degrees. So these are the things where you have to get adapted to it, and you have to set your limits ultimately to get adjusted. This graph is about my cases. I started initially, when it used to take around 1 hour, and you see the last, this is first 100 odd cases, and then this was data of UK. 17 odd minutes was my latest case, and this is also similar graph. Now we move to the next point. How do you think, all of you, that your robot is the most accurate?
If I can start. Yeah, so it has a beautiful locking in mechanism. You just lock into the plane. And then you also have a haptic boundary for the Meko, so you're very safe. You don't cut the good bone. You don't cut the soft tissues. So I think it's very accurate, and CT based trumps non-CT based as per literature.
Right. Anything
So
else?
I can't comment on other robots because I've just used Cubis, and for me it's definitely accurate than me. I can say that because once I've started, I was so skeptical to get a robot, especially because the time involved, because we had time constraints. We wanted, as you say, we wanted to finish surgeries. But after using the robot, we found that we can be so accurate, and the implant can be precisely put. Earlier, we've accepted so much as quite normal. I was wanting to ask you that, because when you, in the previous talk, you said that now we can balance the soft tissue release perfectly because we get a visual feedback. Now all those patients whom we've done historically, where we accepted a little bit here and there, they seem to have
we don't know exactly. Means we always think that we have done a good job, and Yesterday, I was talking to Pachore sir yesterday, and he was mentioning about one meeting where he saw the TBI put in 9 degrees of so-called functional alignment and everything, and those people also carry on. So
That's what I'm
I
saying.
think we have to set up our boundaries, and we used to do all mechanical alignment that time, and then overall, if you see the literature, then the outliers in the conventional surgery were around 27 to 28%, whereas in robotics it is less than 1%. So whatever we are planning, we are absolutely able to implement it.
Yeah.
That's a great advantage.
But all these outliers, not that everyone has come with aseptic loosen
No,
in 5 years. So they have all done well.
So we don't know about whether it is making an impact on survivorship of the implant or the proms also. So we have to actually study it. But if now when we talk of proms, there is one bias also. I think if a person is told that we have done it robotically, they feel nice. That is also fun factor which is not mentioned. I don't know, but patient psychology also is there.
They call it the halo effect.
Yeah. So some people they are like that. Now, any difference? Others you have used burr based as well as saw based, I think, and
I have used Cori. In fact, I used it when it was blue belt.
Yeah. Navio.
It was blue belt. We did a study with Fred Picard validating Cori with Zook.
Okay. Zook, yeah. Uni used to
it
have.
went full circle. Then finally everything came to Smith and Nephew.
So overall, if you see the precision industry, forget orthopedics for a time being, and if you see the precision surgery, most of the precision surgery is done with burrs, not with saws. So that was a theoretical point which I had a debate in last IA also, where I was to talk on burr based, and that was a thing that I said that, okay, this is a burr based, and burr based, you have a watch industry or you have any precision industry, burrs are the ones. But regarding burr, I would like to share one of my experience that you have to be careful when you are doing on an osteoporotic patient. I had a couple of patients, rheumatoid arthritis, patients who were on steroids, where soft bone was there. These burrs, they tend to pull out a lot of bony chunk, when you are not planning it, and you will be left with some of the big bony defects. So be careful when you are using a burr based. Whereas the saw based, I think we are all acquainted with that, and it gives this thing. Another thing, you will have to always know exactly the saw which you are using, because if you are using a Wellis robot, then the saw blade is thick to avoid the skiving of the saw. And so if you are going to measure the cuts, if you have planned a 9 mm cut, then your actual cut will be 7 mm because your saw is 2 mm. So you shouldn't go and redo your cut, because ultimately you will go and do more bone removal. Any additional point from yours?
Other thing, I feel that comparing one robo to other is like comparing iPhone
Apples, yeah.
to Android.
Yeah.
So if you are comfortable with Android, you will vouch for it. If you are comfortable with iPhone, you will continue using it.
You have to get used to it. Yes, you are right.
BMW and Benz.
So it's like more about like how quickly, I feel whenever you are doing a robo, first you need to have trust in that implant. Second, how quickly you can switch from robo to manual, because there will be instances
That is one more
the
point which
machine
will be
might
covered
ditch
in
you.
that. I have that slide here. So in literature, if you see, they have been very less papers comparing accuracy of various robots, and these are some of the papers where they have seen that they are all more or less comparable, no significant difference, especially in outcomes, and in outliers there was no difference. But there is one paper which I am presenting, showing here, is that Navio group and Rosa, they had compared, where they had a less sagittal cutting errors in Navio as compared to Rosa. So that was one paper. Mako and Rosa, this paper is there which is showing similar precision, accuracy, and clinical outcomes also same. So there no significant difference in that my robot is better than yours. It's nothing like that. You are ultimately resorting to some technology which will help us in, mainly in my opinion, adjusting your bony cuts, getting your alignment philosophy right, and having your soft tissue perfectly balanced throughout the range of movement. These are the main advantages. Wellis, there is no comparative study, but they have said that the cuts are absolutely accurate. This is another graph which I could pull out from literature, which is again showing comparative accuracy, where they have shown the errors. This is median error, mean error, and according to this, the Mako is having the least error, but the difference is not statistically significant. And this is a graph which is showing various errors. Now, They have not, none of them have actually published about the soft tissue injuries as far as the accurate, and I think that is the point where the haptic robots score more than the non-haptic robots. Things like, Cori or Navio, which are semi-haptic, that will remove the bone which you have mapped. They are second number, and some third last number will be robots which have no haptic control. Welly's robot people, they tell that this is a linear haptic or a planar haptic, and that doesn't leave your pain, but endpoint of the saw, you will have to judge yourself with the experience of handling saw. So that giveaway which you get is entirely your judgment, and that is where you have to stop. Now coming to another point, which is extension of the first point, how much is your footprint in the OT? Whether that robot is displacing you as a surgeon and taking you out of this thing, how much adjustments you had to do with your operating assistants and everything, because all the robots I am doing, my assistants are at different places. So what was your experience in QVIS?
Well,
QS more or less has replaced, as he was saying,
absolutely.
You go for coffee.
So what has happened in the OR now is the techs, they set up the system before the patient is anesthetized.
Right.
So it takes about 20 minutes, and the patient gets a spinal, and the exposure takes about 5-6 minutes, and then the pin placement another 5-10 minutes, and then the registration about say another 10 minutes, and then the mapping and everything, and then I come in for the gap check. So once the gap check is done, and once we are comfortable with gap check, then the burring
So
is
what
done.
is the stage, especially in a completely automated robot?
Yes.
Now other robot, they are sort of, in my opinion, interactive, means we are doing something, and whereas QS is a fully automated.
Yes.
So where do you chip in for your soft tissue management? Because you will have to do some soft tissue management.
Yes. So in
which
the
step you come in?
In the gap check, normally say in a straightforward varus knee,
it's a rigid varus with say 15 degrees of FFD or 20 degrees FFD with non-correctable varus of say.
So normally at the gap check time, at the time of the gap check, we will know how much is the, so we are expecting a 10 mm gap on both medial and the lateral side. So say suppose the gap is 5 medially and 13 or 14 laterally. That's the common situation we get. So at that time we can play around. Now we give the valgus and varus stress and see what is the maximum stress you get, and it shows on the screen. So if the maximum is about 13 or 14 on the lateral side.
But you will proceed with your bone cuts first?
No. So at that time we can do the adjustments. So we give a little bit of varus on the tibia.
Exactly.
It will give a little bit on the femur, and we come to say, so there is a limit. So we reach that limit. Once we say we've given 3-degree varus on the tibia, and maybe a couple of degrees varus on the femur, we flex it a little bit, we externally rotate a little bit. So at that point it is 9 and 12. That's when I accept it, I go in, and then I go, that 1 mm we can actually need not bother. Say it is 7 and 12, then I had to do a little bit of release. But that's what I'm saying, I'm so surprised that I have to do very little release after doing all these adjustments.
So do you think that we are overdoing the
Yes,
releases?
absolutely.
Yeah. Others, your experience?
Yeah, so we're talking about the OT
your
footprint.
protocol of soft tissue handling?
Yes, sir. So first about the footprint, the Mako is a big one. It forces you to lose weight, so you can accommodate. The second thing about the workflow, pretty similar. I like to go for the full balance first. We call it as a pre-balance. You put in the varus and up to the boundaries, and then take a full cuts, and whatever is remaining, do a bit of soft tissue, which is usually negated after you put in functional alignment.
So with the Cori, there is no change in the footprint because it's a real-time intelligence and it goes hand in hand, whatever you are planning. So there is no change in the footprint.
That's very convenient because you have a tab there sitting on the table, and so it doesn't displace you. You don't have to change any arrangement of your assistants or staff in the OR. So that is there. About Rosa?
Well, Rosa, we were always having one navigation unit. So now we have a robotic unit on the other side. In bilateral, you don't have to change the Rosa. You can just park the machine and do bilateral without moving your robo. And I can't afford to have a coffee. You are fully involved till the end. It is like still Rosa. I am using Rosa because I still enjoy doing the surgery. I'm fully involved in the surgery, and we are doing gap balancing, functional alignment.
Right.
And only thing which I have seen with the robotic is, like ours is a teaching institute. I used to teach 2 students before using robo. Now I feel it's getting bit cluttered. Now it's only one on the other side.
Right. So
But you can, I'm sorry
the
if I can
protocol which, sorry, yeah,
can I
go
add?
ahead.
You can probably have less people scrubbed in, but you can teach more people from the screen. So both work.
Actually, the way, like Rishikesh was mentioning in earlier talk, the way you put your trackers also, they can be your self-retaining retractor-like things. And so in Velis especially, I'm putting it the oblique direction in metaphysis in the incision itself. In UK, you have to put one pin out and one, inside, something like that. So my protocol for soft tissue balance is that initially I will take the stress views and see how much it is getting corrected with a Z retractor and with a physiological pressure, and then I will tweak around the position of implants. But I have set my limits that varus not more than combined varus of 5 degrees, rotation 7 degrees, and valgus side 1 or 2. Beyond that, then every step I am doing, I will do a graph and check that I am getting balanced. So it is a stepwise sort of a release. As far as the OT footprint is there, this is the actual literature, how much space every system is taking. About ROSA, one thing is that ROSA actually doesn't come in between because all the other systems are at a perpendicular to the table, whereas this comes at a 45 degrees. And so it is not in your field, so you don't have to really do a lot of adjustments to this thing. Regarding QVIS, I had my maximum adaptability problem because one, I was getting displaced and that machine was doing everything. So to accept that was a problem. Anyway, so you see the footprints are maximum for Mako. It's 1.7 meter square is what they have documented. ROSA, they have not calibrated the footprint, but as I told, it is not exactly in your operating field or operating area. It is slightly away. It comes from the anesthetist side, and so they are the ones who probably sometimes get irritated. But
they are happy to leave the OT.
Sorry?
They are happy to leave the OT.
Yes. So these are again the similar.
Thing I wanted to add is, like all my knees, I am doing subvastus.
Right.
So putting the pin in through the incision really helps me using it as a tracker.
Right. So footprints, Mako has the largest one. Regarding Velis, it comes and beside you have to keep one fist distance between the knee and your cutting your robotic console, or not console, the handpiece or arm you can say. And that sometimes can be a tricky thing for your assistant. He has to go from above to take the patellar tendon out of equation. Otherwise, you have to be careful because it is not haptic and it can sometimes injure your patellar tendon or something. So you have to be very careful.
If I can add a point here, sir. So with the Mako, though it's a bigger footprint, because you have a haptic boundary, you can actually not have the assistant there. You can use the foot holder and put the antlers. You can do it even without a single assistant. Right. But in the Velis, because there's no haptic, you need somebody to put.
You need, yes, absolutely, you need it. So what I do for MCL is that I put a small radius ulna type of Homans retractor behind the MCL. So it protects and there is no need of somebody coming from in front, because if that person comes, then your camera is blocked. So you can put that small Homans there. Yes, now coming to the imaging and non-imaging, it's a perpetual sort of a debate. So the imaging guys, how do you, two of you are imaging, two of you are imageless. So in ROSA, are you taking X-rays and sending it to Canada, or you are doing mapping? Because that is one thing which I did not like, that you have to send it to some Toronto or somewhere and then you have to get the images and planning from them, and it used to take one day.
But that's optional.
So now we use real-time mapping.
You can do it even without the X-ray.
No, right? Without X-ray. I am also doing without X-ray.
There is an option of going image with image in
with
ROSA.
Image, it is there.
I am not doing it. There are surgeons who are doing it.
I also never did it with ROSA. You have to put those bands with calipers or some calibrations there and send it to their center, software center, and then they will give you a planning next day. So that doesn't work in our country somehow.
So the one thing I found about CTs is the patient never hesitates to get a CT. What I always was afraid that when you say you have to get a CT scan, patient is very happy. When we say you're going to do robotic and get a CT and come, they are more than happy to get. And the next thing is many times it picks up cysts in the tibia or in the femur, which the X-ray doesn't show. So we can be prepared with maybe if you want stems and other things. And sometimes osteopenia also is reported. So that all that is helpful.
Yeah, again, so CT based, definitely the disadvantage, as all the non-CT based guys will say, is the radiation. I think that's a small trade-off because we're getting more accuracy. I mean, again, that's debatable. But the point is, I can plan beforehand. As Sir said, you can plan where the cysts are. You know what the posterior corner offset is beforehand. And I think there is a lot of value in that. And even the registration part, you're just taking points. You don't have to paint the whole bone and go till the posterior. Because if you don't do your registration well in the non-CT based, then as everyone says, garbage in, garbage out. But here, unless you match your CT,
sizing can be an issue sometimes if you are unable to go in a tight knee on the posterior side. So that is there. Yeah. About Corey?
Sir, but Corey, there are no literature differences on the image placement, implant placement and the accuracy, first thing. Second thing, in the Corey, we are getting the CT simulation views. So that way also, we are getting the views and we are not exposing patient to the radiation, unnecessary exposure. I think so.
So when I saw the literature about the radiation exposure, now the average person, gets around 3 MSV sort of radiation in due to cosmic rays and everything, whereas MECO or the preoperative CT, they use around 3 to 8 MSV. So that's quite a bit as far as this is concerned. And if you compare it with X-ray chest, then standard X-ray chest is 0.1. And it is around, if one limb is getting a CT scan done, it is up to 80 chest X-rays can be the exposure. And if you are doing bilateral, it can go up to 160 sort of radiation. So that's one thing which we have to keep in mind. Of course, CT has advantages because it gives you haptic boundaries. I think that is that completes the robot. That's why. But using Corey with semi-haptic, this thing, I had no problem at all, and it was very convenient and never had any soft tissue issues or problems. Intraoperative flexibility and your balancing, how convenient was it? Because in CT based, you have to keep the osteophytes also intact in the beginning, whereas non-imaged, you take it out and then you get an idea of balancing. So how do you, manage this aspect, because your osteophytes are going to be there, and now you are going to, do it later on. So does it modify your cuts? Because we discussed that you may have your 5 degrees or 3 degrees adjustments, and that is a stage you will do before taking out osteophytes. So whether it will go for a toss when you do it later on, remove the osteophytes.
I think it's a minor adjustment to our surgical steps. Normally, we're taught in conventional open and take out your osteophytes first. You just have to refrain from doing that until your registration is done. Only the registration part, because the CT scan is taken with the osteophytes. But as soon as that's done, we take them out and the balancing is done without the osteophytes. So it doesn't really make much of a difference.
So there are 2 ways to do that. One is to, as Adarsh says, you can remove the osteophyte and then proceed with the gap check. Or you can do the gap check and adjust all your implants, and then once you know that there is about 3 mm or 2 mm or 3 mm tightness, then you know that when you remove the osteophyte, it's going to be okay.
So you're saying balance it intentionally tight on that side. Yeah, that's one way to do it.
Others, you are using Velis also.
Yes, sir.
So tell me, does your planning change when you are doing a CT based and this thing? Because in a CT based, what you are getting is a bony image, and cartilage is not seen in that.
Correct.
Whereas in Velis or in Corey or in Rosa also, we are mapping the cartilage.
Yeah.
So how do you manage your cuts in that, and is there any difference in the approach?
I think the approach is only different part. So in the Velis, we take out the osteophytes first and then paint it. Because the software, it takes into consideration the fact that you're taking it on the cartilage. So we don't have to use extra brain there. And the MECO, it's taken into consideration that it's the bone.
The 2 mm
so we don't have to do the extra thinking. It does it for us. Velis, it's with cartilage. MECO is without the cartilage.
So does the thickness of your cuts, they change accordingly, or you take
it's built into the software.
Okay. Now, apart from theoretical this thing, I'll just show you one case, and I would like to tell how your robot is going to plan this case. So this was a extra-articular deformity case with a malunited femur fracture with varus and in slight recurvatum position. Patient had a range of movement which was restricted. It was hardly 60 degrees flexion and had a FFD also. So which robot will be the best to tackle this? Or conventional?
Human.
Human.
Yes. So I'll just give my two cents. It's just when we feed in something like this, then the robot basically just lifts up its hand and says that the virus is too much. So it just says that it cannot be corrected only with robotic.
I'll show you that image when it lifts its one
Yeah.
hand. I have that.
So it's just a reinforcement that obviously we'll have to do something more than just the cuts in this case. So robo is actually trying to balance the knee with only bone cuts, and this case obviously needs much more than that.
First
So
is that whether you will do it intra-articular correction. I
Yes.
think all of us will agree on that.
Yes, because it's
so
close to
no
the
need
joint.
of two surgeries. That is definitely there. Now in this case, probably putting in conventional rod for femur also would have been slightly difficult, sclerotic bone, and that would have probably given some injury to bone, fractures sometimes, so a robot is definitely the way to go.
If I can add, so because of the extra-articular deformity.
Any additional points from, yeah.
Yeah, because of the extra-articular deformity, I think the robot has a lot of value here.
Absolutely.
Because you don't have to put in your intermediate rod, you know where your center of hip is, you know where the center of the knee and ankle is. It helps you with the axis without that struggle.
Right.
Sir, for me, principles of conventional technique apply here with the graded robotic application. So that is the best thing here, because I could judge what I am doing, because there are so many posterior osteophytes. So on the very first note, I will not release 9 mm of tibia, I will not cut that. We'll go the conventional way, remove 7 mm of tibia, let's check, then check again, remove the posterior osteophyte, check it again. Femoral implant placement here.
Yeah, and it's
It
not
is
only
completely-
osteophyte, it's
Yes.
a callus actually there. That was a malunited fracture. You can see the ectopic, huge amount of bone on the posterior side.
But they are tenting on the.
Yeah, absolutely.
yes,
They are
yes,
stretching
yes,
the posterior
yes,
structures,
yes, yes.
definitely. So, sometimes cases which look very difficult to manage, become very easy
Becomes
when
very
you are
easy.
doing robotic surgery. So here we did just routine things, and not much release is also required. Otherwise, massive releases in conventional, which are going to keep your knee lax, the center, and then this was the final graph. And this was the position which robot gives. See where the robot is showing the femur, because it projected the femur trajectory somewhere else, and the implant is showing somewhere. Again, don't get confused with this kind of picture. Just proceed with you. This was done with I think Navio that time. So we could imagine and just burr out the femur. So entire burring was done, and this was the final picture, and this was the final X-ray. So absolutely perfectly you can get, and all the deformities are completely corrected. Coming to bone preservation and soft tissue, so any measurable difference in various techniques, burr, saw, or something like that, or?
Sir, when I moved from navigation to the
Sure.
Cori robotics, when I moved from navigation to Cori robotics, now I am able to see that I am conserving at least 1 mm, 2 mm of bone
Yes.
on the tibial side, at least. So that is one point. Definitely less releases, so ligament tensions and ligament releases are reduced, so pain is reduced post-operatively. Long term, I don't think there are many differences, only short-term differences for early recovery and better balance.
I don't know if there's much difference between robots, but as Dr. Karthik mentioned earlier, between conventional and robotic, we're definitely conserving bone here. We've actually published in HIP, we actually published a paper where we showed that there's much less amount of bone loss in the reaming in a hip. And the same thing with TCAR as well, using much less polys than we would have, much less cuts than you would have in conventional. But I don't know if there's a difference between the robots.
Between the robots, there is only one paper which was there, which was saying that there may be a thermal necrosis in burring sort of technologies, but it is not proven.
Yes.
It is a theoretical concern, I can say. But since the irrigation is continuously going on, I don't think that is a real major issue. As far as the bone preservation, all the robotic systems have shown that they conserve the bone as like you mentioned, that they conserve the bone, and your bone and soft tissues are definitely preferred. Of course, now this is not a very relevant sort of question. Initially, all the robotic systems were open-based. All the implant companies have acquired this, and then they have made a closed systems out of it. Otherwise, all Blue Belt and Ortho Taxi and all those people were open systems. So initially, when I took Navio in 2015-16, Navio had even PFC, Navio had all the this thing, which they later on stopped it.
I think now QS is slowly branching out. They've taken Tux,
Yeah.
they've taken the Biorad,
Right.
and the Medal, but again, it depends on who is using it.
So have they improved the various parameters, the prompts, your robots? What is your impression, and have you published something around that?
We have. So initially we saw in the clinic, post-up day 1, they seem to be much more comfortable. But then everybody said you can't say that without evidence, which is obvious. So then we actually studied a few patients, one side robotic, one side conventional. And definitely we found in the initial post-op period, they're much more comfortable on the robotic side. Yes, they do balance out after 3 months. I'm not denying that. After 3 months, probably conventional and robotic are the same. But the early post-op period, which I feel is very important, they are much more comfortable, they have less pain, they're able to immobilize faster. Probably because of less soft
even
tissue.
the blood loss also is much less because you're not opening the medullary canal, and your releases
And
also
less
are
amount
very
of time
limited.
subluxated also.
So
We have seen that our number of days of discharge
Sorry?
has
Yeah.
number of days of discharge
Yeah.
has significantly
Gone
come down by 30 to 40% after we started using robos. As
Any
in
of you is planning, shorter duration TCare, like daycare, for example, after you have taken robot, or
we
or there
eventually
are other
wants to do
challenges?
it. That's what we were discussing other day, but we have not yet ventured into it. We have to just see and select the patients carefully for that.
Right. So
What I have seen is it's obviously very short term, limited number data, but the patients usually seem to complain for 3 months, 4 months that the knee feels a little foreign when we do it, when we were doing it conventionally. They were not feeling natural, but the way they seem to say that they don't seem to complain about that after starting robotics.
Right.
Do you see that as well? Like, do they feel more natural that
Yeah,
the knee is
definitely,
feeling?
I think so.
So because
but I think we need to have a multicentric
Yes.
sort of a study which is actually published, and that data with our volumes, what we are doing, we must come out with it. I had discussed this with others also some time back, and we must have, because if it is a multicentric data, then it will be more useful.
I think so, sir. It is much beyond the scope of robotics. There are multiple factors.
Correct.
Yes.
I was about to say that.
So,
It's
multiple
not the
factors.
robo
Much
itself
beyond
which is
the-
helping.
It is not the robotics.
It is one of the factor, yeah.
Yes, it is not the robotics.
Because
What
with
the
the
best
robo,
you place
we're
there.
able to
Others
put
said something
functional.
like that even I had done for first 100 cases where I was not very proficient in time management of with robot. So one side conventional, one side this thing, and definitely there was a difference in patients, pain, patients' overall range of movement, active SLR. Somehow, I cannot pinpoint why it happened, but it happened.
Yeah,
in
so
the
we were
same
asking ourselves that same question. Why would the robot make that? Probably because we're maintaining that internal homeostasis by not, taking the ligaments out and stuff. That's probably the reason.
Because there is this group of surgeons who hate robo, and they seem to say everything about that. All the advantages are just gimmick, marketing gimmick. So we have to come out with solid literature to prove that actually robo is better.
Time to come, I think navigation, if you just see, then some registries are now after 15 years saying that navigated knees. Australian registry, there are papers which say that navigation is in, having better survivorship. So we are at a very early phase, so to comment either ways, I think that is the balanced sort of opinion. One tricky question, what is the drawback of your own robot? What do you think? Now everybody is using, what you would have required more from your robot? Like for example, now nobody is Veli, so I will tell that they could have easily put a, you have to literally lift that saw, and it's slightly hard on your shoulders. Hydraulic sort of mechanism would have relieved that pressure. That is one observation.
So there's definitely, I think, small disadvantages in each one, as well as advantages of each one. For the Mako, definitely the footprint is too big. If they can come up with a method to do the same thing without a CT scan, that will be great. And there definitely there are glitches that can happen, but I think you should be prepared to do a conventional surgery whenever you're doing robotic. That's very, very important. You break down in the middle.
Yeah, that's what, how many times you have
it has
tackled
happened,
and because
maybe in like 7,000 cases of our institute, maybe around 10 times. It has happened where like there's a glitch and then we had to.
Once I was doing this QVs, and that time after doing some half femur or something like that, that just stopped.
Yeah.
So to bail out from there, you need to be very smart, and you have to come out. Otherwise, half burying, it leaves you nowhere. Any experiences
Sir,
from
for
other
Cori,
panelists?
carpal tunnel syndrome, CMC arthritis, very common.
Yeah, actually, I think they have done a significant improvement in the handpiece, because initially when Navio was there, they had a spherical burr which was 5 millimeters, and we had to hold it with a pen grip, and that was very hard on your thinner eminence and things like that. But with the gun type, this thing, and with the cylindrical 6 millimeter burr, it is quite fast. But still, if you have a back-to-back TKRs, then it is hard on your hand.
And Mako has a very high noise generation as well, so we're doing a study on that. It's
And second thing, what is needed further is the real-time patellar tracking.
Right.
That is not there in the robotic systems right now.
I think it is such an easy thing to, for all robots, just put one sensor to tell us the rotation of the TBL base plate also. Why nobody is coming out with it, I don't know. I mean, you can have one sensor there, and that can definitely tell you that important determinant, because if you inadvertently internally rotate tibia, it is going to go for a toss. So all good work will go for a complete waste.
I think we are still in the early phases of robotics. I think in 10 years from now, our robotic machine might look very different from what we are using now. In my case, one thing is that it occupies quite a bit of space, one. And then the error you can make is very, very small. Even for small errors, it just stops. We'll have to go back and do everything. So those things, I think, with time, it might actually accommodate a little bit more of manual error, because already CT is there and planning has been done. So those are things which we expect from the...
Let's discuss two cases quickly now.
So just if I think we need to add few things in the robo. They should have a simulation tool where surgeon can practice the gap balancing before especially going for difficult cases. I'll be really happy if it gives me a live image of how much I am playing with my joint line.
Right.
There are few figures which they can add, especially LDFA, MPTA.
Right.
Okay, because we are moving in that direction where you want a native anatomy to be restored. I don't think any of the robos have these.
The Mako has it now. Mako has LDFA and MPTA, but the joint line is a very good point. Mako does have the LDFA and MPTA now.
So this case, how much any modifications in your CT-based robots or this was wind swept deformity, old trauma on this side with a loss of bone. So how would you plan on a CT-based robot?
So again,
here there will be a lot of bony defects here.
Yeah, and each knee is different. So because the varus, we can manage it straightforward way, but the valgus, the beauty of the robo is now I can actually, like earlier Rashgopal sir was saying, one of the biggest no-no is internal rotating the femur. But with the robotic system, I can actually internally rotate to open up that lateral gap, as long as the trochlear notch is still matching, so within a limit. So that's one way we can handle the valgus.
So this was done with, so this was an intraoperative picture, a lot of bone defects and wear there, and you can see that with robot you can get absolutely good ligament balancing and good preparation also. And post-operative X-rays here. And the last case is of this extra-articular complex deformity, segmental fracture of tibia. So does the CT base will give you more advantages in extra-articular deformities, or whether just mapping? Because I have done it this case with image-less robot and I didn't find, but will CT in your opinion give some added value?
I don't think so, because the deformity is quite far away.
Correct.
In both the robots you're going to know what the axis is. So
it is far away also, and one deformity is nullifying the other. One
correct.
Is in,
it's kind of
so
nullified.
overall your limb axis is pretty straight and you have to just do it. So this was with Willis, and we could get this thing intact. And another extra-articular. So I think robots are very useful in all these complex deformities. When we start cases, we are apprehensive about doing complex cases with the robot, but then as you get experience, then you start using it more proficiently. Yeah, you are saying?
In this case, it may be a little useful, the CT base, because you can actually adjust your implant position beforehand, before you go into the case. So to avoid the screw removal, so you can actually plan to do that. So you can still do it in imageless, but that's only intraoperative.
Yeah, we did a CR knee in this, and we didn't require any removal of screws in this particular case. So I think this was the final alignment. Another case, there are many cases like this. Anyway, I think we have come to the closer of this particular seminar. Thank you very much. Thank you all panelists.
Thank you, sir. Thank you, sir. Thank you for all the panelists. moving forward, our next talk is by Dr. Revat Lakshman, who will be presenting early recovery and satisfaction robotic surgery insights.
Good afternoon, everybody. Thank you for this wonderful opportunity. I am Dr. Revat Lakshman. I'm from Bangalore, and I work in Manipal Hospital, Sarjapur Road. So today, I'm going to talk about early recovery and satisfaction among the patients who are undergoing robotic total knee replacements. In my institution, there is Mako robot, and we only have one robot. So we have only about Mako to talk about. And it was a very thought-provoking conversation just before the symposium, and very interesting facts which came to light, and I agree with most of them. And day to day, as we are operating on the robotics nowadays, we see a lot of changes which was unheard of previously. So as far as the number of total knee is concerned, so India is one of the global leaders, and patient satisfaction rate has ranged from 76 to 93%. Most of the robots came into picture to minimize any human error and to decrease the mistakes which are associated with either prosthetic positioning or the bone cuts. Coming to the literature review, robotics definitely has a lower post-operative pain, lower VAS scores, lower opioid users, better HSS and KSS angle, neutral HK angle, a better implant positioning, lower blood loss, and high post-operative time in the first 10 to 15 cases. That's a global average, and I will like to discuss on this point a little later in my talk, and better soft tissue handling. So we did an audit on the first 121, 125 cases, patients, 70 patients, and the first 121 knees, we did an audit in our institution. And we are still assimilating data, and we are still collecting data, so our study is not yet complete. So most of the patients were of the mean age of about 62.88 years, and average BMI was about 28.9. Females outnumbered the males. 48 patients underwent bilateral total knee replacement, and 25 patients underwent unilateral total knee replacement. Pre-operatively, operative based on operative planning, pre-operative CT accuracy, 0 femurs were changed. On table, 6 tibias and were changed, and 7 patients, the plan was changed from CR to PS. Average deformity correction in degrees was about from 8.3 to 1.4 degrees, and in sagittal plane from 5.89 to 1.31. Now, operative time, the global average is about 15 cases to 21 cases. So we took a little longer because our team consists of 3, along with me as a lead surgeon. There is a resident, there is a registrar. So all the 3 people, it combinedly took 41 cases for all of us to get in tune with the demands of the robotic. And the next 80 cases, we averaged around an hour. So an average operating time for all our cases was about 68.4 degrees. So most of the cases in bilateral, they took spinal epidural anesthesia, and unilateral patients took spinal adductor canal and IPAC. This has recently been changed since last 2 months. We are going for bilateral adductor canal blocks as far as the pain is concerned, and spinal anesthesia. DVT prophylaxis, low molecular weight heparin, and on discharge dabigatran, tablet dabigatran was given. An average length of stay for a bilateral was about 4 days, and for a unilateral was about 3 days. 6 bilaterals required blood transfusion. So these are some of our cases. Outcome scores, we found a significant improvement in the Oxford knee score from 17.6 preoperative to 38.2 post-operative, and forgotten knee score was 77.6. Some of our patients, at least 33 of them, also had a conventional, especially the unilaterals, had a conventional on the opposite side. The forgotten knee score was kind of based on that. And time to independent ambulation was roughly around 13.8 days. It was earlier for the unilateral TKRs. So this is comparison, patient comparison of some of our patients. So I'll just be quick. So what are the current limitations we are facing with the robotic is additional cost of installation, maintenance of the robotic machine, any paucity of a very long-term study, and longer follow-up on functional outcomes as it was discussed in the symposium before, and also its role in revision surgeries. To summarize, definitely there is improvement in the accuracy of the implant positioning, reduced periarticular soft tissue handling compared to the conventional jig based, and there is a potential for further research providing objective data on gap measurements and the knee kinematics, and need for long-term RCTs to be established. And of late we have also come to a conclusion the soft tissue handling, which the amount of releases which we used to do in a conventional TKRs is a thing of past. Even in our conventional nowadays, the amount of releases required is quite less. With that, I would like to end my talk. Thank you.
So for the last talk of the scientific session, I would like to invite Dr. Nikhil Likhate sir on the podium. Achieving both anterior and posterior offsets, anterior and posterior offset accurately in robotic TKR.
Very good evening, and I'm I think I'm the last person to play on this speech. So I'm going to talk about the achieving both anterior and posterior offset accurately in robotic TKR. So you know the survival of TKR is almost 97% over 15 years, but you have a 20% of patients experience significant discomfort and pain around their knee that precludes their normal day-to-day life, daily livings. Lack of confidence in stair climbing up and going down, getting up from the sitting position, kneeling, and in twisting activities, they do get pain. And 23% contributes to anterior knee pain. So if you wanted to have an optimal patient outcome, you need to have a good alignment and well-balanced ligaments. You need to have a proper implant placement, replicating native anatomy as much as possible, and accurate sizing to prevent overhang, underhang, and joint kinematics. So in a TK, you need to address two alignment. Basically, one is coronal alignment, which is based on your geometry of distal femur and proximal tibia. And you need to address the sagittal alignment, which is influenced by the anterior offset, which is the bone presenting anterior to the anterior cortical line of the distal femur, and the posterior offset, the bone which is present behind the posterior cortical line of the distal femur. So why posterior offset is so important? So it affects flexion and extension gap balancing. It is crucial in maintaining native joint line, crucial in determining the femoral range of motion. It always allows great degree of flexion and avoids tibiofemoral impingement. So if you see the graphical presentation of posterior offset compared to the range of motion, you can see that if you can't able to maintain the posterior offset within the range, probably you cannot able to even achieve the preoperative range of motion after surgery. Now, how we achieve this in a conventional technique? So you have a reference system. Either you can use the anterior reference system or your posterior reference system to balance these offsets. So, but both the system have their own problems. So in anterior system, your anterior bone cut is remain constant, but your posterior cut is not constant if you are in between sizes, and probably you'll end up with either you cut extra bone or you cut less bone to have a flexion instability. And if you're talking about the posterior reference system, probably you could able to manage the posterior offset well, but there are some issues on the anterior side. Either you can overstuff or you can notch the femur. So why anterior offset is important? So we call it like a third space. So we have a flexion space, we have an extension space. Similarly, we have a third space on the anterior side, which is responsible for your patellofemoral kinematics, which involves extensor hood, like your quadricep mechanism, your quadricep muscle, your patellar tendon, and your retinaculum, and your patellofemoral joint and the retinaculum. So it influences the sagittal balance by changing effective quadriceps or extensor momentum. So 23% all TKs, you know, that contribute to the anterior knee pain. Patellar complications are common in total knee replacement. Despite of improving the implant design, surgical technique, still 10% of all our patients show the complications in patellofemoral joint, and overstuffing is one of the common reason for anabatic TK in literature. So if you are following the posterior reference system, probably you have major two issues. You cannot able to maintain the patellar, you can land up with a patellofemoral overstuffing or notching if you have to oversize or undersize the femoral component if you are in between. So understuffing affects the third space. What it causes the laxity in the quadriceps mechanism. It loses the quadriceps momentum, and probably patient has to work hard, or muscle has to work very hard to lift the leg or extend the leg, and that's why patient land up with weakness while getting up the sitting position or getting up from the chair position. If you overstuff this space, probably increase the patellofemoral pressure and causes the anterior knee pain. So every millimeter of posterior upside loss, you have a flexion reduced by the 6%, 6 degree. And every millimeter increase in the posterior offset, its passive range of motion decreased by the 2 degree. So now there is no objective way you can measure the anterior offset in a conventional way, because whatever the measurements we are using for the anterior offset, anterior femoral cortical line, but the patella articulates with the trochlea, and the distance between this trochlea, base of the trochlea and anterior femoral cortex is really variable and very difficult to measure on table. So that is why we use a Cori handheld robotic system for this. So it is an imageless surface mapping system because it maps the cartilage as well. So we utilize it to maintain the offsets. So our aim is to achieve normal kinematic, not only in the coronal, but also in the sagittal plane. And our objective is to shape match the prosthetic trochlear groove with the native trochlear groove. And simultaneously managing both the offset by changing the femoral components to achieve near normal geometry or anatomy. So we use the standard sizes or we are using the narrow sizes. So this is how the Cori works. Initially, you have to register data, what we call as a painting of the bone. So once we start painting on the bone, the computer starts giving us the model, which is a 3D model of your bone. So it looks like this. But these models are not validated. So we need to validate this model, okay? So because what happens in Cori, so it try to match the closest model of the knee, which have been its data. So it is not a true, or it's not a real time. So we need to validate for our things. So how we validate? So we have some special points you can collect on while doing a surgery. These are the ping points, and then we use them to morph the bone again. So this is sometimes, so we are using the morphing of the medial femoral condyle. So then normally what our philosophy is, we resurface the unaffected compartment. So if I'm talking about the varus knee, probably my unaffected compartment is my lateral compartment, so I'm going to morph my lateral compartment. And if you're talking about the valgus knee, it will be a medial compartment. So I'm morphing a distal lateral cartilage, then MAP, which is called as most anteriormost point of the trochlea, then on the medial side. Then we're mapping the posterior condyle, as well as we are mapping the trochlear groove in our right side line. So this is the groove which we are mapping with this blue pink points, and these are visible all the time when we are adjusting our processes. And that's how we map our bone with a special point. So this is the anterior cortex we are matching. So normally base of the groove and anterior cortex are not at all matching, and so that is why this is necessary to map these special points. So as soon as you map, you will get this kind of picture the computer present you. This is a 3D model where you can work with that. So you know that your prosthetic implant is reading these all marks, and you have to match your implant with whatever you have mapped. So this is a 3D picture. You can move around. So you can play around with these windows. So you can see whether your bone is exposed, whether you are overhanging, whether you're not overhanging, whether it is exactly matching with what you have morphed basically. So this is a 3D picture. So the best picture you can see is a two-dimensional picture. It's like a CT cut. So you have an axial cut, you have sagittal plane, you have a coronal plane, and you start mapping your prosthesis. So the computer is already giving you the size. So it's showing that something like size is 3. Okay. So, but if you see the sagittal alignment, you will find out that the 3 is much smaller than what exactly we want, because we want to manage the anterior offset as well as posterior offset. If I'm managing posterior, probably I'm not able to do my manage anterior offset, and obviously, whether computer is giving me size 3, I have to upsize. So what we'll do, we'll upsize and we'll see again mapping. And secondly, you have to medialize and lateralize. You need not to lateralize all the time your prosthesis to track your patella on the femur. but you can see that your prosthetic groove and your native trochlear is matching or not, and that is easy when you do it on Cori. So this is how we are managing. So you can move around up and down, and you can see all the time you're seeing your all pink mark points, and if your prosthetic groove is matching with that, probably you're maintaining the prosthetic groove with the native groove. So once you have done this, I think you have to stress your knee for the ligament balancing, and then you take a stress view, see what is happening with that. Always you know that this is a contracted side, this is a loose side. So all the medial collateral ligament is tight. So next you have to balance. So keeping all the implant what you have placed before, now you can just do some tweaks in this grid, and you can balance your joint. So you can follow your philosophy. You want a mechanical adjustment, you want a kinematic alignment or restrictive kinematic. Any philosophy, whatever you believe, you can apply it, and you can balance the joint. And with your balance, you can really able to replicate the geometry, preoperative geometry with your prosthetic replacement. So now the question is whether we are really accurate with this or not. But you can see this, once you validate this model, now you can see this. If I'm seeing my prosthetic, this is the prosthetic silhouette actually. If you can see, these are my pink mark at the base of the trochlea, and if it is bit hanging, and when I take a cut with that, you can able to see there's a 1 or 2 millimeter of overhanging. So once you morph and once you validate your model, probably you are pretty accurate while taking your correct cuts. So similar, another example, again same thing, you're shape matching your prosthesis with your native geometry, you're getting your balance, rectify your balance, and get your surgery done, and you can replicate the native anatomy back to the place. So there are different examples. So my take-home message is, advanced robotic technology definitely help in balancing total knee arthroplasty, not only in a coronal plane, but also in a sagittal plane to give a functioning and satisfactory working arthroplasty. One can definitely reciprocate the native anatomy objectively with the help of robotics, but still more detailed studies are required to establish statistically significant results or efficacy of these tools achieving the full functioning results in these patients. Thank you.
Thank you, sir. With this talk, we come to end of our session, and these 2 days were wonderful academic sessions. Now I would like to invite Dr. Jayesh Patil sir for vote of thanks.
A very good evening, everyone. On behalf of the organizing committee of Ortho Trends 2025, it is my privilege to propose a vote of thanks at the conclusion of this wonderful conference. First and foremost, I would like to extend my heartfelt gratitude to our patrons, Dr. Vikram Shah sir, Dr. Pachore sir, and Dr. Ashok Rajgopal sir, for guiding us throughout this conference and organizing this conference. I would like to thank our international faculties, Dr. Harbinder Chadda and Dr. Kyle McGivern, and all the esteemed national faculties for sharing their valuable time, expertise, and insights with us over the last 2 days. Your contributions have enriched this event. A special thanks to our organizing team, whose hard work, planning, and dedication behind the scenes ensured smooth conduct of the conference from start to finish. I would like to mention a special thanks to my colleague, Dr. Pranay, who helped with the scientific committee agenda and coordinated with all the faculties for the smooth running of this conference. We also express a deep appreciation to all the delegates who joined and actively engaged in the discussions and made this conference meaningful and successful. A word of thanks for our sponsors, partners, and supporting staff, without whom the event would not have been possible. Finally, thank you for your presence and enthusiasm and continued support. We will look forward to meet you next year at Ortho Trends 2026. And thank you for coming. I would like to ask our international faculties, Dr. Kyle McGivern, to give his reviews about the conference and his experience in India. This is his first visit to India, and I'm sure there will be more visits in coming future. Dr. Kyle.
This is on, yeah. Thanks for, oh, it's cleared out now. Haven't turned around, but thank you all for inviting me. As far as the trip to India, it's been nothing but amazing. It's been the most hospitable country that I've ever been to, and that includes my own. So thank you all. The scientific agenda was excellent. Learned a lot from being here, so appreciate it, and hope to come back in the future. Thank you all.
Thank you so much. Thank you, everyone.
From SAT to be on the stage for photo session, and all the Shalby team members who are here, would like them to come on the stage for a photo session.
So there is one lucky draw today as well, and I've just selected one paper, and the lucky draw for this goes to Dr. Vikas Savla from Jabalpur. I think, yeah, but the Shalby team can connect on his behalf, don't worry.
And I will certainly inform the winners, Dr. Sukla also, to Vikas also. Thank you so much.
Thank you so much.